Hello, good morning, my dear friends, my dear students, and welcome to this final dash ENT Medico. So, hope you are all doing great, and of course, little setbacks were there, and always the point is all is well, and all the happenings are for some goodness. So, we will take it in a positive way. And in this session, I am going to cover some around 100 questions in ENT, the most important areas of ENT, with which I believe and I trust me, with this session, you can have some very good revision or fast revision of the ENT areas. Even if you would have forgotten some topics in ENT, or you have revised or studied the ENT topics very long time back. And anyway, don't worry, with this session we can revise all those topics and we can easily crack as much as possible the questions in ENT. So let us go for the questions, and happy learning. Thank you. See this with the starting of the anatomy of the ear. Let us move with ear, nose, and throat questions. And this MCQs, and I have prepared in a way. I have clubbed many MCQs into your single MCQs, all the points into your single MCQ, so that we can cover almost all the topics that have been asked in the previous years. So to start with, always we need some good orientation of the ear anatomy. So the gross orientation of the ear anatomy we need to know. So this, with this first picture, we have this bony external meatus that is called the tympanic bone or tympanic ring. Please remember this point. The bony part of the external meatus is called tympanic ring or tympanic bone. That terminology is very important. You should not get confused if this terminology has been asked in the MCQs. And we have this bigger pars tensa and a very smaller pars flaccida. So we have the tensa and flaccida of the tympanic membrane, and the gross relation of this ear is anteriorly it has this TM joint, temporomandibular joint, and posteriorly we have this mastoid antrum. This is the right ear for your orientation, and this is anterior, this is posterior. So antrum behind in the posterior part, we have this sigmoid sinus much behind, and it turns into a jugular bulb in the floor of the middle ear, and this is the internal jugular vein. And more anteriorly in the floor, we have this internal carotid artery in the antero-inferior part of the middle ear. So this is the gross orientation, and of course superiorly the bone is called the tegmen tympani, which separates this middle ear from the intracranium. So these are all the gross orientation, and we will have some orientation into the middle ear, how this middle ear structures are aligned and oriented, and of course the inner ear. And assume you are seeing the patient as if the patient is standing like this, the aerial view. The right ear, assume this is the right ear which is been shown here. Again, this is lateral, this is more medial, this is anterior, this is posterior. Please correlate with the man standing like this. Okay. And more importantly, the inner ear, understand the cochlea is anteriorly placed, and the semicircular canals and vestibular apparatus are posteriorly placed. This is the little important anatomical orientation you should remember. So the middle ear is related to the cochlea of the inner ear, and the mastoid is related to the semicircular canals of the inner ear. Okay, and the next important structure you have to orient in the middle ear is facial nerve. That's very important. The facial nerve is coming from the internal acoustic meatus like this. It passes through the inner ear, that is the labyrinthine segment, and this is the first genu of the facial nerve. It takes a sharp curvature in the anterior end of the middle ear. That's very important. See, that is in the cochlear end of the middle ear, anterior end of the middle ear. It travels horizontally backwards, posteriorly, and it takes a second genu in the posterior end of the middle ear, and it travels vertically downwards in the posterior wall of the middle ear. So this is the gross traveling of the facial nerve. So the labyrinthine segment, again I will draw you, mention only the facial nerve in this picture so that no confusion should be there regarding the facial nerve travel inside the middle ear. So the labyrinthine segment passes through the inner ear, and it takes a first genu, the anterior end of the middle ear, and it takes a horizontal segment that travels from the anterior to the posterior end, and it takes a second genu at the posterior end, and it travels vertically downwards in the posterior wall of the middle ear. Okay. At the first genu, it gives a very important branch that is called greater superficial petrosal nerve. That is an important branch from the first genu of the facial nerve. Okay. And the same orientation, the man is standing in the same way, and just need to know how the ossicles are been aligned inside the middle ear. It's very important. See how this malleus incus are been aligned. It's not exactly malleus is lateral, incus is medial, and stapes is further medial. It is not so. Please remember the malleus is the lateral most, and this is the lateral process of the malleus where the tympanic membrane is closely adherent. And see the incus. Incus is posterior and medial. It is posterior and medial to the malleus. That's very important. And this is the short process of the incus, which is pointing at the posterior wall of the middle ear. Again, please orient. This is the anterior. This is the posterior. Again, the same orientation. The man is standing in the same way, and you are seeing the picture in the same way. So this incus, short process of the incus, is placed in the posterior wall. And do you know what is the name of the short process of the incus placed at the posterior wall of the middle ear? That is called fossa incudis. We will see this later, how it has been important. Fossa incudis. It is the point where the short process of the incus is placed in the posterior wall. Okay, that's what. And we have this smaller stapes further medial. And again, orient yourself, cochlea anteriorly, the vestibular apparatus, utricle and saccule in the middle part, and the semicircular canals posteriorly of the inner ear. And coming to the internal acoustic meatus, we have this internal acoustic meatus where the two nerves are going through, and the very important nerve is the facial nerve. The facial nerve, we know it runs in the anterior part from where it takes the first genu and goes posteriorly. So the facial nerve is more superior to this inner ear, cochlea and the vestibular apparatus. We can see from this picture. So the facial nerve is in the anterior and the superior part of the internal acoustic meatus, and other nerves in the internal acoustic meatus are one is cochlear nerve, and other things are vestibular nerves, superior and posterior, superior and inferior vestibular nerves. So we need to know this alignment, and we will see this in the again in the internal acoustic meatus section. So this is how this structures of the ear, the gross relationship with the neighboring structures, and the middle ear facial nerve orientation is there. So with this refreshing orientation, we will move on to the questions. Again, this is the inner ear in the petrous part of the temporal bone. We are seeing from the aerial view. Again, this is the superior surface of the petrous part of the temporal bone, and this is the posterior surface. We have this sigmoid sinus, and we have this jugular foramen here in the floor of the middle ear, of course. And see again, the internal acoustic meatus is here, through which we have the facial nerve and the vestibulocochlear nerve anteriorly, vestibular nerves posteriorly are passing through the internal acoustic meatus. Yes. Coming to the question. An elderly man came to the ENT OPD with complaints of right ear pain for 3 weeks. Elderly man with ear pain for 3 weeks. On examination, ear was found normal. There is no abnormality in the ear. Which of the structures need not be examined to find the cause for ear pain? So very typical clinical question. Whenever the patient is having ear pain, and if the ear is found normal, we need to look for other pathologies regarding this referred otalgia. Referred otalgia is a very important clinical question you'll be getting in MCQs. So what are all the things we need not examine to find the cause for ear pain? Pharynx, tongue, temporomandibular joint, and vestibule of the nose. Do you know the answer? You can comment in the chat box, and if not, we can go with the answer. Any idea about this answer? Which is the answer for this question? Which area we need not examine? If there is a chance we are thinking about referred otalgia. The answer for this question is D, vestibule of the nose. So we need to know what are all the nerve supply, sensory supply for the ear, and we need to know what are all these nerves supplying in other areas in the head and neck region, so that we can know what are all the areas which we need to examine if there is a species of referred otalgia. So what are all the nerve supply of the ear? So before that, what is the nerve supply of the vestibule of the nose? This is V2. This is maxillary division of trigeminal nerve. That is the infraorbital branch of maxillary division of trigeminal nerve is supplying the vestibule of the nose. And V2 has no nerve supply for the ear. Only the V3 has a nerve supply, that is auriculotemporal nerve branch of V3. So vestibule of the nose is not giving ear pain. Any disease in the vestibule of the nose like vestibulitis will not cause referred otalgia. All other things, any disease in the pharynx, tongue, temporomandibular joint, we will see that in the further slides. So coming to the ear innervation, always tell this mnemonic in an easier way to understand. Vague friends group. There are many nerve supply for the ear, and collectively, if we remember in this way, there are many nerve supplies from all directions. So from vague directions, they are supplying the ear. So they are like friends group. So it is like vague friends group. So V is for the vagus nerve, A is for the auriculotemporal nerve anteriorly again, auriculotemporal nerve anterior, A for A anteriorly, and G is for the greater auricular nerve, F is for the facial nerve, and G is for glossopharyngeal nerve. So this are the nerve supplies, that is prime nerve supply of the ear. So we will have a little break and we will start with the lecture later. Thank you. Okay, sorry for the break. We'll start again. So vague friends group is the mnemonic we need to remember easily. So the vagus nerve, that is auricular branch of the vagus nerve, that is called Arnold's nerve. Simply, if you take the picture like this, the middle green area, that is a conchal area, and of course the concha is related to the posterior part of the external meatus. See, the concha will be like this, and that is related to posterior part, posterior wall of the external meatus. So the green area in lateral surface and the medial surface, that is the bowl of spirit, what I used to say. So it is supplied by the vagus nerve. On stimulating this vagus nerve, it also increases the appetite. So sometimes in the olden days, the aldermans, clergymans, they pour little alcohol into the ear canal. That chill alcohol will trigger this vagus nerve and that increases their appetite, and they will get more food during begging or getting food from the houses. So this vagus nerve is the middle part of the concha and the posterior wall of the external meatus supplied by the vagus nerve, and the anteriorly it is supplied by this auriculotemporal nerve, which is a branch of V3, and greater auricular nerve, the greater part of the auricle, is applied by the greater auricular nerve from the C to C3. And very importantly, these are the three prime nerves, and very smaller area superiorly, the yellow region is for by the lesser occipital nerve, not much significant. C2, the lesser occipital nerve, a lesser area by the lesser occipital nerve, not much significant. And very importantly, the facial nerve. Facial nerve has its sensory supply to the ear, very important, and it supplies through the vagus nerve. So the areas that is covered by the vagus nerve is the area supplied by the facial nerve. That's very important. The same conchal area, retroauricular area, see this behind the green color, retroauricular area, the same vagus area, and the posterior wall and floor of the external meatus. is supplied by the facial nerve. The MCQ again is the only sensory supply. The general sensation of the facial nerve in the entire head and neck region is only in the ear. There is no other general sensory supply for the facial nerve. Very important point. So that is the facial nerve fibers through the vagus and the middle ear. Leave the external ear now. The middle ear supplied by the glossopharyngeal nerve, ninth nerve. So these are all the prime nerves that supply the ear. Okay. Yes. Anything? Okay. Let me. Okay. Okay. So far good. Oh yes. Let's move on. And in the entire head and neck region, I tell you little points. See, we know the sensory supply for the face is by the trigeminal nerve, V1 ophthalmic division and V2 and V3 maxillary and mandibular divisions of the trigeminal nerve. The entire face, there are two important points which has some exceptions. That's quite important. See, one thing they will ask you, what is the nerve supply of tip of the nose and what is the nerve supply of the angle of mandible? These are the two important areas they will be asking you. So this tip of the nose is, logically speaking, we may think it is in the middle part of the nose and we will be marking it as a V2 maxillary division of trigeminal nerve. It is not so. The tip of the nose and the dorsum of the nose, the dorsum and the tip of the nose is supplied by the external branch of anterior ethmoidal nerve of V1. That's very important. So ophthalmic division, it has a branch called nasociliary. It has a branch called anterior ethmoidal nerve. We'll be seeing in the nose section. But remember this, the external branch of anterior ethmoidal nerve, which is a branch of ophthalmic division of trigeminal V1. So the dorsum and the tip of the nose is supplied by V1. That's very important. Again, coming to the angle of mandible, where we may again think it may be by the V3 mandibular division. It is not so. Again, the greater auricular nerve, see the violet area, the greater auricular nerve which is exiting from the posterior border of the sternocleidomastoid, it supplies the greater part of the auricle, what we have seen now, and also the angle of the mandible. That's very, very important, the angle of the mandible. So this greater auricular nerve has a MCQ point. This is the most common nerve injured in parotidectomy. Yes, the greater auricular nerve is the most common nerve injured in the parotidectomy. So if we get this greater auricular nerve injured, the patient will be having loss of sensation over the pinna and the angle of mandible. So that is very important in the face. This angle of mandible is supplied by, not by V3, it is by the greater auricular nerve. Yes, yes, yes. The majority of the external ear senses supplied by greater auricular nerve. Yes, very true. The greater part of the auricle is supplied by greater auricular nerve. Easy to remember. So this is a point to note. Okay. So what are all these nerves supplying in other part of the head and neck region? Yes, vagus nerve. This vagus nerve supplies the larynx and hypopharynx. So any problem, any lesions in the larynx and hypopharynx, which is very important in the elderly people, malignancy. So malignancy in larynx and hypopharynx will many times present as a referred otalgia, a non-specified ear pain in the elderly people. So in any elderly people coming with ear pain for a prolonged period, we should examine larynx and hypopharynx and other areas of the head and neck region to rule out other pathologies. That's very important. Yes. And regarding the vagus, other important points are this vagus stimulation. Whenever we probe the ear canal, we may get cough reflex, and even the patient may go for syncopal attacks due to bradycardia. So this is due to vagal stimulation. That is one MCQ. So ear canal stimulation will lead on to cough reflex and bradycardia. That is due to vagal stimulation. That is one point. And coming to the auriculotemporal nerve, this is the nerve supply from the V3. So what are all the V3 sensory supply important areas where we have to look for. So V3 supplies the sensory supply to the anterior tongue. And which nerve is a sensory supply for the anterior tongue? Any idea? So this is lingual nerve. So lingual nerve is a sensory supply for the anterior tongue, that is a branch of V3, and of course the dental caries, inferior alveolar nerves. Inferior alveolar nerves, that's very important, dental caries. So the lower dental caries very importantly cause rhabdotalgia. V3, that is a mandibular division. The upper dental is by the V2, that will not cause any rhabdotalgia, but the lower dental, lower alveolar nerves from the V3 cause rhabdotalgia. And very important, TM joint pain, TM joint arthralgia, Coston syndrome, which causes ear pain, vertigo and tinnitus. So clicking sound during eating, Coston syndrome. Temporomandibular joint, again supplied by the auriculotemporal nerve of V3. And glossopharyngeal nerve, the ninth nerve is a sensory supply for oropharynx. That's very important. Base of tongue, tonsils. So where if you get any pathologies, again that will cause rhabdotalgia. That's very important. Yes. The Hitzelberger sign. What is Hitzelberger sign? That's very important sign in ENT. Very frequently asked question in ENT. Hitzelberger sign. Any idea? So Hitzelberger sign is seen in vestibular schwannoma. The vestibular schwannoma, when it compresses the facial nerve. The first nerve, the vestibular schwannoma of the inner eighth nerve, the compression is trigeminal nerve. And the second nerve it compresses is the facial nerve. And the earliest sign of facial nerve compression is Hitzelberger sign. What is Hitzelberger sign? Again, this is paresthesia of conchal area and the posterior wall of the external meatus. So in this area, if the patient experiences numbness, that is called Hitzelberger sign. So this Hitzelberger sign will be typically seen in vestibular schwannoma, compressing the facial nerve, the earliest sign of facial nerve compression. That is very important. Yes, very good. Hitzelberger sign in acoustic neuroma. Super. And last is the facial nerve we have seen. Facial nerve, do we have any other sensor supply for the facial nerve in the head and neck region? No, that's what I told you. The facial nerve do not have any other sensory supply in the head and neck region. So facial nerve's only sensory supply is in the ear canal, posterior canal and the conchal area and the retroauricular area. And of course, another MCQ regarding this facial nerve supply in the ear is, that's why we have in Ramsay-Hunt syndrome, we have the painful vesicles. If the Ramsay-Hunt syndrome is nothing but the eighth nerve gets herpes zoster reactivation in the geniculate ganglion. So when the seventh nerve, very sorry, this geniculate ganglion of the facial nerve, the herpes zoster reactivation. So that causes facial nerve palsy with vesicles. And of course, the sensory supply of the facial nerve is in the conchal, retroauricular and external meatus. The patient will be getting the painful vesicles in these regions. So these are all about this nerve supply. So many MCQs surrounding around this nerve supply of this pinna. Okay. Coming to a little few landmarks of the pinna. Anything else? Very good. And Pratyusha want to say, very good. The tongue, the general sensation for the tongue is lingual nerve, and the taste the sensation is by the chorda tympani. Don't get confused. So lingual is for the general sensation, and for the taste it is chorda tympani. It is not other way around. So chorda tympani is for the special sensory, and for general sensory it is the lingual nerve of the trigeminal nerve. Lingual nerve is a branch of V3, mandibular division of trigeminal nerve. That's very important. Yes. Good. Yes. Regarding anything else you want to know from this external ear nerve supply, almost all the things I have covered, I think so. Good, good. Yes, super. Good. So, coming to the pinna, we have this, what are the MCQ points regarding the pinna? This pinna is made up of single yellow elastic cartilage. It is not a hyaline cartilage, first point to note. And we have this is the tragus, we know very well. and this is the root of helix, we know very well, and the point in between these two things, this is called incisura terminalis. Incisura terminalis is the point where the cartilage is deficit, and hence if you want to make an incisions without injuring the cartilage, we can make this incision in this area of incisura terminalis, and that incision is called endoral approach, a Lempert's endoral approach. If you make an incision in this area like this, they will make incision like this to expose the middle ear and only the antrum, a limited exposure of the antrum. So this is called endoral approach that is being made in the incisura terminalis. So this is about the important landmarks of the pinna, and of course this is the concha. And what is this area? This is called Simba concha, this area. So this is concha, adjacent to your external meatus is the concha, please remember, and little superiorly is called Simba concha. And what is the importance of Simba concha? Any tenderness in the Simba concha, what does it implies? Any idea? This is mastoiditis, because Simba concha is a landmark, external landmark for the mastoid antrum. So if you press the Simba concha and if the patient winces with pain, that means the patient is suffering from acute mastoiditis. That is very, very important. Okay, good. Few points regarding the external meatus. What are all the points to note in the external meatus? First thing, they are very commonly asked the division of the external meatus. So easy to remember again. See, this external meatus is divided. It's a canal-like structure. It's divided into lateral 1/3 and medial 2/3. And lateral 1/3 is made up of cartilaginous and medial 2/3 is made up of bony, which is quite easy to remember because obviously the pinna cartilage is making the lateral part of the external meatus, obviously. So the lateral part should be the cartilaginous and more medial inner part should be your bony. Okay, and which is smaller, which is bigger? How to remember? 1/3, 2/3. Very simply, the soft tissues are very minimal for the ear, and the majority of the ear structures are within the bony cavity. Majority are within the bony cavity. So the majority of the ear canal is also the bony. Only the smaller area is cartilaginous. Remember in this way. So the majority of the bony ear structures are within the bony cavity of the petrous part of the temporal bone. So hence, lateral is only smaller, 1/3, and medial is bigger, 2/3. So the lateral 1/3 is cartilaginous and medial 2/3 is bony. Never forget. And the same applies to the eustachian tube, that is one another canalicular structures. They will be asking this MCQ. The same division, lateral 1/3 and medial 2/3, but the components differ. Very simple. Components differ. So see this tabular column. The lateral 1/3, this is for the external meatus, this tabular column. Lateral 1/3 is cartilaginous and medial 2/3 is bony, and the same division in the eustachian tube, it is opposite. Lateral 1/3 is bony and the medial 2/3 is cartilaginous. There is no big confusion in remembering these points. So that is a point here. And the next thing is regarding the glands, this lateral 1/3, which is having the hair follicles, sebaceous glands, ceruminous glands, which secretes the cerumen for the wax production, are all present in only the lateral 1/3, and hence the MCQ is furunculitis will be seen only in the lateral 1/3 of the cartilaginous part of the external meatus. This medial bony part do not have any glands, and hence the furunculitis will be seen only in this cartilaginous part of the external meatus. It will not be seen in the bony part. And there are certain dehiscences, fissures of Santorini and foramen of Huskey in the cartilaginous and the bony part, from where the infections will come to and fro from the external meatus. Okay. And the next point to remember in the eustachian tube, little extra points regarding the eustachian tube, the MCQs are, at what age the eustachian tube becomes child from the childhood configuration into adulthood configuration at the age of 7 years. This is one point to note. At the age of 7 years, 7 to 10 years, this childhood configuration becomes adulthood configuration. Means the chance of infection into the middle ear gets decreased, because in childhood it is shorter, straighter and stouter, and hence the any infections from the nose and the nasopharynx can easily ascend into the middle ear. Okay, and another thing, what is the direction of eustachian tube from the ear to the nasopharynx? So this is a mnemonic, of course. Many of you would be very well knowing about this mnemonic. It is downwards, anteriorly and medially from the middle ear to the nasopharynx. It is downwards, travels downwards and anteriorly from posterior into the nasopharynx, anteriorly, and from lateral to the medially. So it is downwards, anteriorly and medial. DAM is a mnemonic for the this direction of the eustachian tube from the middle ear to the nasopharynx. Okay, and one more point, the childhood eustachian tube is little patulous. Why it is patulous? Because it has little elastin content and little Ostman's pad of fat. So hence it becomes little patulous. Any infection can easily ascend into the middle ear, and hence they are having more chance of getting frequent otitis medias children. That's what. Oh yes, yes, we will see this embryology separately, definitely. All are boundaries of the prosodic space. Now coming into the tympanic membrane and into the middle ear area. So what are all the important areas to note, important MCQs to note, and very important question is prosodic space. All are boundaries of prosodic space except pars flaccida, head of malleus, neck of malleus, lateral malleolar ligament. Can anybody answer about this question? What are the boundaries of prosodic space except except yes. Okay, so this is about, the answer is pars flaccida, head of malleus, neck of malleus, lateral malleolar ligament, and answer is head of malleus. We need to know how this, the epitympanum is arranged. That's very important. And where is the prosodic space? That's quite important to note. Okay, so before entering into the prosodic space proper, little points about the tympanic membrane. Okay, little points about the tympanic membrane. Yes, we have this right ear tympanic membrane and left ear drum. That's a thing how it is purely white or purely gray in color, and it is very glistening tympanic membrane, a bright glistening tympanic membrane. And the very important MCQ point is, which is a prominent point in the entire tympanic membrane, lateral process of the malleus. Which is the lateral process of the malleus? See this picture. We have this pars tensa and very smaller area pars flaccida, and this is the handle of malleus. This is called the handle of malleus, and its middle part is called umbo. We know that. And the most prominent structure, see, we can see this is called lateral process of malleus, which is a prominent structure of the entire tympanic membrane. Please remember, this is a very important MCQs. It is not handle, it is not umbo, and of course it is not cone of light. Cone of light, it falls in the antero-inferior quadrant of the tympanic membrane, because that is more perpendicular to your ray of light. Okay. And another point is this pars tensa is surrounded by this fibrous ring, a whitish ring, that is called annulus. And this annulus is deficit in the pars flaccida, and the pars flaccida is covered by the bare bone, that is called notch of Rivinus. And this notch of Rivinus is formed by a bone is called scutum. Please remember this. The lateral bony covering of the epitympanum is called scutum. That is very important. Very simply, the pars tensa is against your mesotympanum, and the pars flaccida and the scutum is against the lateral wall of the epitympanum. That's quite important. Okay, so these are all the points to note in the tympanic membrane. Okay, coming to the prosodic space proper, see this. The prosox space is a very smaller space here behind your pars flaccida. We know pars flaccida itself is a smaller area, very smaller area. Pars tensa is bigger, pars flaccida is very smaller area, and the space behind the pars flaccida is the prosox space. So obviously the prosox space is bounded laterally by the pars flaccida itself and medially by the only the neck of the malleus. The bigger head of the malleus is behind your scutum, in the bigger area of the epitympanum, please remember. So the head of the malleus is behind your scutum into the epitympanum, and behind the pars flaccida the smaller area prosox space and boundary posterior is by the neck of the malleus, and superiorly it is by the lateral malleolar ligament. So this is the area called prosox space. What is the importance of prosox space? This is the route of entry of cholesteatoma into the middle ear. The first area of entry of cholesteatoma into the middle ear. How we know this? So pars flaccida area for the retraction pockets. So epitympanum is more crowded, so negative pressure is common in epitympanum, and hence the pars flaccida. And also the point is pars flaccida is not having the fibrous layer, middle fibrous layer. It is deficit of middle fibrous layer. It is more thinner. Hence the retraction pocket easily occurs. So it easily occurs in the pars flaccida. So whenever there is a negative pressure in the epitympanum, this pars flaccida gets sucked inside the middle ear, retraction pocket. And once the retraction pocket happens, this retraction pocket enlarges as a balloon inside the prosox space. So the retraction pocket will be lined by this outer stratified squamous epithelium. We know that. See, the tympanic membrane is outer layer is the stratified keratinized stratified squamous epithelium, and inner layer of the tympanic membrane is by the columnar, ciliated columnar epithelium, and middle is the fibrous layer. So outer, middle and inner. And of course in pars flaccida this middle fibrous layer is very deficit, very minimal. Okay, so outer layer is the epithelial layer. Once the retraction pocket happens, all the keratin debris gets collected inside this balloon, retraction balloon, and that is nothing but cholesteatoma, and that causes enzymatic decalcification that secretes the osteolytic enzymes and causes enzymatic bony erosion once it is eroding, extending into the middle ear and the intracranium. So this is how the cholesteatoma extends from the pars flaccida prosox space, the first area of cholesteatoma entry, and into the middle ear. That's how this prosox space is very important. It is the first area of formation of cholesteatoma, route of entry into the middle ear. Okay, and these are all the real pictures how the retraction pocket appears like and how the keratin flakes, the cholesteatoma flakes appears like. Please remember, because many times you will be getting the picture questions. See, the pars tensa is intact, and you can very clearly see the retraction pocket in the pars flaccida. That is very important. And once the keratin flakes gets collected inside this retraction pocket, this is how this purely white keratin debris will appear like. Even the cholesteatoma will appear like the purely white material. That's very important. Purely white cholesteatoma is nothing but keratin flakes. That's all. So it gets occupied in the retraction pocket and enlarges and destroys the middle ear structures. So this is about the prosox space. And coming to the middle ear walls. Now the next area is middle ear walls. Very important. This question. Let me, yes. Okay. A CSOM patient was planned for surgery after doing cortical mastodectomy. The surgeon opened the area marked in the picture. What is the area? This is the area marked in the picture. Okay, the whole area. Yes. The following are true regarding the area except. The following are true, the rounded area, except. Posterior tympanotomy. Medially it is bounded by chorda tympani, also done in cochlear implant surgery. Round window can be approached through it. So what are all the points which is except? Basically, after doing a cortical mastectomy, one natural opening will be present in the superior part, which is that. So this is the area. See this. The natural opening will be present. That is called Auditius, communicating the epitympanum to the mastoid antrum. That is Auditius. If we iatrogenically create another opening in the posterior wall, that is the facial recess area. That is very important area which has been created in certain surgeries to approach the posterior part of the mesotympanum. So this is a facial recess area. So that is a very important area. The natural opening is nothing but the Auditius, through which we can see an ossicle. Incus, I told you, malleus is anterior, incus is little posterior. So through the Auditius, see, mastoid antrum is posterior to the middle ear. So through the Auditius, we are seeing the ossicle. Which ossicle? Incus. Incus is a posteriorly placed ossicle which is being seen through the Auditius. That's very important. Okay. And iatrogenically created area is facial recess area. So posterior tympanotomy, yes, we are making a tympanotomy in the posterior wall of the middle ear. So it is called posterior tympanotomy. The facial recess approach is called posterior tympanotomy. Medially it is bounded by chorda tympani. No, we will see the boundaries. Laterally it is bounded by chorda tympani, not by medially. So the answer is B. Also done in cochlear implant surgery. Yes, definitely. It is a very important approach for cochlear implant surgery where the electrodes are placed into the round window through the facial recess approach. You will see the pictures, more clear pictures. Round window can be approached through it. Yes, round window is in the posterior part of the mesotympanum. It can be approached through it. Yes. So these are all the points and B is the answer for this question. Okay. And again have a look of this picture. Again, we will have a clear look with other pictures. See this, again I tell you. So this is the incus. Incus short process is lodged at a point in the posterior wall of the middle ear, and that is called fossa incudis. Please remember this point, fossa incudis. And the bridge of bone is called incus buttress. Incus buttress, the place where the incus is placed. Incus buttress, that's all. Okay. And in the posterior tympanum, we have opened this area. And in the posterior wall of the middle ear, we know the facial nerve is running vertically downwards. This is the facial nerve, the vertical segment of the facial nerve running downwards. If you open the area above this facial nerve, that is a facial recess, and the chorda tympani will be emerging like this and goes anteriorly. So medially by the facial nerve and laterally by the chorda tympani nerve and superiorly by the fossa incudis. So these are all the boundaries of facial recess in the posterior wall of the middle ear. So this is about the facial recess, and we will see all other things, and we can even see the round window there very clearly. See again, see this incudostapedial joint assembly present in the oval window. Stapes, we have this anterior and posterior crura, and very clearly we can see the round window membrane here. So to expose this area, posterior mesotympanum, we are doing this facial recess approach. Please remember. Coming to the middle ear, what are all the points to note in the middle ear? We have this epitympanum, mesotympanum, and hypotympanum. Epitympanum is the widest area. The width is 6 millimeter, please remember. And the bigger part of the ossicles are present in the epitympanum. They'll be asking you, what are all the components of epitympanum? Head and the neck of the malleus and the body of the incus and its short process are all present in the epitympanum. And handle of the malleus, long process of the incus, and the whole stapes, all the slender structures are within the mesotympanum. The bigger structures are within the epitympanum, head and neck of the malleus, body and short process of the incus within the epitympanum. And all the slender structures are opposite against your pars tensa. Those are present in the mesotympanum, and a small shallow area is in the hypotympanum. So these are all the areas, and the widest part is the epitympanum, 6 millimeter width, and the narrowest part, don't look at this picture, this is just a schematic diagram. Basically the middle ear will be like this, tympanic membrane will be like this, and the promontory bulge will be like this in the medial wall, and the hypotympanum, and this is the huge epitympanum. So this width is 4 millimeter, this is the narrowest 2 millimeter, and hypotympanum is around, so this is 6 millimeter and this is 4 millimeter hypotympanum. So the epitympanum is widest. Please remember, epitympanum is 6 millimeter. So hourglass appearance is the middle ear anatomy. Okay. Coming to the walls, I have given in a simple pictorial representation. In each wall there are 3 rounds. So easy to remember, 3 important structures in each wall MCQ wise, and of course clinically of course. So these are all the points we have to remember where the MCQs will be surrounding these areas. So what are all the walls of the middle ear? Let us start with the lateral wall. Again, I have noted it as 3 structures. See very clearly, it has been peeled, the pars tensa, it has been peeled away to expose the middle ear. So the lateral wall contains the bone, the structures in the lateral wall of the middle ear are the pars tensa and the smaller pars flaccida, which has been again peeled away, and the bone which is forming the lateral wall of the epitympanum is scutum. So these are all the 3 structures of the lateral wall. After peeling off this tympanic membrane, you can very clearly see the handle of the malleus, lateral process of the malleus. See how prominent it is, lateral process of the malleus, and we can see this incudostepedial joint assembly in the posterior part of the mesotympanum. For your understanding, all the pictures of this ear anatomy are right ear. Right ear, please understand, all the pictures of this ear anatomy are regarding the right ear, so that you can easily understand, orient yourself. Again, for your orientation, this is anterior, this is posterior. So obviously the posterior we have this incudostepedial joint assembly, and what is this nerve, this thing, see this nerve going. So obviously we know the vertical segment of the facial nerve will be like this in the posterior wall of the middle ear. The branch is cauda tympani nerve. The cauda tympani nerve goes like this and goes in between the malleus and incus and exits in the anterior wall of the middle ear, and exits in the anterior wall of the middle ear. That is the course of cauda tympani. It goes between the malleus handle and the incus long process. So this is the course of this cauda tympani. Okay. And this spicula of the bone is the radiological picture, lateral view is a scutum. So scutum forms the lateral wall of the epitympanum. See, this is the epitympanum, and this is the mesotympanum, and this is the hypotympanum, how it looks like in the radiological CT picture. And if the cholestoma occurs from the pars flaccida into the prosoc space, the scutum is the initial bone to get eroded. So scutum erosion, usually scutum will be like this sharp. When there is a blunting of the scutum, when there is blunting of the scutum, if this part of the scutum has been eroded, so scutum erosion is a sign of cholesteatoma formation. That is very important point. Scutum erosion is a sign of cholesteatoma formation. That's very important sign in CT scan in cholesteatoma patients. Okay. Coming to the medial wall. So again we have this surrounding the promontory, we have 3 structures, 1, 2, 3. 3 important structures in the medial wall also. So how it looks like the medial wall? See this. This is the simple pictorial representation, and this is a real anatomical pictures. Of course, we will be getting many pictorial questions in the MCQs. So if you get any pictures of the middle ear, we should be knowing how the structures really looks like in a middle ear or any structures in the ear. So this is how we have to correlate. So the middle bony part, bulge, is the promontory. And of course, we know promontory is formed by the basal turn of the cochlea, the bulge in the medial wall of the middle ear. We are seeing the medial wall of the middle ear. Okay. Surrounding the promontory, 3 important structures. Again, please orient. This is a right ear again, anterior and posterior. Okay. Posteriorly, we have 2 windows very clearly. We have this oval window, and this is the round window. This is this marking. See this. These are all the hypotympanic cells, small defects in the inferior of the hypotympanic cells. That's not very important. So this is the round window. So the round window. So two windows in the posterior, oval window, round window, postero superiorly and postero inferiorly. And antero superiorly, there is a very important structure called processus cochleariformis. That is very important. Processus cochleariformis. We have very important MCQs for processus cochleariformis. Antero superiorly, above this promontory, we have this bony structure. A prominent bony structure is called processus cochleariformis. How it looks like? This is how it looks like in the real picture. A prominent bony structure. Sometimes there will be a tendon attached to this process cochleariformis. The tendon is nothing but tensor tympani. See this tensor tympanic canal. The tensor tympani arises, attaches to the process cochleariformis, and the tendon will be coming out to get attached to the neck of the malleus. Neck of the malleus. Okay. We have this process cochleariformis. What are all the points? The first point, this is the most prominent structure of the middle ear. We have seen the most prominent structure of the tympanic membrane is lateral process of the malleus. Please remember. And the most prominent structure of the middle ear is process cochleariformis. And second thing, the process cochleariformis gives attachment to the muscle called tensor tympani muscle, where the tendon arises. And the third thing, very important again, this is the only landmark for very important landmark for first genu of the facial nerve. Where is the facial nerve here? I will show you. So this is the only important landmark for first genu of the facial nerve. So the facial nerve is here. See this. I will mark it. This pink structure above all this structure is the facial nerve. So this is the first genu area of the facial nerve, where the labyrinthine segment will be deep inside this petrous part of the temporal bone. And again the first genu arises, first genu here, horizontal segment, the red dots I have made here, and the second genu here, and again the vertical segment of the facial nerve will be descending well inside the fallopian canal, that is the bony canal of the facial nerve. So this is how the facial nerve courses as in a real picture. First genu, horizontal segment, second genu on the vertical segment. So the first genu of the facial nerve, the process cochleariformis is the only important landmark. Another landmark is cog. Cog is nothing but not a very significant landmark, I'll tell you. A bone is spicule hanging from the tegmen. A bone is spicule hanging from the tegmen at the level of first genu. But that is not much significant landmark. The process cochleariformis is a very important significant landmark for the first genu of the facial nerve. So these are all the points to note here. And regarding the other important structures, the oval window and the round window, what are the points to note? The oval window, it sits over the saccule of the inner ear. See, the oval window leads to the sound wave, leads into the cochlea. Not only the cochlea, we have the utricle and the saccule inside the vestibular apparatus. The part of the oval window sitting over the saccule. That means any loud sound, it can stimulate not only the cochlea, it can also stimulate the saccule of the inner ear. That's very important point. And round window is covered by a membrane called secondary tympanic membrane. That's very important. And the membrane is also called as tympanic membrane. Simply, it is a secondary tympanic membrane. Round window is covered by secondary tympanic membrane. Okay. Coming to the anterior wall, from below upwards, we have this prominent canal called eustachian tube orifice, which goes into the nasopharynx, and we have this tensor tympanic canal, the bony canal. See this bony canal for the tensor tympani, and a small canal called canal of Hugier. This three things. Can you correlate with your pictorial box? Three rounds again in the anterior wall. The canal of Hugier is nothing but it is where the chorda tympani, I told you. See, this is the vertical part of the facial nerve again. Chorda tympani arises from the posterior part and exits the middle ear through this canal of Hoogier. So canal of Hoogier is the exit canal for the chorda tympani. Okay. These are the three structures in the anterior wall. Posterior wall, very important area where the MCQ surrounds in the posterior wall and the medial wall. These are the two important areas we have to note. Again, the posterior wall, see, there are certain pictures to orient ourselves. This first picture, please orient. We are looking into the middle ear as if we are sitting in the eustachian tube orifice and looking into the middle ear. Okay, and straight ahead of your middle ear is your antrum, and that is through a opening called Auditory, the opening in the posterior wall of the middle ear. Three important structures again, as in the picture. Auditory is the first opening, which connects the epitympanum to the mastoid antrum, Auditory opening. And the second thing, come to this picture, the vertical part of the facial nerve. That is the second important structure in the posterior wall of the middle ear. Of course, we know that. So, vertical part of the facial nerve runs in the posterior wall of the middle ear. In between these two structures, concentrate on this second picture. So, we have this Auditory here where the epitympanum communicates with the antrum. We have this vertical part of the facial nerve here, and we have a prominent bony structure. What is this? This is the bony structure, pyramidal process, PP, pyramidal process. The pyramidal process gives stapedius muscle, and this tendon is the stapedius tendon, attaches to the neck of the stapes. So we have two muscles of the middle ear. One is tensor tympani, and next one is stapedius muscle. So the pyramidal process gives origin to the stapedius muscle. So these are the three structures in the posterior wall of the middle ear. So three structures. And if you see aerially, above goes above and sitting and seeing from above in the posterior wall of the middle ear. So this is the posterior wall of the middle ear. We have the structure called the facial nerve in the middle, and it gives a branch called chorda tympani. Of course, chorda tympani. So on either side of the facial nerve, there is a valley, depression. Imagine facial nerve is like a mountain ridge, and on either side of the facial nerve we have the depression, valley on either side of the facial nerve, and each valley has its name. So see the first picture again, correlate the first picture again. On either side of the facial nerve we have this depression laterally, and we have the depression medially. So the recess lateral to this vertical part of the facial nerve is called facial recess, and the depression medial to the facial nerve is called sinus tympani. These are the two important areas on either side of the vertical part of the facial nerve. That is very, very important. That's why with this picture we can very clearly say, see, the facial recess is bounded by medially by the vertical part of the facial nerve. See the yellow line, laterally by the chorda tympani, and superiorly the point where the fossa incudis is present. The short cross of the incus is placed. That is a fossa incudis. So these are the three boundaries of the facial recess. That's very important. So this is about the posterior wall of the middle ear. Coming to the facial recess in a very clear enlarged way. So this picture, if you skeletonize the structures very clearly, you will get the second picture. See this again, see this. Through the Auditory, we are very clearly able to see the incus, and further dissection, we are able to see the malleus head there. And this is the fossa incudis I told you. The facial nerve vertical part is very clearly delineated, and this is the chorda tympani nerve. So in between the facial nerve medially and the chorda tympani nerve laterally, facial recess, we can see this oval window and round window structures. And through the antrum, if you further delineate, there is a bulge in the medial wall of the mastoid antrum. What is that bony bulge? That is the lateral semicircular canal, the dome of the lateral semicircular canal. In the first slide itself, I told you the semicircular canals are related to the mastoid. So if you open the mastoid, you will encounter the semicircular canals. So the bony bulge over the medial wall of the semicircular, that is of the mastoid, is the dome of the lateral semicircular canal. If you further delineate, skeletonize, you will encounter the superior semicircular canal and the posterior semicircular canal. But the most important dome, the bulge, see this again in this picture. This dome is called dome of the lateral semicircular canal. So this is about this facial recess, and the point, like at a slingshot facial recess, vertical part of the facial nerve medially, chorda tympani laterally, and fossa incudis superiorly. Please remember these three structures: medially by the facial nerve vertical part, laterally by the chorda tympani, and superiorly by the fossa incudis. So these are the three important structures surrounding this facial recess. So with this, we give you a small break and we'll be back with other areas. Hello, we are back. So we have seen the facial recess, quite important anatomy. And now one more area we have dealt, that is the area medial to the facial nerve, vertical part of the facial nerve, that is called sinus tympani. Where is sinus tympani? See the same picture we are seeing often, the same medial wall, it is been zoomed in picture now. If you zoom in the posterior part of the mesotympanum, very clearly you can assess the structure. See, oval window where the stapes is sitting with its screw round footplate, and this is the incus, and this is the incrostapital joint, and we have this round window. This is the round window. This is the round window. And of course, I told you this is the vertical part of the facial nerve running, and this is the pyramidal process with its stapedial tendon. And this area is the sinus tympani. This is the sinus tympani, bounded above by a thin bone called ponticulus, where it is meeting the pyramidal process from the promontory. So P to P is a P, ponticulus from promontory to the pyramidal process. Just these are all the rare questions they may ask you. And subiculum, this is called subiculum, a broad bone below the sinus tympani. But if you want to, if you can, please remember. So ponticulus and subiculum are the two important boundaries of the sinus tympani. And what is the important MCQ about sinus tympani? That is very important. This sinus tympani is hidden area for colostoma in the middle ear. So the sinus tympani is a very small, very deep area inside the tympanum, and hence the colostoma there is more chance to hide deep inside. Unless otherwise you explore this sinus tympani clearly, there is a chance for residual colostoma after your colostoma surgery. So sinus tympani is a hidden area for colostoma. That's very important. Okay. So these are all the things. So this is the picture C, where the whole external meatus, tympanic membrane, mastoid, everything is been removed, exposing the whole entire medial wall of the middle ear. So this picture is for your understanding how the ossicles are aligned. See, this malleus is present, the incus is present with its short process of the incus, that is the fossa incudis, and we have the handle of the malleus and long process of the incus. So this is the dome of lateral semicircular canal. This is the dome of lateral semicircular canal. We have this posterior and superior semicircular canals. And how the facial nerve is been oriented. See this. This is the vertical part of the facial nerve behind your ossicles, and this is the second genu of the facial nerve, and this is the vertical, sorry, that is a horizontal part, and now I am drawing the vertical part of the facial nerve, and this is a chorda tympanic branch of the facial nerve. So with this, we need to know how this second genu has many important landmarks for the facial nerve. Many important landmarks for the facial nerve. I just tell with this picture, and you please correlate so that you can easily understand the second genu. See, second genu, first point, it is at the level of pyramidal process. First point, the first landmark, pyramidal process. At the level of pyramidal process is the second genu. Okay. And then oval window. Oval window is antero-inferior to your second genu. See, remember, please remember, this is the second genu. So second genu is at the level of pyramidal process, and oval window is antero-inferior to the second genu. The dome of the lateral semicircular canal is posterior-superior to the second genu. And one more landmark, fossa incudis, that is a short process of the incus, fossa incudis. When you relate to the fossa incudis, just remember the facial nerve second genu is inferior and medial, inferior and little medial to the fossa incudis. With this, you can clearly correlate all these structures. So these are all the important landmark. So I told you for the first genu processes, cochleariformis is the only landmark, important landmark. But for the second genu, there are multiple landmarks: oval window, pyramidal process, dome of the lateral semicircular canal, and fossa incudis. These are all the points for the second genu. And even if you want to correlate with the fossa incudis, please correlate. In this picture, we have clearly seen, see this, this is the second genu, and this is the fossa incudis I told you. So the second genu is a little inferior and medial to the fossa incudis. So these are all the points regarding the second genu of the facial nerve. Landmarks of the facial nerve. That's all. Coming to the mastoid. Next MCQ. All are false about McEwen's triangle except. So we know very well know McEwen's triangle, which is a very often asked question, very important area in ENT. So mastoid antrum lies 1.5 centimeter deep to it. All are false about McEwen's triangle except surgical landmark for the facial nova. Yes, it is false. It is not the surgical landmark for the facial nova. It is actually the antrum. Okay. Present in preauricular region. No, it is present in postauricular region. It is bounded by suprameatal crust anteriorly. No, it is bounded by the suprameatal crust superiorly. So it is also false. So which is the only true statements? This is the true statement. Mastoid antrum lies 1.5 centimeter deep to it. So the McEwen's triangle is basically a landmark for the mastoid antrum. That's quite important. Okay. Yes. So this is the McEwen's triangle boundaries. What are all the boundaries in the temporal bone? I told you already, this is the tympanic ring, tympanic bone, or the bony part of the external meatus. So that is the point. So what is this spicula of the bone? And that spicula of the bone is called Henle's spine. Henle's spine, it is in the postero-superior part of the extremitus, Henle's spine. And Henle's spine is a landmark for Otitis. Otitis, the connecting canal, I told you, between the epitympanum and the antrum, Otitis. So the McEwen's triangle, the boundaries are draw a line along the Henle's spine or the postero-superior part of the extremitus and draw a line in the suprameatal or supratemporal line. Draw a line along the supratemporal line and draw a tangential line to the posterior wall of the extremitus. So this is the posterior wall of the extremitus. Draw a line tangential touching the posterior wall of the extremitus. So this area is the McEwen's triangle, which is a landmark for the mastoid antrum. I told you, Simba concha. The Simba concha is the external landmark for the mastoid antrum, and then the bony landmark after exposing the temporal bone. This McEwen's triangle is the landmark for the mastoid antrum, and the antrum is sitting 1.25 to 1.5 centimeter deep to this McEwen's triangle. Okay. What is this line? I have clearly mentioned with the arrow marks. See, this is the CT scan picture, the axial picture. This is the middle ear. This is the middle ear. This canal, small canal, is the Otitis, and this is the mastoid. So this is like this. So the middle ear where we can see the ossicles, through the Otitis, the antrum, and through the middle ear the ossicles will be seen like this. The malleus head and incus body will be like this, and it is like ice cream cone appearance. See this very clearly, we can see this ice cream cone appearance of the ossicles in the epitympanum region. So that is one point you have to know, how it resembles like in the CT picture. And what is this line, the arrow marked line? That is called corner septum. That is called corner septum. So the corner septum, it separates the superficial cells from the deep petrosal cells of the mastoid air cell system. So means the corner septum, if it is there, the antrum will be present deep inside the corner septum. So if there is a corner septum in the CT scan, if you identify that, you should be very careful. You have to open the corner septum to expose the antrum, to enter into the antrum. So antrum is deep, medial to the corner septum. This is nothing but petrosquamous septum. Embryologically, it divides the superficial squamous cells and the deep petrosal cells of the mastoid air cell system. So that is about the corner septum. Okay. In the mastoid, two more areas are quite important. One is Citali's angle, another one is Trotman's triangle. What is Citali's angle? If you take this picture, this after exposing the mastoid antrum, see this is the middle ear, external meatus and the middle ear, and behind is the antrum, when the whole mastoid has been exposed. So this is the posterior meatal wall, and this is the sigmoid sinus. See, the blue is sinus behind your mastoid, and superior is your tegment plate, or it is called dural plate. So the angle in between this thing, dural and sigmoid, sinodural, sinus and the dural. So sinodural angle is the Citali's angle. This area is the Citali's angle. What is the importance of Citali's angle? This is again a hidden area in the mastoid region for cholesteatoma. So the hidden area for cholestoma in the mesotympanum is your sinus tympani. The hidden area in the mastoid is the Citales angle, sinodural angle. Okay. And one more triangle is called Trotman's triangle. What is Trotman's triangle inside this mastoid? So Trotman's triangle will be like this. This area is the Trotman's area and it is bounded by the labyrinth anteriorly. Labyrinth is nothing but the inner ear. So we have the semicircular canals. So the anteriorly by the labyrinth and posteriorly by the sigmoid sinus obviously, and superiorly there will be a vein traveling, that is called superior petrosal sinus. Superior petrosal sinus in the dural plate. So these are the three areas surrounding this Trotman's triangle. So correlate with this picture, see this. If you take an axial picture like this, you can easily see this. This is the Trotman's area. More inside, anteriorly we have this inner ear and posteriorly we have the sigmoid sinus and superiorly we have the superior petrosal sinus. So what is the importance of this Trotman's triangle? Through this we can enter into the posterior cranial fossa, through which we can enter into the posterior cranial fossa, and even we can expose the endolymphatic sac during your Meniere's surgery. Meniere's disease, if you want to expose the endolymphatic sac, this is the area we can expose. So how will they expose actually? What are the landmarks for that, this endolymphatic sac? We have to draw a line along the lateral semicircular canal which bisects the posterior semicircular canal like this, and the endolymphatic sac will be lying antero-inferior to this Donaldson's line. This is called Donaldson's line. So this is where we have to find the endolymphatic sac. So this is a Trotman's area, very important in the mastoid. Coming to the inner ear, regarding semicircular canals, Qualls is has two ampullated ends, opens through the 5 openings. Crus commune is the common opening, opens into utricle, which is false. Of course, it do not have two ampullated ends. It has only one ampullated end. One ampullated, one non-ampullated. Opens through 5 openings. Yes, even though we have the 3 canals, of course there should be 6 openings. There is a common opening. What is that common opening? That is called crus commune and opens into the utricle. So this is about the semicircular canals, and we will see the picture later. Any other points I will add on. And next question. An infant was treated for meningitis. Again, the inner ear, related to the inner ear. An infant was treated for meningitis. Okay. During the time of discharge, baby was found not responding to the sounds. BAER shows profound sensorineural hearing loss, and baby was diagnosed as having labyrinthitis. Okay. What is the probable route of transmission of infection into the inner ear? So meningitis baby at the time of discharge found to have been having deafness. On examination of the BAER, the baby was found to be having sensorineural hearing loss, and that is due to labyrinthitis. The meningitis has spread into the inner ear causing labyrinthitis. So what is the route of spread of meningitis into the inner ear, infection into the inner ear? So cochlear aqueduct, endolymphatic sac, vestibular aqueduct, round window. So through which aqueduct it would have entered into the inner ear? So round window, we know this is a connection between the middle ear and the inner ear. Cannot be. Okay. Either other two openings, endolymphatic sac is actually a closed sac. So through which it cannot be. So there are two openings through which, one of the opening through which the infection would have been entered into the inner ear. So the answer for this question is cochlear aqueduct. How and why? So we need to know. Cochlear aqueduct is the canal for draining the perilymph. So perilymph is nothing but a filtrate of the CSF which drains into the subarachnoid space. So obviously in meningitis, the infection will be in the subarachnoid space that will spread into the inner ear through this cochlear aqueduct. The vestibular aqueduct opens into subdural space, not into the subarachnoid space. So we need to know what are all the differences, what are all the openings of the inner ear. Grossly, this inner ear structures we have, I told you, we have the superior semicircular canal and posterior and lateral semicircular canal. which opens into the utricle, and the angle formed by this intersection is called solid angle, and the common opening between the superior semicircular canal and the posterior semicircular canal is called crus commune. That's why it has only 5 openings. Sorry, okay. And this is the saccule, and surrounding this inner ear, the blue colored balloon here is the membranous labyrinth that is filled with endolymph, and the white space, see, the white space surrounding this membranous labyrinth is the perilymphatic space. So that is a membranous labyrinth, and this is the brown color is the bony labyrinth. Between the membranous and the bony labyrinth is the perilymphatic space. So endolymph within and perilymph surrounding that. So we have this 5 openings around this inner ear. What are the 5 openings? From the middle ear side, we have the oval window and the round window. And one more important opening is the internal acoustic meatus. And apart from these 3 openings, 2 other important openings. One is the vestibular aqueduct. This is vestibular aqueduct. And another one is cochlear aqueduct. So simply see this diagram. The vestibular aqueduct drains the endolymphatic duct there, the blue line, and that drains into a sac called endolymphatic sac, and that is opening in the subdural space. And the cochlear aqueduct, from the cochlea, it drains into the subarachnoid space, the white line, which drains the perilymph. So we have 2 fluids, endolymph and perilymph. We need a draining canal for these 2 fluids. So vestibular aqueduct is for the endolymph and cochlear aqueduct is for the perilymph. The mnemonic here is cochlear aqueduct drains perilymph, cap, CAP. So that is an important point. And obviously, why the infection passes through the cochlear aqueduct? Very simple. The perilymph is nothing but CSF, ultrafiltrate of CSF. Where is the CSF? Subarachnoid space. Again, the perilymph drains again into the subarachnoid space, and hence any infection from the intracranium will spread through this cochlear aqueduct, because the meningitis infection will be, the CSF space will be infected. So subarachnoid space is infected. So that spreads into the inner ear through the cochlear aqueduct. So please remember the mnemonic CAP, cochlear aqueduct drains perilymph into the subarachnoid space, obviously. So this is about the difference between this draining of the 2 fluids. And endolymph, it has more potassium, please remember, because that is the depolarizing positive ions in the endolymph for the hair cells. And perilymph, it is like CSF, which is extracellular fluid, it has more sodium. And again in the CSF, the glucose content is more, 80 milligrams per deciliter at least will be present in the perilymph. So these are all the points regarding these 2 fluids. All the following are true about hair cells of organ of corti except. All the following are true about hair cells of organ of corti except. Inner hair cells have the maximal afferent fibers in the 8th nerve. Outer hair cells are more in number. Inner hair cells modifies the mobility of the basilar membrane. Outer hair cells are more vulnerable to the noxious stimuli. So which is false? All the true about the hair cells except. Inner hair cells have maximal afferent fibers in the 8th nerve. Yes, true. Outer hair cells are more in number. Yes. Inner hair cells modifies the mobility of the basilar membrane. No, it is not the inner hair cells. Outer hair cells modifies the basilar membrane mobility. There are certain points I give you a mnemonic to easily remember this. Outer hair cells are more vulnerable to the noxious stimuli. True. So what are all the differences between the inner and outer hair cells? See, inside the cochlea, cut section of the cochlea, a few important points to note. This is the basilar membrane. This is the Reisner's membrane. This is scala vestibuli. This is scala tympani, and this is scala media. And we have a slender membrane called tectorial membrane. And we have this inner hair cells and outer hair cells. And we have the spiral lamina and spiral ganglion, which is the first order neuron from the inner hair cells. And this is the stria vascularis, that is a secretory epithelium for the endolymph in the scala media. Stria vascularis is present. Okay. So the differences between this inner hair cells and outer hair cells are, I tell you, A, E, I, O, U, vowels. Write it in this order to remember in an easier way. So leave the U, A, E, I, O, U. We have leave the U. Inner hair cells are afferent, outer hair cells are efferent. Please remember, that is very important. So inner hair cells are afferent, outer hair cells are efferent. And I, it is like a single. So it is a single row. Inner hair cells are minimal, single row. And of course, the more number will be outer hair cells. Remember the power switch symbol, power symbol. So inner hair cells are single, and outer hair cells are like arena, gallery, multiple rows of gallery will be present in the outer hair cells. So inner hair cells are single row, minimal, and outer hair cells are multiple rows, majority, more number. And inner hair cells are afferent and outer hair cells are efferent. Efferent means, what does it mean? The outer hair cells are called cochlear amplifiers. The outer hair cells has the property of increasing the vibratory property of the basilar membrane. So the outer hair cells can make the cochlea to vibrate, the basilar membrane to vibrate more, and to create more stimulation in the cochlea. So this is what the outer hair cells are called, cochlear amplifiers. So if you want to keenly observe on certain sound, our cochlea has the ability to keenly observe on a particular sound. So that part of the basilar membrane can be vibrated in an augmented way by means of this outer hair cells. Outer hair cells are contractile in nature. So this is a point. So outer hair cells are efferent. They are cochlear amplifiers. So this is very important. And vulnerability, these inner hair cells are more resistant. The outer hair cells are easily damaged by the ototoxic drugs and noise. So any noise-induced hearing loss, ototoxicity, presbyacusis, in any of these conditions, outer hair cell degeneration are quite common. Okay, so these are all the important differences. Please remember the mnemonic, that's what I am telling you. Vowels A, E, I, O, U, leave the U away. Inner hair cells are afferent, outer hair cells are efferent. Inner hair cells are single rowed, outer hair cells are like gallery, more in number. Last, even though the last point, inner hair cells are minimal, single row, inner hair cells afferent fibers occupies majority of the eighth nerve fibers. That is the first point of MCQ that we have to remember. So even though the inner hair cells are minimal, afferents are very important to hear the sound, of course. So which is afferent? Inner hair cells. So the inner hair cells has multiple nerve fibers that will be innervating. So more fibers in the eighth nerve will be from the inner hair cells, afferent fibers. Of course, we need afferent fibers for hearing. So more fibers are afferent fibers from the inner hair cells. That is the point to remember. That is the point number A. Inner hair cells have the maximal afferent fibers in the eighth nerve. Yes, true. Okay. Bill's bar lies between which of these structures in the internal acoustic meatus? So the inner ear, more important areas are over. Now coming to the Bill's bar, internal acoustic meatus. Which of these two structures? It's very clear. Don't get confused. It is facial nerve and superior vestibular nerve. That is the answer for this question. So again, easy to remember. The point is internal acoustic meatus. I told you there is internal acoustic meatus. The facial nerve is running more anteriorly and more superiorly. That is the mnemonic. Facial nerve is in the antero-superior terminal. Facial nerve is in the antero-superior terminal. So facial nerve in the antero-superior terminal. Obviously, which is the nerve that present anteriorly? Another nerve which is present anteriorly, cochlear part of the eighth nerve. Why? Because cochlea is present anteriorly. Semicircular canals are present posteriorly. The semicircular canals are present posteriorly. So obviously, the antero-inferior will be your cochlear part of the eighth nerve. And behind postero-superior, postero-inferior. And that is very simple. Superior vestibular nerve and inferior vestibular nerve. So these are the two nerves in the posterior part of the internal acoustic meatus. So we have the two bony bars, the transverse crust, falciform crust separating the superior bundles and the inferior bundles, and a vertical crust which separates two superior bundles. So of course the anterior will be our facial nerve and posterior will be our superior vestibular nerve. So this vertical crust is called Bill's bar. So this importance where it happens in the surgery of vestibular schwannoma. So if you identify this vertical crest and the horizontal crest, you can avoid injuring the other nerve bundles. The facial nerve injury can be avoided, cochlear nerve injury can be avoided. So this is the alignment of the nerve bundles in the internal acoustic meatus. So remember the mnemonic fast, the facial nerve is in the antero-superior terminal. So obviously the antero-inferior is cochlear, postero-superior and postero-inferior is your superior and inferior vestibular nerve respectively. So this is about the alignment of the nerve bundles in the internal acoustic meatus. Coming to a few points regarding the embryology of the ear, where often you will be getting the questions. All are true regarding post-oral incision C except. So see the picture, pinna they have been, it's been indicated like A and B incisions which are irregular post-oral incisions, very close to the pinna in the retroauricular groove itself and little away from the groove, B and AB. That's a useful post-oral incisions, William Wild post-oral incisions. And there is an incision called C. So they are asking about C, which is made far away from the pinna, more horizontal, more far away from the pinna. So all are true regarding post-oral incision C except absent tympanic ring, well-developed mastoid to avoid facial nerve injury made in infants except. So this post-oral incision C is made in infants. Yes, it is typically made in infants. Okay. Why it is been made like this far away from the pinna? To avoid facial nerve injury. Yes. Why it is made far away from the pinna again? There are two bony structures defective at birth. One is mastoid, another one is the bony part of the external meatus. Remember this, these are the important MCQ. Two important structures that are defective at birth is mastoid bone and the tympanic ring, the bony part of the external meatus. So absent tympanic ring, yes, that is why we are making more posteriorly. Since these two bony structures are defective, the vertical part of the facial nerve is more superficial, just underlying the skin it will be present. That's very important. So it is not well developed mastoid, it is ill developed mastoid. That's all. So it is not well developed mastoid, it is ill developed mastoid. So these are all the important points regarding this incision. So this is about the post-oral incision C. So point here is, what are the two structures defective at birth? This mastoid bone and the tympanic ring bone are defective, and hence this facial nerve will be vertically downwards, which is present just underlying the mastoid part. The mastoid thickness will be very thinner, just 1 to 2 millimeter, that's all. So if you drill a little, you will enter into the facial nerve. So we have to make a more posterior incision, more posterior drilling is very important. So that is why we are making the incision C more posteriorly, far away from the pinna to avoid facial nerve injury. So most frequently asked questions of embryology. What are all the typical questions they will be asking? All these points again and again they will be asking. So the fetus can hear by 20 weeks. All the structures of ear are well developed at the age of 20 weeks of gestation, so that the fetus can hear. So there are two structures which are defective. One is the mastoid air cell system. Remember, antrum will be present, but the mastoid air cell system will be ill developed. It is not present at birth. The pneumatization gets completed by the 5 to 6 years of age. That is one point. And the tympanic ring or tympanic bone, the bony part of the external meatus is defective at birth, and hence the tympanic membrane is more horizontal. And once the tympanic bone grows, the tympanic membrane becomes more vertical. So this is two important structures which are defective at birth. And regarding the ossicles, the origin of the ossicles, the malleus and incus and stapes. Regarding this, these are all from the first and second arches. Malleus is from the first branchial arch, and incus and suprastructure of the stapes are from the second branchial arch. And the foot plate of the stapes and its surrounding annular ligament, they do not originate from the branchial arches, they are from the otic capsule. Otic capsule. The otic capsule is the point where the bony labyrinth originates. So the foot plate and its annular ligament belongs to the otic capsule, not from the branchial arches. This is often asked a question, that's quite important. So foot plate and its annular ligament originates from the otic capsule. So diagrammatic understanding of this inner ear are, say this, the external meatus originates from the first branchial cleft. The first opening from the skull is the external meatus. So obviously it's very clear it is from the first branchial cleft. And the middle ear is from the eustachian tube and the middle ear and antrum. All are the same group, tubo-tympanic recess. The eustachian tube, middle ear and the antrum, all are from the single origin. That is the first branchial pouch. So this is first branchial cleft and that is first branchial pouch. And we have seen that ossicles, malleus from the first arch, incus and stapes suprastructure from the second arch. Sure, okay. And the inner ear, it has a separate origin from the otocyst, from the hindbrain, the neuroepithelium from the hindbrain, otocyst. And this bony labyrinth surrounding this membranous labyrinth is called the capsule. It is like capsule. It is called the otic capsule. So otocyst and surrounding bony labyrinth is called otic capsule. Remember these points. And regarding this otocyst, that is an MCQ. So in the fetus, see, otocyst, it develops into the inner ear. Okay. The fetus is bending the neck like this in the inside the womb. It will be like flexing the head. So this otocyst develops into two parts, 1 and 2. And since it is fetus is bending downwards, it is been termed like this part is called pars inferior, or correlate with the picture. See this, if there is otocyst like this, it is divided into two parts. So it is pars inferior or ventralis or anterior, and this part is called pars superior or dorsalis or posterior. We very clearly know which is anterior part of the inner ear, cochlea, which is posterior part of the inner ear, semicircular canals. So that is a simple thing. So pars inferior or the anterior is developing into cochlea plus its adjacent part of the vestibular apparatus, saccule, cochlea and saccule. And the pars superior develops, or posterior develops into superior semicircular canal plus its adjacent part of the vestibular apparatus, utricle. So these are the two divisions. So please remember why it is called pars inferior, pars superior, or pars anterior or pars posterior. So simply to confuse you, the terminology pars inferior or superior is used in the MCQ. So pars inferior develops into the cochlea and the saccule, and the pars superior is developing into the semicircular canals and the utricle. So these are the two divisions of the otocyst. Okay. Coming to certain deficiencies, dysplasias of the labyrinthine origin cochlea. Complete absence of bony and membranous labyrinth, which is a deformity. Of course, we know this, often it's been asked Mondini deformity, Michael, cochleosaccular and Alexander dysplasia. The answer, complete absence is Michael deformity. So what are all the deformities we have? Dysplasias very commonly. Scabies is common, cochleosaccular dysplasia most common, and Mondini is, it is only the part of cochlea, basal tone of the cochlea is present, that it takes only 1.5 turns. Usually we have 2.5 to 2.75 turns of cochlea, but only the basal turn 1.5 turns is present. Apical part of the cochlea will be absent in Mondini dysplasia. So easy to remember in a way. I used to tell Mondini, Monday. Mondini is Monday is present. The tail end of the week, Sunday is absent. So the Monday, the initial part, basal part is present, and the Sunday, the tail end part is absent. The apical part of the cochlea is absent. It is Mondini deformity. Michael aplasia, Michael Jackson is dead. So the whole inner ear is absent. Absent inner ear. Nothing will be present in the inner ear. That is called Michael aplasia. So these are the two important conditions of the inner ear where you will be getting questions from the cochlear implant. So where cochlear implant can be done, in which kind of anomalies, in which kind of anomaly you cannot do. You cannot do in Michael aplasia because there is no cochlea at all. We need some part of cochlea to put the electrodes inside the cochlea. So you can do a cochlear implant in a Mondini deformity or the scabies dysplasia, but you cannot do a cochlear implant in case of Michael aplasia. So there is no cochlea at all. So this is a point regarding these things. So what can be done if the patient is having Michael aplasia? How to make the baby to hear well? So cochlea is not present. So the next point is to stimulate the cochlear nucleus itself. So if there is a Michael aplasia, we have to stimulate the nucleus itself in the brainstem. That is auditory brainstem implant. We will be seeing that later in further questions. Coming to the physiology of hearing now. Few points regarding the physiology of hearing. Lever ratio is, how much is the lever ratio? 14, 1.3 is to 1, 18 is to 1, 1.5 is to 1. So the answer is 1.3 is to 1. I tell you in a simpler little way to remember this, whether it is 1.3 or 1.5, sometimes we may get confusion. A little points I tell you. So hearing mechanism, the physiology of hearing. So mechanical conduction of the sound through the external meatus, and that is from the external ear, middle ear, it is conducted into the inner ear. So from the inner ear, the mechanical sound energy is converted into electrical energy. That process is called transduction. Transduction is conversion of mechanical energy into electrical energy, and that electrical impulse is carried on to the brain through the auditory pathway, E. coli ME. So what is the role of middle ear here? Middle ear is nothing but impedance matching. So majority of the sound waves, when they are traveling in the air, and if they want to enter into the fluid medium of the inner ear, majority will be reflected away. So to prevent the reflection, the middle ear increases the force of the sound energy into the inner ear. That's very important. It increases the force of the sound energy into the inner ear. So this is the impedance matching, resistance matching mechanism of the middle ear. So how the middle ear do its impedance matching mechanism? So there are two mechanisms. So one mechanism is hydraulic ratio or aerial ratio, and another is lever ratio. So what is aerial ratio? See this, the sound waves falling upon on the bigger area of the tympanic membrane, the pars tensa, it is converged through the ossicular system into a smaller area of the footplate area. When the sound energy, the energy is converged, the waveform is converged onto a particular point, what happens to the force? It enormously increases. So the aerial ratio, it increases the sound energy or force at the inner ear level. How much it increases? 14 times it increases. How to remember this value? Usually, we divide tympanic membrane into how many quadrants? 4 quadrants. 1, 2, 3, 4. This is how we will divide the tympanic membrane. Obviously, remember the name 4. 1 tympanic membrane, 4 quadrants. So, obviously, 14 times it increases the force at the inner ear level. This is aerial ratio to remember. What is lever ratio? Lever. So, if you are given a lever like this, when the lever length shortens, we have to give more force to push the stone away. If you are given a good lengthy lever, a little force is enough. But if you are a shorter lever, we have to give more force to push the stone away. So as the lever length decreases, the force increases. So the malleus, we have this long handle, and incus we have this long process which is shorter than the malleus. So as the lever length decreases, the force increases. That's all. That is the lever ratio 1.3:1. So it is based on the ossicular system. How many ossicles we have? 3 ossicles. Very simple. So the lever ratio is 1.3. So this is about the lever ratio. So to remember the number 3, remember 3 ossicles, number 3 is there. So combinedly we have 18 times the force is increased at the inner ear level to have a good hearing. That's all about this impedance matching mechanism MCQs. Now the sound has entered into the inner ear. What does it do? It will vibrate the basilar membrane. It passes through the oval window and comes out through the round window. So it vibrates the basilar membrane. There is an important MCQ at this point. A patient with damage to the basilar membrane presented with high frequency hearing loss. A patient has damage to the basilar membrane at some area. And on examination, he has high frequency hearing loss. Where is the location of most likely lesion? Modiolus, stria vascularis, helicotrauma, oval window. So in which region the basilar membrane injury is present? That's what the question. So based on what we have to assess, the only point which is given is the patient has high frequency hearing loss. So high frequency hearing loss and low frequency hearing loss are there. So if in which area of the basilar membrane injury, it will lead on to high frequency hearing loss? Basal turn. So basal turn of the basilar membrane is near to which part? Oval window. Helicotrauma, that is in the apical turn. The junction point of the scala vestibuli and the scala tympani is the helicotrauma. So that is the apical turn of the basilar membrane. The basal turn, the basal part of the basilar membrane is near the oval window. Why not modiolus? Why not stria vascularis? See, this modiolus is present through the entire length of the cochlea, around which the cochlea is winding around. All the basal apical turn is present to the entire length of the modiolus. And stria vascularis, of course, it is present from the basal turn to the apical turn. So based on these two anatomical structures, we cannot say which is basal turn, which is apical turn. So either oval window or round window, it is near the basal turn, and helicotrauma is in the apical turn. So since the patient is having high frequency hearing loss, the answer here is oval window. So few points regarding this traveling wave theory of von Bekesi. What does it say actually? See, if you unwind the cochlea like this, we have the basal turn and the apical turn. It's like a tail, you remember. The basal turn is bigger and the tail end is smaller, apical turn. Imagine like this. So when a sound enters, any sound, when it enters into the inner ear, not all the frequencies, we have the low frequencies and high frequencies. See, very simple. Frequency is nothing but the nature of the sound. In a guitar, if you strike one string, it will be sounding like doing like this. Otherwise, if you strike another string at the last string, it will be sounding like toing like this. So doing is a low frequency sound. Toing is a high frequency sound. So based on the frequency only, we will identify the nature of the sound. So that is very important. So frequency identification is very important for identifying what kind of sound we are hearing. So that's where the cochlear anatomy is very important here. Hence, not all the sound will vibrate the basilar membrane uniformly. The high frequency sound will vibrate the basal tone of the cochlea, and the low frequency sound waves will stimulate the apical tone of the cochlea. So our brain will recognize if the basal turn basilar membrane fibers are coming or excited, that means we are hearing a high frequency sound. The apical turn is fibers are excited, that means we are hearing a low frequency sound. This is how the brain will hear the sounds. So this is what a simple thing. So easy to remember, basal turn is bigger. So high frequency sound, it is not that easily, it is basically based on the thickness and the width of the basilar membrane. Again, there is no need to dig deep into all the physiologies here. we need to remember and to mark the MCQs. So easy to remember, a mnemonic like thing. The basal turn is bigger, so the high frequency sound will hit the basal turn. The apical turn is smaller, so the low frequency sound will hit the apical turn. That's all. So, if the patient is having high frequency hearing loss, where is the pathology? Basal turn is a pathology. Where is the basal turn? Which is near the oval window and the round window. Very simple. When the patient is having a low frequency hearing loss, where is the pathology? The apical turn is a pathology. What is the part of apical turn? This arrow mark, see, the continuity of the scala vestibula and scala tympani. Helicotrema is the apical turn. That's all. So this is all about the traveling wave theory of von Beckersey. So based on which, whether a high frequency or low frequency, in which area it is hitting, it depends. Okay. So what is the need to understand what frequency hearing loss the patient is having? I tell you at this point one more MCQ. Most of the cochlear hearing losses starts from the basal turn. Outer hair cell degeneration starts from the basal turn, and that will proceed to the distal apical turn. Proximally to the distally it will proceed usually. So presbyocusis, ototoxicity, noise-induced hearing loss, all those things will start as a high-frequency hearing loss and then involve the low frequencies. Except one disease, very important, please know this, Meniere's disease. In Meniere's disease, the disease starts in the distal part of the cochlea because Meniere's is endolymphatic hydrops, increased volume. When the endolymphatic sac is obstructed, the distal part of the cochlea where accumulation initially happens, the endolymphatic stasis initially happens, very simple. So the apical turn of the cochlea where the stasis happens, and hence the patient initially presents as low frequency hearing loss, and then gradually the high frequencies are involved. So please remember this MCQ. In Meniere's disease, the initial frequency loss will be low frequency hearing loss. But in all other cochlear diseases, the initially frequency loss is high frequency hearing loss. This difference is quite important in marking the MCQs. So you will be getting the MCQs from this area. Okay. So transduction, the mechanical energy is converted into the electrical energy. Once the basilar membrane vibrates, the hair cells moves and depolarization occurs. So we know the endocochlear potential, the scala media contains more potassium. That is how much current it has, plus 80 millivolts. That is one MCQ, simple MCQ. That potassium enters into the hair cells, that causing depolarization of the hair cell. So the hair cell is depolarized by the potassium influx. Through which channels the potassium enters into the hair cells? MET channels, mechano-electrical transduction channels. Very simple to remember. Mechano-electrical transduction channels. See, mechanical energy is converted into electrical energy. That process is called transduction. So MET channels is nothing but mechano-electrical transduction channels through which the potassium enters into the hair cells. And one more MCQ at this point is aminoglycoside toxicity. The first route of entry into the hair cell system, through which route the aminoglycosides enter into the hair cells for destroying it. MET channels is the answer. Mechano-electrical transduction channels is the answer. Okay. So this is about this transduction. And last, once the electrical impulse is generated, it passes through the auditory pathway to the brain. So what is auditory pathway? Very usually E. coli MA, eighth nerve, cochlear nucleus, superior olivary complex, lateral lemniscus, inferior colliculus, medial geniculate body, auditory cortex. Which is auditory cortex? Superior temporal gyrus is the auditory cortex. Broadman's area 41 is that area. And there are a few points to note, and one MCQ is trapezoid body is a body present in the auditory cortex. What is the role of trapezoid body? It is where the crossing over of the fibers, decussation of the fibers happens. See, from the right it goes to the opposite side, and from the left it goes to the opposite side. From the cochlear nucleus goes to the superior olivary complex by decussating, crossing over, and hence we can easily localize ipsilateral and contralateral impulses are going in either way. Hence localization is very the person is able to do by this crossing over of the fibers. And hence the MCQ is, localization of the sound happens from which part of the auditory pathway? Superior olivary complex. Please remember, see again I tell you, eighth nerve, cochlear nucleus, and then the superior olivary complex. So in between this area only, at the level of cochlear nucleus only, the trapezoid body present in the brainstem pons area, and from there it goes to the superior olivary complex. So from the superior olivary complex, this localization is possible. Okay. Appreciation of the sound happens in which area? Only in the cortex. Only the impulse should reach the cortex. Then only we can appreciate a sound, any sound. So appreciation happens in cortex. Second MCQ. Frequency identification of a sound happens from which area? From the cochlea itself. So cochlea itself is a tonotopic center. It identifies the kind of frequency, whether we are hearing a high frequency or low frequency based on the traveling wave theory. So frequency identification happens from the cochlea itself. Coming to the vestibular physiology, the semicircular canals, utricle and saccule, what are all the things to note here? Horizontal semicircular canal response to. We have this utricle, saccule, three semicircular canals, horizontal and superior and posterior semicircular canals. So these are the three semicircular canals we have. So horizontal semicircular canal responds to horizontal acceleration, rotational acceleration, gravity, anteroposterior acceleration. So the horizontal, if you see this term horizontal, don't jump into horizontal acceleration. It is not so. All the semicircular canals, whether it is horizontal or a vertical, it will respond to a rotatory acceleration. A rotatory movement, that is very angular movement or rotatory movement. So answer is rotational acceleration, very important. So this is the important thing to note. Don't jump directly into the horizontal. Okay. So the answer for this horizontal semicircular canal responds to which movement of the head? Rotational acceleration. Okay. What are the points to note here is vestibular physiology. So what are the basic function of the vestibular apparatus? Very simple. Based on any movement of the body, it tries to maintain our balance. It maintains the balance of the torso and it maintains the gaze stabilization. If the gaze is stabilized, our vision is stabilized or fixed, we can maintain our balance. If the vision is moving here and there like that, we cannot fix or maintain our balance. So these are the typical function. Based on any movement of our body and head, our body is maintained its balance. So we have this utricle and saccule and semicircular canals. The end organs in the semicircular canals are called cristae. C in canals. So C for C, cristae in semicircular canals, and that will respond to any of your angular rotation, the head movement, horizontal movement, or the vertical movement, or the this kind of movement of the head. Any of your angular rotation will stimulate the cristae of the semicircular canals. Any of the linear movements will stimulate utricle and saccule, and that is called maculae. The end organs in the utricle and saccule are called maculae. So we have two linear movements, horizontal linear movement and a vertical linear movement. As if you are traveling a bus or train is a horizontal linear movement. And if you are traveling in a lift, it is called, or falling from height, it is called vertical linear movement. So these two movements, which movements stimulate which maculae? So easy to remember again. See, we have the utricle and a saccule. So make a lazy U. U is like this. If you make a lazy U, it will be in the orientation of the horizontal string. Horizontal string. So the horizontal movement will stimulate the utricular maculae, and the saccule, make a lazy S. This is the way we can make a lazy S. So the lazy S is in the vertical orientation. So your vertical movement will stimulate the saccular maculae. So remember in this way, easy to remember. So utricular maculae gets stimulated by the horizontal movement, and the saccular maculae will get stimulated by the vertical movement. So these are all so any movement will stimulate the vestibular apparatus. And this vestibular apparatus in turn has efferents to the oculi muscle, cerebellum and spinal muscles to maintain the balance. So we have two reflexes mainly, vestibulo-ocular reflex, vestibulospinal reflex. So vestibulospinal reflex maintain the balance of the torso, and vestibulo-ocular reflex maintains your gaze stabilization. Whatever the movement your head is happening unconsciously, our gaze is stabilized so that our body and head is stabilized. This is quite important. Okay. In this cristae and maculae, there are specific, like our tectorial membrane, we have a membrane over this hair cell system. And one specific membrane is called otoconial membrane, which is present in the maculae of the utricle and the saccule. This otoconial membrane, the important MCQ is, they will be asking, it is made up of calcium carbonate crystals. That's quite importantly they will be asking. So the otoconial membrane is made up of calcium carbonate crystals. And what is this importance of this otoconial membrane? Sometimes this calcium carbonate crystals from the utricle may get accidentally dislodged into the semicircular canals, and that will stimulate the semicircular canals in a false manner, and that is called BPPV. That disease is called BPPV. So the otoconial membrane displacement is called BPPV, the disease. Coming to the next question based on the physiology of the semicircular canals, left side lateral semicircular canal excitation causes. Left side lateral or horizontal semicircular canal excitation causes. I told you this semicircular canal movements, whatever the head moves, our vision should be stabilized. That is called vestibulo-ocular reflex. So whatever the canals are stimulated, there will be a corresponding eyeball movement to maintain the gaze stabilization. So through which cranial nerves the eyeball movements are stabilized in lateral semicircular canal stimulation or a horizontal semicircular canal stimulation. That is a point to note here. So the left side lateral semicircular canal stimulation causes the eyeball will be moving to the opposite side. This is the simple physiology, I tell you. So the answer here is ipsilateral medial rectus and contralateral lateral rectus. So left third nerve and right sixth nerve are the movement happening for the eyeballs. For the left lateral semicircular canal, if it is stimulated, our eyeball will be moving to the opposite side. So ipsilateral third and contralateral sixth nerve, left third and right sixth nerve are stimulated, and hence the eyeball will be moving to the opposite side. So this is the basic physiology of the vestibulo-ocular reflex. So how the vestibule maintains the balance? Vestibulo-ocular reflex and vestibulospinal reflex. Sure. What is this vestibulo-ocular reflex? It is nothing but doll's eye reflex. See, you would have seen a moving eyeball doll. When the doll is rotated like this, the eyeball will be moving to the opposite side. When the doll's head is rotated like this, the eyeball is moving to the opposite side. So this is a simple mechanism. So the vestibular physiology can be understood based on the horizontal canal stimulation. See, whatever the head is moving, even unconsciously, our eyeball moves in the opposite direction to maintain the gaze stabilization. In other ways, remember this one-liner for your clear understanding. Each vestibule pushes the eyeball to the opposite side is the physiology. That's all. That's all the physiology. See, if there is a point in front of you, if I want to stabilize my vision on that point, if my head rotates to the right side, my eyeball should be moving opposite to the direction of the head. If my head is moving to the left side, eyeball moves in the right side direction to fix the object. So this is the basic physiology. In other ways, why on moving my right head to the right side, which canal is stimulated? This is based on Eval's law. Again, no digging deeper into physiology, very simply to understand, it's based on the endolymphatic movements inside the canal. Right movement of the head causes stimulation of the right canal, right horizontal canal. My left movement of the head in the horizontal plane causes left canal stimulation. If I move my head in the vertical directions or like this in the vertical directions, either the superior canal or the posterior canals are stimulated. So the lateral canal is called horizontal canal, The superior and the posterior canals are called vertical canals, very simply. So very simply, moving the head to the right, right canal gets stimulated. Moving the head to the left, left canal is getting stimulated. So on moving the head to the right, right canal is stimulated. What happens to the eyeball? Moves in the opposite direction. So very simply, if my right canal is stimulated, if my right vestibular apparatus is stimulated, it moves the eyeball, it pushes the eyeball to the opposite side. That's all the physiology. This one point, please remember. If the right vestibular apparatus is stimulated, eyeball moves to the opposite side. If my left vestibular apparatus is stimulated, eyeball moves to the opposite side. So this is the physiology of the vestibular apparatus to maintain the gaze stabilization. That's why on moving your head on either side, I am able to fix the eyeball in the midline to watch at the center. So this is called vestibulo-ocular reflex, intact brainstem reflex. This is a very important doll's eye reflex. So this is about this vestibular apparatus physiology to understand. If this vestibular ocular reflex is not functioning, if the brainstem is not functioning as the brainstem dead people, the eyeball, even if you move your head, the eyeball move along with your head. It will not move in an opposite direction. That is called doll's eye reflex absent. So this is the important vestibulo-ocular reflex, and this vestibulo-ocular reflex is happening through MLF, medial longitudinal fasciculus. This is another MCQ. The vestibulo, from the vestibule to the ocular muscles, the pathway is medial longitudinal fasciculus. Okay. Tabular column. What is the tabular column? What happens if the lateral or horizontal semicircular canals are stimulated? Ipsilateral medial rectus, contralateral lateral rectus. Very simple. If my right is activated, see my right turning to the right, right is activated, eyeballs move to the opposite side. So ipsilateral medial rectus, contralateral lateral rectus is activated, so that the eyeball moves in opposite direction to fix the gaze. That's all. So for the superior canal and vertical canal, there is no need to mug up. Only understanding one simple point I tell you. When the vertical canals are stimulated, ipsilateral rectus and contralateral oblique, or other way, simply recti and oblique are activated. If the recti and oblique are activated, I tell you, whenever there is horizontal movement of the head, the horizontal canal and the horizontal movement of the eyeballs will be happening. When the vertical canals are stimulated, the eyeball movement will be in the vertical direction. It is not a simply vertical, it is vertical torsional. Vertical torsional. This is very important. Why it is vertical torsional? Both recti and oblique are stimulated. That's why it is not a pure vertical, it is vertical torsional. It moves and rotates. It moves and rotates. This is called vertical torsional movement of the eyeballs. So for the horizontal canals, horizontal movement of the eyeball happens. If the vertical canals are stimulated, vertical torsional movement of the eyeball happens. This is used in the pathology. Simply, if the horizontal canal is diseased, horizontal nystagmus will happen. If the vertical canals are diseased, it is not a vertical nystagmus. Please remember this point. It is vertical torsional nystagmus. This is a quite important MCQ will be asking. If you encounter a patient with a pure vertical nystagmus, that means you are dealing with a central pathology. Some intracranial pathology is present for the patient. Please remember this point. So any patient having a pure vertical nystagmus, look for intracranial pathology. If it is a peripheral disease like a vertical canal disease, the nystagmus will be vertical torsional nystagmus, not a pure vertical nystagmus. This is a point to note here. That's all. So if you want, come back to that MCQ. Left side lateral semicircular canal excitation causes. Left side lateral semicircular canal excitation causes my eyeballs moving to the opposite side. So left third nerve and right sixth nerve are been induced, excited. So that is the answer for this question. Left oculomotor and right sixth nerve, abduction nerve are been triggered. So this is a basic physiology. Each vestibule pushes the eyeball to the opposite side. Please remember that is one take home message, because many times in this area we may make mistakes. So each vestibular apparatus pushes the eyeball to the opposite side. Right vestibular pushes eyeball to the left side. left vestibular system, it pushes eyeball to the right side. So that only our gaze is fixed. Okay. Coming to the hearing assessment, which is quite a fond area for the examiners. What are all the areas? What are the points to note? Rinne's test starts with the tuning fork test and then move into the audiometry and then impedance audiometry and then the objective test like our OAE and BAER. These are all the areas we will be covering. Okay. Positive Rinne test is seen in otosclerosis, CSOM, impacted wax, presbyocusis. So in which condition positive Rinne's test is seen? Two conditions, normal hearing and in sensorineural hearing loss, the Rinne's test will be positive. Otosclerosis is conductive, CSOM is conductive, impacted wax is conductive. So the answer is presbyocusis. So it is not a true positive, of course. Rinne test will be reduced positive in sensorineural hearing loss. But the question they will give you to confuse you. So positive Rinne test is seen in presbyocusis. Next question. In a patient, Rinne test positive in both ears. Okay. Rinne test is positive in both ears. Okay. Weber is lateralized to the right ear. Very important. Okay, right ear. What does this signify? What does this signify? So this is very, very important. Very simple to answer. I told you, Rinne positive. Either it should be normal hearing or a sensorineural hearing loss. Okay. In the question, in answer, we have the right sensorineural, left sensorineural, right conductive, left conductive. Normal hearing is not given. Okay. Conductive deafness is there. Simply, if the Rinne's is positive, it cannot be conductive deafness. Rule out this conductive deafness. Simple. First, we are ruling out two options very easily, either right or left. So, Weber is lateralized to the right side. If the Weber is lateralized to the right side, only we have the two options, sensorineural hearing loss, right or left sensorineural hearing loss. If the Weber is lateralized to the opposite side, the sensorineural hearing loss will be on the other side. So obviously it is left sensorineural hearing loss, deafness. So again we will clarify this in the Weber's test, don't worry. So this is about the answer for this question. See, if the Weber is lateralized to the both sides or Weber is centralized, it is equally heard on both sides, then only it is a normal hearing. But here, even though Rinne is positive on both sides, Weber is lateralized to one side only. So obviously some pathology is present, either a normal hearing or a sensorineural hearing loss. Since this Weber is lateralized to right ear, it is a left-sided sensorineural hearing loss. That's all. So points regarding this Rinne's test. We have this 4 inferences. Like in any test, positive Rinne, negative Rinne, false positive test, false negative test. One small correction here. There is no false positive Rinne. It is reduced positive Rinne. Please remember, in Rinne, reduced positive. There is no false positive. That is a point here to note. So positive, negative, reduced positive and false negative Rinne. And the first column, so very simple, either the air conduction is better or bone conduction is better for the patient. Again the same thing, air conduction is better, bone conduction is better for the patient. So positive negative is very clear. Air conduction is better than bone conduction, normal hearing. Bone conduction is better than air conduction. Of course, there is some block in the conductive apparatus, conductive hearing loss. Air conduction is better than bone conduction, but both are reduced. Air conduction, bone conduction, both are reduced. The patient will tell you, sir, I am hearing air conduction better than bone conduction, but both are less heard than my opposite side. So simply reduced positive. Positive, but that is reduced. So it is called sensorineural hearing loss. And the last variety, very typical variety of Rinne's test, if I am having a complete deafness of this ear, my bone conduction will be carried on to the opposite side of the skull, to the opposite side of the ear. So the person will hear the bone conduction. But air conduction, no, it is totally deaf. So it cannot be conducted through the conductive apparatus. So in last variety, the false negative, see, the patient will tell you bone conduction, yes sir, I am hearing, but how he is hearing? Through the opposite ear, but he will not aware of that. He will tell you, sir, I am hearing the sound. So bone conduction is better, but air conduction is not present. So bone conduction is heard but not the air conduction. Bone conduction better than the air conduction. So we will mark it as a negative actually, thinking, oh, he's having some conductive hearing loss. Not so. It is not a true negative, it is false negative due to the opposite transmission to the ear. So that will happen in a profound deafness or a total deafness. Very, very important. Total deafness on one side. So this are the 4 inferences. So with the Rene, what are the points here? There are some fallacies. It is little confusing us. Simply remember normal hearing, conductive hearing loss, SN hearing loss, total deafness in the last column. Normal hearing, conductive hearing loss, SN hearing loss, and the total deafness. So these are all the points to note here. So this is about this Rene. Okay. Okay guys, sorry for the break. Let us continue with this Rene test. Okay. See, we have this normal hearing, conductive hearing loss, sensorineural hearing loss, and total deafness as the inferences. Okay. So the question sometimes will tell you only the positive Rene, or the patient is telling us negative Rene. What all the inferences we can take from that point? If the patient has positive Rene, either the patient is having normal hearing or the patient is having sensorineural hearing loss, positive or reduced positive. The point here is it cannot be conductive hearing loss. That is very, very important. If the patient has a positive in the question, the patient cannot be having conductive hearing loss. This is a very important point you have to know. If the patient has negative Rene, but here is a problem for us. Either the patient is having a true negative, which is a conductive hearing loss, or the patient can have a false negative, in which condition total SN hearing loss or a profound SN hearing loss. See, total deafness means itself that is SN hearing loss. So it can be a sensorineural hearing loss. So negative Rene, it can be either a conductive hearing loss or a sensorineural hearing loss. But a positive Rene, the patient cannot be having a conductive hearing loss. So these two understandings of the positive and negative Rene is important. Okay, coming to the VBUS. VBUS MCQ point, the most sensitive test is VBUR. The most sensitive tuning fork test MCQ point is VBUS test. Even a 5 decibel difference of 2 years can be identified by the VBUS. So two situations we have to test whether the patient is having normal hearing, conductive or sensorineural. If the patient is having normal hearing, on placing the VBUS on any midline prominence, the patient will hear the tone equally on both sides. That is VBUR in normal hearing patient, or equal conductive deafness or equal SN hearing loss. There is no difference between 2 years. Okay. If the patient, two scenarios coming to you complaining of right-sided hearing loss. First patient coming to you with right-sided hearing loss. On doing the VBUS, our job is to identify what is the pathology in the right ear for the patient. That is our job, the ENT surgeon's job. So VBUR is lateralized to the right side itself. If the VBUR is lateralized to the right side itself, what is the pathology in the right ear? Conductive hearing loss. Very simple. So very simply you can mimic this. If you close your meatus like this, it is mimicking conductive hearing loss on my right side. If I am closing the meatus, I am mimicking conductive hearing loss. On telling 1, 2, 3 or something, my name is Praveen Kumar or something like that, the sound is well augmented in the conductive deaf ear itself. That's why in VBUS, bone conduction sound, the patient is having conductive deafness that is well heard in the deaf ear itself. The simple logic is it is cutting off all the surrounding noises, the conductive apparatus, and the bone conduction is well augmented. Our speech is also a bone conducted sound, so it is well augmented. So that is why VBUS is lateralized to the deaf ear itself in case of conductive hearing loss. You can do this even the exam hall. No wrong in this. Just mimic as if you are having conductive deaf ear and tell something 1, 2, 3. You will hear better in the deaf ear itself. So when the VBUS is lateralized to the deaf ear itself, what pathology the patient is having? Conductive hearing loss. Very simple. In another case, another scenario, a patient is coming to you complaining again right ear hearing loss. If in this case, if the VBUR is lateralized to the left ear, that is normal hearing, then what is the pathology in the right ear? SN hearing loss. In this patient, the VBUR will be lateralized to the opposite ear, normal ear, in a sensorineural hearing loss. So this is the two important scenarios we have to understand. That is what the question is again. In a patient, Rinase is positive in both ears, but VBUR is lateralized to the right ear. So with the first point, Rinase is positive in both ears, we are getting to the point either a normal hearing or a sensorineural hearing loss. So normal hearing is not in the option. Again, the conductive deafness we are ruling out. VBUR is lateralized to the right ear. Obviously, the sensorineural hearing loss will be on the opposite side, left side. So the answer is left-sided sensorineural deafness for this patient. So this is the answer for this question. A similar tuning fork test in case of a conductive deafness or a otosclerosis, Bing's test and Gillis test. There is a test. In Bing's test, on alternately compressing and relaxing the tragus, the sound increases and decreases for the patient. This indicates. So in which condition the sound increases and decreases, and in which condition there is no difference in intensity of the sound by the patient. So in a case of conductive deafness, there is no difference in intensity. But in a case of normal hearing and the sensorineural hearing loss, there will be increase and decrease in the sound intensity. So this indicates sensorineural deafness, adhesive otitis media, otosclerosis, CSIM. All the three things are conductive deafness where there should not be any change in intensity. So answer is sensorineural deafness. So what is Bing's test or a Gillies test? Gillies is used by seagulls is used to do Gillies, and tragal occlusion is done in Bing's test. So mostly both are a simple same kind of test, and tuning fork is placed over the mastoid bone conduction. So on compressing and relaxing the tragus, again do the same maneuver in the example if you want. Say 1, 1, 1, 1. Compressing and relaxing, the sound increases and decreases. So either a normal hearing or a sensorineural deafness will have this change in intensity. Imagine if I am already having a compressed or jammed conductive apparatus. Your maneuver of compressing and relaxing will not do any change because already there is a compressed jammed conductive apparatus. So the patient will not feel any change on your maneuver. So there is no change in intensity. The patient is suffering from conductive deafness. So this is called bingo. That is, bingo is positive in normal persons and sensorineural deafness. That is, change in intensity will be present, and it is negative in otosclerosis or other conductive deafness patients. So that's where the mnemonic I have given. Bing's test in otosclerosis, no. Bingo, bingo, is it healthy or not? It is not healthy. So no to bingo. So that is a mnemonic here. Bing's in otosclerosis, bingo. Bing's in otosclerosis, in conductive deafness, there is no change in intensity. Negative, N for negative again, or no change in intensity of the sound. So remember this mnemonic. Bing's in otosclerosis, no change in intensity, negative bingo. Negative Bing's test is seen in otosclerosis. So this is the answer. Coming to the audiogram. Yes, the symbols are quite commonly asked in audiogram. In pure tone audiogram, the symbol X is used to mark air conduction right ear, air conduction left ear, bone conduction right ear, bone conduction left ear. Answer is, so air conduction in the left ear. So we need to remember the symbols. I tell you what. Okay. What would be the tuning fork test finding in this patient whose PTA is given? What would be the tuning fork test finding in this patient whose pure tone audiometry is given? See, two curves are present in pure tone audiometry. First, we need to know what are the two curves basically. So obviously, we need to know the symbols. Again, see, round is given here and into mark, cross mark is given. So obviously, the superior line is the air conduction left ear, and the inferior line is the air conduction right ear. So two air conduction sounds are curves are given. Which is not given? Bone conduction curves has not been given. Simply the bone conduction curves are to be taken as normal, in the normal range. So in the normal range. So separately for ears, please assess. Please take a little time here. Don't get confused. Separately for the ears, please assess. Let us assess for the left ear first. So forget this line here now. This line, please forget. Imagine in the left ear, the bone conduction like this will be in the normal range. That's what it's been assumed. So for the left ear, the bone conduction sound and the air conduction sound are both more or less in the normal range, that is within the 25 decibel range. So left ear is more or less normal hearing for the patient. That's all over. Okay. Come to the right. Now please forget this line. Assume the right ear now. For the right ear, bone conduction is somewhere here in the normal range. But what happened to the air conduction curve? It is been fallen down. The threshold is increased. That's the point. So a huge airborne gap is present for the patient. So the air conduction has fallen down. So in which condition there is an airborne gap is present? Obviously, it is in the conductive deafness. So the answer for this PTA is basically right conductive hearing loss for the patient. So if it is a right conductive hearing loss for the patient, what will be the tuning fork test? Don't look at the options in this way, in these conditions. You very well know. In the right conductive hearing loss, what happens to the Rinne? Rinne will be negative. What happens to the Weber? Weber will be lateralized to the right ear. So the option is right ear Rinne is negative and Weber lateralized to the right side. So first think the answer and then go into the question options. So there is no way of logical answering here unless otherwise you know the points clearly. So this is about this answer for this question. Answer is D. So regarding the Pewton audiogram, we very well know the lines and symbols they are asking. The red line is used for the right ear markings and blue or black line is for the left ear markings. And for the air conduction, a continuous line is been used. So air is universally present everywhere, continuously present everywhere. So continuous line is for air conduction. The bones are having multiple joints. So the jointed line, multiple joints are there in the bones. So jointed line is for the bone conduction. Okay. If you do not have this clarification right, the red color or black color or the jointed line or the continuous line, symbols or the other things where we have to clearly assess. So many times you will be given only the symbols, not the color codings or the jointed lines. So what are the symbols we have to use? Again, very easy to remember. I tell you, see, we have masked audiometry and unmasked audiometry to prevent that cross transmission of the sound signals. Okay, for the bone conduction sound, the symbols are like this. Bone conduction, B for B. See, for the bone conduction unmasked audiometry, right beak and the left beak is being used. Right beak and left beak. And for the masked audiometry, the symbol is right box bracket and left box bracket is used. So right beak, left beak, right box bracket and left box bracket are being used for the bone conduction. That's all. So B for B. So the bone conduction symbols are quite easy to remember. Separately remember that. Then only we can easily remember the air conduction curves. So for the bone conduction curves, remember this B for beaks and brackets. Beaks and brackets for the bone conduction symbols. Okay, bone conduction curve symbols. For the air conduction, now the point comes here. We need to set a mnemonics to remember. What are the mnemonics I'm using? So for the air conduction unmasked, round is the for the right ear, into mark, into is left out symbol. So left out is for the left ear, left out symbol for the left ear. Right ear round, R for R, round is for the right ear. And masked audiometry, what is the symbol they are using? Triangle for the right ear, square or rectangle for the left ear. A box, a triangle or the square is for the left ear they are using. So these are all the symbols for the air conduction. So there is a mnemonic I used to say. For the right ear, if you remember for the air conduction, left ear symbols we can easily remember. So remember, bone conduction symbols are quite easy. Right beak, left beak, right box bracket, left box bracket. Quite easy to remember and separately we can remember. For the air conduction, we need some mnemonic. For the right ear, what is the color you are using? Red color. For the air conduction symbol, we need this mnemonic. So what is the symbol for the right ear air conduction? Round. For unmasking. Audiometry technique unmasked, round. So we got R, triple R. So triple R, join the triple R, we get the symbol called triangle. Again the triangle is for the right ear with masked. Right ear with masked. So if you remember for the right ear symbols, The left ear symbol is easy to remember. That's all. So with this mnemonic of the pictorial mnemonic, we can easily remember. For the right ear, red color is used, round is the symbol, and then triangle is the symbol for the masked audiometry. And obviously the into mark is for the left ear, square is for the left ear. That's all. These are the two symbols left out, easily remembered. Sure. Okay. So this is about the symbols for the audiometry. How the audiometry charts will look like in case of each hearing. So whenever both the curves are within 25 decibels, that is a normal range of hearing, 25 decibels. So that is called a normal hearing. When the bone conduction is normal, but the air conduction has fallen down. Please disclaimer, the symbols used here are not right symbols. It is just from the Google Pics, just for the orientation, how the curves will be in case of each hearing losses. That's all. So the bone conduction is better than air conduction, and there is an airborne gap is present. And how much airborne gap is significant? 1.5 box, that is 15 decibel difference should be there between the bone conduction and air conduction to say that is conductive hearing loss. So that is the important thing. And in the third picture, both the air conduction and bone conduction has fallen down. Air conduction is better than bone conduction, but both has reduced. Reduced positive RNA is seen in sensorineural hearing loss. And in the case of mixed deafness, both these criteria should be used here. See, both the curves has fallen down, air conduction and bone conduction, both the curves has fallen down, and also the air-bone gap is also present. So it is called a mixed deafness. So this is about the audiometry charts in various hearing losses. So there are certain typical audiometry charts in atypical diseases where we need to know. So what are all the audiometry charts? If you find a dip in the bone conduction curve at the 2000 Hertz, this is called Kerhart's notch, which is seen in otosclerosis. 2000 Hertz is the resonant frequency for the ossicles. In otosclerosis, tape is fixed, ossicle is fixed. Hence, at the resonant frequency, there is a dip in the bone conduction curve. So, this is Kerhart's notch, 2000 Hertz dip in bone conduction curve. Right, again, sorry. Both the curves, there is a dip in the 4000 Hertz. This is called noise-induced hearing loss. Very typical. In a noise-induced hearing loss, boiler's dip, they will say. Due to the trauma, there will be a dip in the 4000 Hertz in case of both air conduction and bone conduction curves. This is noise-induced hearing loss. A cookie bite audiometry or a trough-shaped audiometry where the mid-frequency loss will be present is seen in congenital SN hearing losses. Commonly, not always, commonly. Congenital SN hearing loss. And the last thing, Meatus is very, very important. Please note down the Meatus disease. See, I told you in the Meatus disease, basal turn and apical turn. In Meatus disease, the apical turn, the stasis of endolimb happens in the initial period. Which frequency will be lost in the apical turn disease? Low frequency hearing loss. And hence, the early frequency loss in Meatus disease is, see, these are all the low frequencies, these are all the high frequency sounds. So, low frequency are affected first in the Meatus. The threshold is increased, those curve is has fallen down, and high frequencies will be normal. So low frequency hearing loss, or otherwise called as upsloping audiogram. Upsloping audiogram is an early audiogram in a Meatus disease. This is quite often asked question. Please remember, upsloping audiogram. Okay. What happens in the second stage? Both the low frequencies and high frequencies will be affected, and in the end all the frequencies will be affected, and hence this is called inverted V-shaped audiometry. Inverted V-shaped audiogram is seen in the next stage of Meatus disease. So initially low frequency audiometry, hearing loss, that is upsloping audiometry, and then inverted V-shaped audiometry are seen in Meatus disease. In contrary, in presbyacusis, ototoxicity, noise-induced hearing loss, I told you, the high frequencies are affected first. The low frequencies will be normal because the basal turn will be affected first and then the apical turn, and hence the high frequency curve has fallen down and the low frequencies is within the normal range, and this is called downsloping audiometry. This is called downsloping audiometry. So upsloping audiometry is seen in Meniere's disease and downsloping audiometry is seen in the presbycusis, ototoxicity, noise-induced hearing loss, all kinds of regular cochlear hearing losses. Please remember this, okay? Simply these points. Any patient coming to you with a very simply bilateral symmetrical high frequency SN hearing loss. It may be a presbycusis, ototoxicity or noise induced hearing loss commonly. Unilateral low frequency SN hearing loss. Meniere's disease usually starts unilaterally and then only it goes into the bilateral disease. So unilateral low frequency SN hearing loss. Always think about Meniere's disease. Again, the next point, any elderly man, if it is a presbyocusis, it will be having a bilateral symmetrical loss. But if an elderly man coming to you with unilateral high frequency SN hearing loss, see this first point, it is bilateral high frequency SN hearing loss, usual forms of hearing losses. But any elderly man coming to you with the unilateral high frequency hearing loss, SN hearing loss, you must to rule out vestibular schwannoma, very important. So these three things, please have a look, have a good understanding about this so that you can easily answer the questions in the MCQs. So low frequency, high frequency, there is no big confusion based on which we can easily answer the questions. So this is about this three kinds of this hearing losses. Coming to the next is impedance audiometry or tympanometry. So this is about impedance audiometry. A middle-aged male comes with hard of hearing. Impedance audiogram was done for him, which is false statement regarding this tympanogram. So basically, what is the type of curve we have to know? So this is the normal box. This is the volume of the middle ear, and this is the pressure range. X-axis is the pressure range and the y-axis is the volume of the middle ear. So a normal curve should be well within this box, that is the A curve. If the curve goes below this box or goes above this box or goes away this box, these are all the abnormal curves, very simply. So in this, obviously the curve is below the box. The curve is below the box. So what is this curve? This is AS curve. In otosclerosis or conductive deafness, when the compliance of the middle ear is decreased, AS curve, any kind of ossicular fixity, AS curve will be present. So which is false statement regarding this tympanogram? It is subjective test of middle ear function. A itself is false. It is not a subjective test, it is an objective test of middle ear function. We need not get any cooperation from the patient. We just keep a probe here and the patient will need not tell anything, it will automatically create a graph. So it is an objective test, it is not a subjective test. Compliance is diminished. Yes, AS curve, the compliance of the middle ear is diminished. It is not conducting the sound waves properly. Middle ear pressure in normal limits. Yes, of course, only when the curve is in the negative range only, the middle ear pressure is decreased. It is in the normal range, of course. The peak of the curve, see, it is in the normal range. Stapedial reflex may be absent. Yes, in otosclerosis, stapedial reflex will be absent. So stapedial reflex most probably absent in the AS curve. So these are all about this tympanometry. So identify the curve first and then go for the answer. The answer is A. It is not a subjective test, it is an objective test. Impedance audiometry or tympanometry, as I told you, just keep a probe and it will make a pressure difference and gives a tone, and reflection is assessed, and hence the fixity or the compliancy of the middle ear has been assessed. So these are called Jager's curves, and the normal middle ear volume is around 1 ml. Simply remember, around 1 ml is the middle ear volume, and the pressure is minus 100 millimeter of water to plus 50 millimeter of water, and the tone is raised 220 hertz. What are all the curves here? The green curve is A curve. It is a normal curve. and yellow is the AS curve, that is a reduced compliance in any otosclerosis or tympanosclerosis or any ossicular fixity. It is present. AD, the compliance is indefinite or increased compliance in case of ossicular dislocation. D for dislocation, ossicular dislocation due to trauma. So one part of the ossicle will be vibrating very commonly, very normally, and that even though it is vibrating very normally, that is not transferred to the other side of the ossicles, other part of the ossicles. So the compliance is indefinite or high compliance will be present. And C curve, the curve is present in the negative side. So any negative pressure in the middle ear, eustachian tube blockage, eustachian catarrh is C curve. And very importantly, B curve, see the flat curve, the violet line, blue line, flat curve is present. Simply any fluid containing middle ear like acute otitis media, serous otitis media, or a perforation in the middle ear, CSOM, all these conditions will produce a flat curve. There is no change in pressure of the middle ear. So that is flat curve is present in any otitis media very simply. So that is B curve. So this is about the impedance audiometry. Coming to the stapedial reflex, acoustic reflex, few MCQs. This is a protective reflex against a loud sound. What they will do, a loud sound, how much loud? A 70 to 100 decibel sound is given, and afferent is the eighth nerve, and the reflex center is the superior olivary complex, and from there the sound waves impulses travels to the electrical impulse travels to the both facial nerve, ipsilateral and the contralateral facial nerve, and through the facial nerve it goes to the nerve to stapedius, pull the stapes, stop it vibrating so that the further loud sound will not enter into the inner ear to protect inner ear from the acoustic trauma. So this is about the stapedial reflex. The afferent is 8th nerve and the efferent is the 7th nerve. That's the important point. And the decibel, please note down 70 to 100 decibel. So the point is, if the 8th nerve itself is gone, what happens? Or if the in otosclerosis, the stapes itself is fixed, the sound itself is not transmitted into the stapes. So what happens? Both the reflexes will be absent. Both the reflexes, ipsilateral and contralateral. If the afferent function is lost, afferent transmission is lost, both ipsi and contra will be absent. Okay. But in case of facial nerve palsy, let us assume right facial nerve is not working. What happens to this stapedial reflex? Simply right-sided stapedial reflex will be absent. That's all. So it goes through the afferent. In this way, it will not work, but contralaterally it will go. So in case of right facial nerve palsy, right side reflex will be absent. In case of left side facial nerve palsy, left side reflex will be absent. That's all. So this is about the stapedial reflex in afferent pathway disease and efferent pathway disease. So this is about the stapedial reflex. Coming to this question, yeah, a clinical question. A PTA of an elderly male patient presents with left ear hard of hearing and tinnitus for 6 years, prolonged period. Left ear hard of hearing and tinnitus in an elderly male. Left ear has, that left ear has negative recruitment. What would be the probable diagnosis? So here they want to ask you what type of SN hearing loss the patient is having. In sensorineural hearing loss, there are two gross differences: cochlear SN hearing loss and retrocochlear SN hearing loss. So any disease that affects the cochlea, cochlear SN hearing loss, and retrocochlear, eighth nerve, brainstem, all the auditory apparent, auditory pathway, it is retrocochlear deafness. So what type of hearing loss in this man is having? So very clearly they have given 2 points. The patient is having a left-sided hearing loss and a tinnitus. Okay, and if you take that PTA is given for the patient, this is the right side based on the symbols, it's very clearly seen, and the left side symbols are very clearly seen. See, right side more or less in the superior part of the audiogram, very mild SN hearing loss is present, and on the left side there is a gross falling down of both the curves, air conduction, bone conduction. There is a severe SN hearing loss on the left side. So patient is basically having a left-sided severe SN hearing loss is patient. The patient, I tell you, this asymmetrical or unilateral sensorineural hearing loss in an elderly male, what should be the common disease, what you have to think. So we have to have certain special tests to differentiate between cochlear hearing loss and retrocochlear hearing loss. So the second point in the question is they are very clear. In the left ear, it has a negative recruitment. If the recruitment is positive, so that side, that is cochlear sensorineural hearing loss. If the recruitment is negative, that could be a retrocochlear sensorineural hearing loss. So what would be the probable diagnosis for this patient? So that we have to think the disease of retrocochlear side. So Meniere's disease, cochlear otosclerosis, vestibular schwannoma, presbyocusis. Of all the four things, vestibular schwannoma is a typical retrocochlear disease, retrocochlear deafness. All the other things, Meniere's, cochlear otosclerosis, presbyocusis are all cochlear diseases. So here the answer is C, vestibular schwannoma. So unilateral sensorineural hearing loss plus tinnitus, and the patient has very typically negative recruitment. And here the disease is retrocochlear deafness. So this is about the question answer for this question. So what are all the tests that differentiate between the cochlear and retrocochlear? First thing is these two things. Recruitment is present in cochlear, that is a loud sound will be more louder for the patient. A loud sound will irritate the patient. The less louder sound the patient will not hear, but if you give a louder sound, that will actually trigger the cochlea as if in a normal patient. So growing of loudness is present in cochlear deafness, recruitment is present, but in retrocochlear recruitment is absent. Tone decay, no tone decay in cochlear, but retrocochlear tone decay is present. What is tone decay? Simply retrocochlear deafness, a classical example is vestibular schwannoma compressing the eighth nerve. So the eighth nerve becomes fatigable, very fatigued now. So it cannot carry the impulse. So if you give a tone for 1 full minute, the patient cannot hear the tone for 1 full minute. The tone will decay within few seconds. This is called tone decaying in a fatigable nerve, that is seen in retrocochlear deafness. This is one difference. And third point is very important. Speech discrimination, understanding the speech is poor, of course, in cochlear deafness, but it is very poor in retrocochlear deafness. Rollover phenomenon is present in retrocochlear deafness. Please remember, speech discrimination is highly impaired in a retrocochlear deafness. So this is the differences between these two cochlear deafness. So in the speech discrimination score, this phonetically balanced test, like single syllable words are given, and we have to ask the patient to repeat the words, how many words he is repeating correctly. So in case of cochlear deafness, speech discrimination is low, of course, but in retrocochlear deafness, it is very, very low, very poor, and rollover phenomenon will be present. What is this? In last curve, see retrocochlear deafness, after it is very low, it reaches only 20 to 30% of the words the patient is able to repeat, only 20 to 30%. Even if you increase the intensity, the discrimination becomes very low. So even if you increase the intensity, the patient cannot repeat the words properly. This is called rollover phenomenon. Due to fatigability of the nerve, even though if you increase the decibel, the patient cannot repeat the sounds. So this is about the retrocochlear deafness. So this is very, very important about this differences. Speech discrimination score is very poor in retrocochlear deafness. That is very important. Coming to the OAE. So OAE is absent in a child. Okay. What would be the next investigation to be advised? Pure tone audiometry, speech audiometry, tympanometry, free field audiometry. Even if you have a next option like BERA, even if you add this BERA, A, B, C, D, E, what will be the right next investigation that we can order for the patient? See, if OAE is absent, simply OAE is a screening test. We may think the child is deaf. What is the usual next investigation we have to subject the patient to ABR? BERA is the usual test. If it is an adult patient, we have to do a pure tone audiometry. Or if the BERA is not available, ABR is not available, what else we can do means free field audiometry we can do. Free field audiometry is nothing but this audiometries, OAE, pure tone, impedance, BERA, all these things are done in a soundproof room. But in a open space, if the audiometry is done with the speakers, that is called a distraction technique or free field audiometry. So without any soundproof room, it is been done in a young children. So these are all the things we will do. But before going into any definitive test, we have to know whether the external meatus, tympanic membrane, middle ear are normal or not. So that is very, very important. Any child having negative or absent OAE, that is very important. So if the OAE is absent in a child, rule out middle ear infections. See, external meatus and tympanic membrane we can well see in the otoscopy or endoscopy. So normal meatus and normal tympanic membrane. How will you assess the tympanic middle ear impedance audiometry or tympanometry? So this is the investigation you have to do for the patient. That's the answer is C. So only if the middle ear is normal only, then only we can take this OAE as a reliable OAE. So this is about the answer for this question. So coming to that OAE, again I will tell you the point is this otoacoustic emissions are from outer hassles, few MCQ points, 3 times spontaneous OAE, transient evoked OAE and distortion product OAE. Transient evoked is the commonly test because we are evoking OAE by giving a tone. And inferences either it is pause or refer, we should not tell it as failed OAE because that it is not a definitive test, it is a screening test. Either the OAE is pause or a refer. Okay, if the OAE is refer, is coming as refer, what will you do? We have to do a tympanometry because from the external meatus a tone is given and it is going and triggering the outer hair cells in the cochlea, through which it goes through the external meatus, middle ear and cochlea. And from the cochlea outer hair cells, again the sound is transmitted to the middle ear, external meatus and to the microphone in the meatus. So when the external meatus and middle ear is normal only, the OHC outer hair cells are triggered by the tone given, then only it becomes reliable. So hence very importantly, in any OAE is refer OAE or absent OAE, we have to assess the middle ear function. If the middle ear function is normal only, then subject the patient to next investigation to confirm this like ABR or BERA. So tympanometry is the next investigation to be done in a case of OAE absent. Okay. The uses of OAE are, it is a screening test for the hearing units and it is used for early detection of high frequency hearing loss as in ototoxicity and noise induced hearing losses. It easily detects high frequency hearing loss, and the fallacy here is this point. A baby is having cochlear deafness. What happens to OAE? OAE will be absent because outer hair cells are not there, OAE is absent. Okay, it's very straight. But if a baby is having a retrocochlear deafness like absent eighth nerve, or in young adults or adolescents, bilateral acoustic neuroma, or any of these conditions, retrocochlear deafness, where cochlea is present normally. So OAE will be present in these deaf children even though they are deaf. In a retrocochlear hearing loss, OAE will be present, which may confuse you. So even OAE is present, but if you still have suspicious of the hearing loss, you have to subject the babies to the definitive test. Which is a definitive test? BERA is the definitive test. ABR, auditory brainstem reflex or brainstem evoked response audiometry is a definitive test. True about BERA findings in acoustic neuroma. With this, we'll stop and then we'll go for the lunch break, okay? With the last question. Latency of wave 5 is increased, latency of wave 1 is increased, no waves on BERA, latency of wave 5 is decreased in affected ear. In acoustic neuroma or vestibular sphenoma, what happens to the BERA? So, BERA, the latency of wave 5 is increased in the affected ear. Answer is A. How? A simple diagram, easy to understand, there is no big confusion of the BERA. I will tell you in an easier way. With before that, a little few points regarding the BERA. This is the investigation of choice for the deafness in infants and mentally retarded or malingerers, and it clearly identifies the retrocochlear pathologies in that pathway. So these are all the early latency waves are identified in the BERA. So it identifies the pathway till the midbrain level. Till the midbrain level, where is the pathology that can be identified with the BERA, and it BERA becomes reliable after 24 weeks of gestation, because we know that 20 weeks itself the inner ear has developed normally, embryology, and hence from the 20 to 24 weeks of gestation. Means even in preterm babies, BAER can be done. That is the MCQ point here. That is a point. And BAER needs sedation. It takes at least 60 to 90 minutes for the proper evaluation of the auditory pathway. It needs sedation, but OAE do not need sedation. Okay. In BAER, after giving a tone or a click, the vertex electrodes are placed, scalp electrodes are placed, which get the waveforms from the auditory pathway. There are waveforms 1, 2, 3, 4, 5, 6, 7 waveforms will be obtained in BAER, and the MCQs regarding the waveform is the most predominant waveform is wave 5, and which part of the auditory pathway the waves are generated. The wave 1 is from the distal part of the eighth nerve near the spiral ganglion. I tell you with the diagram, you will understand. And wave 2 from the proximal part of the eighth nerve near the brainstem. And 3 from the cochlear nucleus, 4 from the olivary complex, 5 from the lateral lemniscus, and 6 and 7 from the inferior colliculus. Remember, the MCQ point is wave 5 is the predominant waveform of the BAER. So, wave 5 assessment is commonly done in BAER. So, this is predominantly seen. All the other waveforms are a little less significantly produced in the waveform, in the graph. Take this picture. I told you. So, this is the cochlea where the spiral ganglion cells are present, star number 1. The spiral ganglion cells are present in the cochlea. From there, the eighth nerve starts, the first order neuron, eighth nerve starts. Okay, eighth nerve. And the eighth nerve very near to its cochlear nucleus, brainstem, is the second wave will be generated. So, this is the distal waveform and this is the proximal E. So, 1 and 2, 2 E's. So, otherwise it is a E. coli is the mnemonic, very similar to the auditory pathway, first E and second E. The first E is from the distal spiral ganglions and the second E from the nerve near to the brainstem nucleus, and 3 cochlear nucleus, 4, 5, 6, 7 we have seen. Okay. So, this is how the waveforms are being generated. Okay. So, what is our common indication of the BAER? Retrocochlear pathology, it can easily identify. So, whenever there is a tumor, assume there is a tumor in the eighth nerve, compressing the eighth nerve, what are all the inferences that can be obtained in the BAER? Very simply, 3 inferences, very easily to note. When the eighth nerve is compressed by the tumor completely, what happens? No impulse will cross across the eighth nerve, and hence, see, on giving a tone to the patient or click to the patient, wave 1 will be generated as usually, but no other waveforms are generated because the eighth nerve is completely compressed, no impulse will pass through the nerve. So, wave 1 is generated, all other waves are absent. But in another scenario, if the eighth nerve tumor is partially compressing the eighth nerve, what happens? The nerve becomes fatigable. Transmission is very much delayed through the nerve, the diseased nerve. So, the wave 1 will be generated and the latency of all other nerves will be delayed 2, 3, 4, 5, 6, 7. So, the latency will be increased for all the waveforms, especially wave 5. That's all. Due to the fatigable nerve, the waveform 1 will be generated normally and all other nerves will be having a delayed waveform generation. So, latency of wave 5 is delayed but not wave 1. That's the point here. So, wave 1 to 5 latency is delayed in BAER. So, this is the point. So, if you compare the 2 ears, the diseased ear and a normal ear, this interoral latency of wave 5 is delayed. How much it is delayed? Usually more than 0.2 milliseconds it is delayed. So, wave 1 is present, other waves are absent. Wave 1 to 5 delayed latency, and interoral, if you compare with the opposite normal ear, 0.2 milliseconds will be delayed. So, these are all the inferences in retrocochlear pathology in the BAER. Very simple. If you understand the picture, easily you can crack this answer. Okay. Last point, MCQ point. In which condition no waves are present, even the wave 1 is absent. Even that wave 1 is absent, in which condition auditory neuropathy. In auditory neuropathy, this is a condition called auditory dyssynchrony or neuropathy. From the spiral ganglion itself, everything is degenerated. Seen in acoustic neuroma or vestibular schwannoma, spiral ganglion is normally working in the cochlea. So wave 1 is generated, but not all other waves. But in auditory neuropathy, which is a congenital disorder of the eighth nerve, from the spiral ganglion itself, everything is been degenerated. So even the wave 1 is not present. So absent BERA is seen in, please remember, auditory neuropathy or auditory dyssynchrony disease, auditory neuropathy spectrum diseases. There's a condition. This is a rare congenital hearing loss cause, auditory neuropathy. So where no waves are present in BERA. So this is about BERA. Okay. So with this, we go for a lunch break. Thank you very much for your listening, and then we'll come back after 1 hour. Thank you. students. So we'll cover the remaining parts in this afternoon session. Okay. So the basics of ear, what we have discussed, a little more concepts and more understanding is necessary. Hereafter, we can sail in an easier way. Okay. Let us continue with the questions. The most common congenital middle ear abnormality, what is that? Absent footplate of the stapes, fixation of footplate of the stapes, oval window abnormality, absent long process of the incus. So the answer here is fixation of the footplate of the stapes. MCQs, 2 points are important here. The middle ear anomaly they are speaking about, ossicular anomalies. Congenital ossicular anomaly and acquired ossicular anomaly. Two things, there is a difference. In a congenital ossicular anomaly, the most common bone that is involved is stapes. Very important. It is very similar to otosclerosis. So here also the stapes becomes fixed. Fixity is the most common anomaly. Stapes anomaly. Okay. And there is a fourth option, absent long process of the incus. So this is quite common, acquired conductive deafness. So the incus is the bone involved in case of acquired diseases like any cholesteatoma eroding the incus or traumatic dislocations causing incus dislocation. Because this incus long process is more thinner and has very minimal end arterial blood supply. So erosion of the long process of the incus is quite common in cholesteatoma. The most common ossicle to get destroyed in cholesteatoma or any otitis media is long process of the incus. And the most common ossicle involved in traumatic dislocation is incus, again because it has very weak supports. So malleus and stapes has its supports from the tendons, muscular tendons and ligaments, and incus has its weaker support. So incus is the most common ossicle involved in acquired conductive hearing loss, and stapes is the ossicle involved in congenital conductive hearing loss. And regarding this origin, incus and malleus are from the first arch and stapes is from the second arch. And please remember the footplate of the stapes with its annular ligament is deriving from the otic capsule. So malleus and incus are from the first arch cartilage, first branchial arches, and stapes superstructure is from the second branchial arch, and the footplate and the annular ligament are from the otic capsule origin. This difference please remember. Okay. So congenital causes of conductive hearing loss, if they are asking in a broader way, not the middle ear anomalies, congenital causes of conductive hearing loss, the most common cause is meatal atresia. This is MCQ. The most common cause of congenital conductive hearing loss is meatal atresia. If they are very specific about the ossicular anomaly only, the stapes, fixation of the stapes footplate is the present, second most common of course, and the congenital cholesteatoma is the third most common of the congenital causes of conductive hearing losses. But commonly, congenitally deaf children are mostly sensorineural hearing loss. But here the question is conductive hearing loss. So these are the three most common, and the most common is external meatal atresia. Microtia with external meatal atresia is the common cause for congenital conductive deafness. So acquired conductive deafness ossicle involved is incus. Please remember that. So coming to the congenital sensorineural hearing losses, they are broadly classified into genetic and non-genetic causes, and the genetic causes are most common causes of congenital sensorineural hearing losses. And among the genetic cause, syndromic causes are there. Non-syndromic are most common again. Syndromic are there. We will see the few syndromes. And non-genetic causes, it is classified as prenatal, perinatal and postnatal, and a few MCQs are prenatally. The most common cause are cytomegalovirus and rubella are the most common cause of prenatal non-genetic sensorineural hearing loss. Perinatal, we know prematurity, low birth weight, less Apgar less than 3, and congenital hyperbilirubinemia, kernicterus. So prolonged ventilator support. These are all the causes for the perinatal causes. And the postnatal causes, the most common causes, neonatal meningitis. I told you, through the cochlear aqueduct, meningitis will cause labyrinthitis and causes sensorineural hearing loss. So this is the postnatal most common cause. few syndromic causes. The most common syndrome causing congenital syndromic SN hearing loss is Waardenburg syndrome. This white forelock, heterochromia iridis, hypopigmented patches with sensorineural hearing loss. Waardenburg syndrome is the most common congenital syndromic SN hearing loss. Okay. There are certain syndromes which are associated with conductive hearing loss, branchial arch anomalies. So here the first, it is bilateral maxillary and mandibular hypoplasia. This is called Treacher-Collins syndrome. Please remember, bilateral maxillary and mandibular hypoplasia. And unilateral hemifacial microsomia. This is called golden hair syndrome. So in these both syndromes, conductive hearing loss, congenital conductive hearing loss, because these involves the branchial arches. We know the branchial arches causing this malleus incus from the first arch and stapes from the second arch. So the branchial arch anomalies will lead on to conductive hearing losses, golden hair syndrome, hemifacial microsomia. Okay, so Treacher-Collins and golden hair are related to conductive hearing loss, syndromic. And last one, a peculiar syndrome or more famous syndrome is Penrod syndrome, where this SN hearing loss is associated with prepubertal goiter. So prepubertal goiter with SN hearing loss, Penrod syndrome. So please remember these syndromes and the SN hearing loss with prolonged QT interval, in ECG, where the arrhythmias are common, is Jervell-Lange-Nielsen syndrome. As it is a prolonged QT interval, the name is also a prolonged name, Jervell-Lange-Nielsen syndrome. SN hearing loss with prolonged QT interval. Okay. Which is the initial mode of entry for aminoglycoside toxicity. So aminoglycosides are very notorious and common drugs causing this ototoxicity, and we will be getting questions from this. So which is the initial mode of entry? Sodium potassium ATPase, mechanoelectrical transduction channels, basilar membrane, outer hair cell, calcium channels. So obviously we have already seen this mechanoelectrical transduction channels in the tip of the hair cells. Sodium potassium ATPase will be present in stria vascularis for the production of potassium into the endolymph. Basilar membrane, no. And outer hair cells, inside the hair cells, we have the calcium channels that will be opened only after influx of the potassium inside the hair cells. So basically the potassium channels, nothing but these are the potassium channels, are called as mechanoelectrical transduction channels. So potassium channels through which the aminoglycosides also enter into the hair cells and causes apoptosis, hair cell death, permanent hair cell destruction, apoptotic cell death it will cause. That is a mode of injury. So few points regarding this ototoxic drugs. Aminoglycosides, we have this GST, gentamicin, streptomycin, tobramycin, GST, vestibulotoxic. Some people are saying no, GST is waste. So like that we can easily remember in a way. Gentamicin, strepto and tobramycin, GST or vestibulotoxic. Kanamycin, kanamycin, amikacin, neomycin or oto. Con is here, so kanamycin is ototoxic. That's right. That's why that is cochleotoxic. And the strongest ototoxic is neomycin and the weakest is netilmycin. So these are all cochleotoxic. And analgesics, antibiotics, antimalarials, loop diuretics, chemotherapeutic drugs. The point to note here is MCQ point is which of these drugs causes permanent cell death, irreversible cell death, irreversible damage. So aminoglycosides, vancomycin, and the chemotherapeutic drugs, and very specifically cisplatin and carboplatins. These are all the drugs causes permanent cell death, permanent hair cell, outer hair cell destruction, and that will lead on to this irreversible damage to the inner ear. So aminoglycosides, chemotherapeutic agents, cisplatin and carboplatin, and vancomycin are all the typical notorious drugs. WHO classification of deafness. How this deafness has been classified? So up to 25 decibel it is normal hearing range. From the 25 decibel it is mild, classified as moderate, moderate to severe, severe and profound. Okay, it is very easy to classify, very simple. From the 25 decibel it is all 15 decibel plus 15 plus 15 plus 15, and this is only 10 decibel. I tell you what, we have to remember two values in this classification. One is 25 decibel, up to 25 it is normal, and above 90 value, remember the 90 above is profound, and nothing is here is total. So if it is a plus 15 here, it is 95, but the cutoff value is 90 decibel. So that is one point. The last addition only it is 10 decibel. That's all. So in this order we can grade the severity of the deafness. So 25 decibel is normal, 90 decibel above is a profound deafness. Please remember these two values so that you can easily classify in between. Intensities of sound at 1 meter distance. What is the intensity of each type of sound? Whispering, a normal conversation, shouting or a loud sound, any sound that produces discomfort or pain in the ear, like we are sitting very near to the speakers, pain in the ear, and inner ear rupture, acoustic trauma, TM or inner ear, any sound that causes inner ear rupture, acoustic trauma. What is the decibel level? Again, easy to remember. Start with 30 decibel, plus 30, plus 30, plus 30, plus 30. Simple. 30 decibel is whispering, 60 is conversation, 90 is an augmented and a loud sound, and 120 decibel is a sound which produces a pain in the ear, and plus 30, around 150 decibel causes acoustic trauma. So it is from 140 to 170 is the sound that typically any sound greater than 140 decibel is not allowed in the society. It can lead on to acoustic trauma. So plus 30, plus 30, plus 30, you can easily remember in the range of this intensity of the various sounds. And various middle ear pathologies that causes how much conductive hearing loss. This they will be asking often. So tympanic membrane perforation will lead on to, based on whether it is a smaller perforation or a larger perforation. So 10 to 40 decibel hearing loss will be present based on either smaller or larger, 10 to 40. And complete obstruction of the ear canal like impacted wax will produce a 30 decibel hearing loss. And very simply, any ossicular destruction, very simply please note this, any ossicular destruction will lead to the decibel loss of 40 decibel. If your audiometry shows a 40 decibel hearing loss in a CSOM patient, that means more than 40 decibel hearing loss, that means ossicular discontinuity is present. We have to assume like that. So when the ossicular disruption is there with the tympanic perforation is present both, then the hearing loss is 38 decibel. But with the intact tympanic membrane, only the ossicular dislocation is there, the decibel loss is 54 decibel. As we know, with there is a large perforation, the sound can directly hit over the remaining ossicles and some hearing may be there. But the tympanic membrane is intact, the sound passes through the tympanic membrane, through the ossicles, and that is discontinued. It cannot further pass into any of the ossicles, so the hearing loss is more. So this is the difference between these two conditions. And MCQ point again, any fixed stapes, complete fixation of the stapes will produce 60 decibel hearing loss. Very important. So a complete fixity of the stapes in otosclerosis, the maximal conductive hearing loss is 60 decibel. A complete fixity of the stapes will produce a maximal conductive hearing loss, and that is 60 decibel. That's very important. Partial fixity of the stapes will be less than 60 decibel. It all depends on the degree of fixity. So complete fixation, maximal conductive hearing loss, that is 60 decibel. A deaf child is planned for cochlear implant surgery. Which is false regarding the cochlear implant? Postlingual deaf children are not benefited with cochlear implant, can be implanted in Mondini deformity. Intact eighth nerve is a prerequisite. Hearing aid trial should be given. So what are all the things we have to do before doing a cochlear implant surgery? That's very important. What are the indications and what are the prerequisites? So based on which this question is there. Which is false regarding the cochlear implant? Postlingual deaf children are not benefited with cochlear implant. Not at all. That is a false statement. Postlingual deaf children are the best candidates for cochlear implant surgery. It can be implanted in Montini. Yes, some amount of cochlea is enough to implant the cochlear implant. So Montini, the basal turn is present, we can do a cochlear implant. Eighth nerve is a prerequisite. Yes. See, in cochlear deafness only we are doing a cochlear implant. Outer hair cells are degenerated. So we are doing a electrodes inside the cochlea that will stimulate the spiral ganglion cells, and that impulse should be carried on through the eighth nerve. If the eighth nerve is absent congenitally, what is the role of cochlear implant? You cannot do a cochlear implant, you cannot make the baby to hear. So eighth nerve should be intact for a cochlear implant to be successful. Okay, if the eighth nerve is absent, what is the option for the babies? That's what I have told in the initial time. We have to directly stimulate the cochlear nucleus. And what is the implant called? Auditory brainstem implants. That's very important. So either if the cochlea is totally absent or the eighth nerve is absent, we have to implant directly over the cochlear nucleus, auditory brainstem implant. That's the point. Hearing aid trial should be given before planning for cochlear implant. If, of course, if the babies are hearing well with the hearing aid, there is no need for cochlear implant. Cochlear implant is more sophisticated, a little complicated surgery and more costlier surgery also. So if the babies are hearing with the hearing aid, then that is a treatment for congenital deafness. If the babies are not hearing with the hearing aid, then the cochlear implant is indicated. Hence, okay, before that, we will move on, have a next question. In cochlear implantation, which part is placed inside the ear? Transmitter coil, speech processor, electrode array, receiver stimulator. Of course, it's very clear. We are placing the electrode array only inside the cochlea. All other things are outside the ear. We will see what are the external components, what are the internal components, which are frequently asked question in cochlear implant. Regarding the indication, we are doing cochlear implant in case of bilateral severe to profound sensorineural hearing losses. So in case of moderate or mild, moderately severe hearing losses, hearing aid itself is enough. There is no need for cochlear implant. And postlingual deaf or ideal candidates, of course, see if after developing the speech, if the baby has gone for deafness, if you do a cochlear implant surgery for these babies for whom the speech is already been developed normally, so they will hear immediately and they will have a good speech after cochlear implant. So the postlingual deaf children are the best candidates for cochlear implant surgery. For the prelingually deaf children, that is a usually congenital deafness, they are not hearing from the birth itself. If you do a cochlear implant surgery for them, of course, that is a treatment for the severe hearing, profound to total hearing losses, severe to profound. For these patients, we had to give 1 to 2 years of strict speech therapy for these children. Then only these children will catch up the speak and start speaking. But for the postlingual deafness, if you do a surgery and once you switch on the device, they can easily hear and they will start their existing speaking skills. So it can be done in certain cochlear malformations like Mondini dysplasia, scabies like common cavities. Prerequisites, eighth nerve should be intact, and 1 to 6 years of age is the ideal age group. If you delay the cochlear implant after 6 years, even though the baby is here, the speech development will not be normal. So there will be a brain plasticity where if you delay the cochlear implant, the speech will not be obtained by the children normally. There will be very delay or poor speaking skills. So as early as possible, around 1 to 2 years, the cochlear implant should be done to gain speaking skills very normally, or at least in a good way. Adequate hearing aid trial for at least 6 months, 3 months should have been done for the babies before considering. Components, what are the components? We have the external components and internal components. See, this is microphone and speech processor, and this is the transmitter coil externally to the skin. Okay, microphone, speech processor, and the transmitter coil. From this transmitter coil, the impulse will pass on to the internal component. So this is receiver stimulator, which is placed underneath your scalp over the bone. So this is receiver stimulator. From the receiver stimulator, the impulse will be carried on to the electrode array, which is placed inside the ear through the round window into the cochlea. So this is internal component and this are external components. So this is about the internal and external components of the cochlear implant. This question carries importance because The cochlear implant is not an aesthetic surgery. It has external devices also. Okay, that is, it is not a completely implantable device. It is a point to note. So the electrode is, again, few MCQ points. The electrode is placed in the scala tympani through the round window, and the electrode stimulate the spiral ganglion cells. It is not stimulating the outer hair cells, because which are been already destroyed, degenerated. We are stimulating the spiral ganglion cells. And post-operatively, the device is switched on. Activation is done only after 3 to 4 weeks of wound healing. So once you do a cochlear implant surgery, immediately the babies will not hear. After 3 to 4 weeks only, we have to switch on of the device should be done. Then the babies will get hearing, and mapping of the frequency loss should be done, and strict audio verbal therapy, speech therapy should be given for 1 to 2 years, 2 years at least, for the patients to gain speaking skills. A 2-year-old child was planned for brainstem implant. All are indications for brainstem implant except I told you the cochlea or eighth nerve is not there. Then only brainstem implant. Bilateral neurofibromatosis, yes, can be done. Absent auditory nerves, that's what, yes, we can do brainstem implant. Mycal aplasia, yes, there is no cochlea for the cochlear implant to be placed. So in mycal aplasia, we have to do a brainstem implant. Mondini deformity, no need. See, brainstem implant is even more morbid intracranial surgery than the cochlear implant surgery. So in Mondini deformity, cochlear implant itself gives a good result. There is no need for brainstem implant. So auditory brainstem implants are designed to stimulate the cochlear nucleus complex in the brainstem by placing the electrode in the lateral recess of the fourth ventricle. That is where the cochlear nucleus is situated. This MCQ point. It is placed where? Lateral recess of the fourth ventricle. This is where we are placing the brainstem implant. A child was brought to ENT surgeon with a hearing difficulty. The surgeon examined completely and he advised the following aid for the child. See this following aid, how it looks like. What should be the pathology for the child? So this kind of device is advised by the doctor. What is the pathology of the child for the child? Cochlear malformation, SN hearing loss, bilateral acoustic neuroma, atresia of the external ear. So this kind of aid, please have a look. We have seen the cochlear implant. We have the microphone, speech processor, and the transmitter coil. Everything was there outside the scalp. And we know the conventional hearing aids. So which will be like this. It will be closely, a box will be placed behind the ear, and a loop will be coming. A plastic loop will be coming, and a receiver will be placed inside the ear canal. So this is how the conventional hearing aid will be there. But here what is there? See, there is no connection with anywhere to the pinna, and it is directly osseous integrated to the bone. So it is nothing but bone anchored hearing aid, a small box like thing directly anchored to the bone anchored hearing aid. So this is typically advised in atresia of the external ear. In this condition only we are doing a BAHA. So bone anchored hearing aid is done when you cannot place a normal hearing aid. Like in this picture, see this microtia with extraluminal atresia. We are directly placing this bone anchored hearing aid by titanium fixtures in the bone osseointegration method. So this is the important indication for BAHA. So this microtia and extraluminal atresia are corrected. Next MCQ, at the age of 5 to 6 years, at which age the pinna and extremitis will become adult configuration. At the 5 to 6 years of age only, it becomes adult configuration. Then we can harvest the costal cartilage to sculpture like the pinna, and we can correct this microtia with extremital atresia at the age of 5 to 6 years of age. That's quite important. Till then, the baby should hear. So what way they can hear? BAHA is the only option. So after that, the BAHA can be removed once the external canal anatomy is been re-established. So this is how a titanium fixer is osseointegrated to the bone behind the pinna, and the BAHA instrument is attached to that. A patient presented to emergency with acute vertigo with horizontal nystagmus. Coming to the nystagmus, vestibular pathology. So it's quite small things to understand so that we can have a good answering. A patient presented to emergency with acute vertigo with horizontal nystagmus. Slow component is towards the left side. What is the more likely diagnosis? Posterior canal BPPV, superior canal BPPV, left hypoactive labyrinth, right hypoactive labyrinth. First point, the patient presents with horizontal nystagmus. So which canal is involved? Obviously, horizontal canals are involved in the disease, not the vertical canals. If the vertical canals are diseased, what kind of nystagmus the patients will be having? Vertical torsional nystagmus, not the horizontal nystagmus. So obviously, in this question, we can easily rule out two options: posterior canal and the superior canal, or the vertical canals. So that cannot be the answer because the nystagmus is horizontal. Next thing, the nystagmus has a fast component and slow component. So the given component is slow. Always, if the slow component is given, convert it into a fast component. If the slow component is towards the left side, where should be the fast component? It should be the right side. It is a horizontal beating nystagmus. So it is always fast component is the right side. So that means it is a right beating nystagmus. So nystagmus is based, the naming is based on its fast component because the fast component is easy to visualize. That's why it is named after its fast component. It is a right beating nystagmus. So what is the more likely diagnosis? So most of peripheral diseases are classified into irritable lesions or paralytic lesions, hyperactive lesions or hypoactive lesions. This is a basic classification. So based on which we can easily, there is a typical mnemonic in this nystagmus. So irritable lesions or hyperactive lesions causes I for eye, ipsilateral nystagmus. The fast beating is towards the irritable ear itself. So irritable, if I am having a right irritable lesion of the vestibular apparatus, the nystagmus fast beating should be towards the right side, irritable ipsilateral. There is a pathophysiology here which is easily understood based on the, see, nystagmus has a slow component and a fast component. Slow component is due to the vestibular stimulation, and the fast component, replacing component, is due to the cerebellar replacement component, cerebellar corrective component. So this is why the nystagmus has the slow vestibular component and a fast cerebellar component. So based on its action, which is hypoactive, which is hyperactive, the nystagmus will be beating towards the particular ear. So again, understanding this is less important than answering the question in a few days. So mnemonic. So what is a mnemonic? I have described this pathophysiology in the regular classes, but here mnemonics. Remember the mnemonics. Irritable lesion, ipsilateral nystagmus. Paralytic lesions causes opposite side nystagmus. P for P. So irritable ipsilateral, paralytic opposite side. That's all. So this is the mnemonic. So irritable and paralytic lesions. In this case, coming to the question, the patient is having fast component to the right side. That means right beating nystagmus. What should be the options? Either leave the options of the questions. It is a right beating nystagmus. So either right side should be a hyperactive lesion, irritable. If it is a irritable lesion on right side, then the nystagmus is beating on towards the right side itself, or a left side hypoactive lesion. If the left side is hypoactive, then again the nystagmus will be beating to the opposite side. The fast component is towards the opposite side. So either the disease is right hyperactive or left hypoactive. So what is the options we have in this question? Left hypoactive is present, right hypoactive present. So answer is left hypoactive labyrinth. Very simple. So it is a fast beating towards the right side, right beating nystagmus. So if it is a right beating nystagmus, either the right is irritable lesion or a left is paralytic lesion. The option given is left is paralytic. So left hypoactive labyrinth is the answer for this question. So this is how we have to derive the answer for the nystagmus. First is horizontal nystagmus, so the horizontal canal is involved, and next is which is the fast component side. So based on that we can say which is hyperactive or hypoactive. So this is about the question and answer for this. So vertigo in nutshell. So any patient having few seconds to few minutes vertigo, that is BPPV, which is the most common cause of peripheral vertigo, MCQ, and a continuous vertigo for days together or weeks together. The second most common cause, vestibular neuronitis, continuous vertigo, vestibular nerve inflammation, viral infection. Triad, episodic vertigo, which lasts for 24 minutes to 24 hours, episodic vertigo with tinnitus with hearing loss, commonly unilateral, is Meniere's disease. Any patient CSOM will lead on to vertigo. Always think about labyrinthitis, because CSOM commonly in cholesteatoma, the most commonly the cholesteatoma can erode into the inner ear through dome of the lateral semicircular canal. The dome of the lateral semicircular canal is protruding in the antrum region. So when the cholestoma involves the antrum, it can easily erode the dome of the lateral semicircular canal. That is the most common point of fistula formation, lead into labyrinthitis and severe vertigo. So CSOM with vertigo, labyrinthitis. Any post-traumatic vertigo, iatrogenic trauma, road accident traumas or barotrauma, after that the patient is getting vertigo. In a question, if you carry like this, perilymphatic fistula is to be thought of. It is a fluctuating triad, hearing loss, vertigo and tinnitus, and that is typically aggravated by straining. Whenever there is an increased intracranial pressure, like in Valsalva maneuver, lying down, or any climbing or straining, defecating activities where there will be increased intracranial pressure, the patient will experience vertigo. So this is perilymphatic fistula. So a strain induced, a positive pressure induced, Valsalva induced vertigo is called Hennebert's phenomenon. Hennebert's phenomenon, a pressure induced vertigo is Hennebert's phenomenon, perilymphatic fistula. This is very important. And anything associated with neurological deficit, vertigo with dysarthria, dysphagia, ataxia, seizure, hemiparesis, like that, look for into central causes. And regarding the BPPV, few MCQ points. The most common canal involved is posterior semicircular canal, because that is the gravity assisted canal. So the otoconial debris can easily enter into this gravity assisted canal. So otoconial debris in the posterior canal is the most common canal involved. So what kind of nystagmus the patient will be having? Obviously it is a vertical canal. So the nystagmus is vertical torsional nystagmus. So the most common nystagmus in a peripheral diseases is vertical torsional upbeating nystagmus, because BPPV is a irritable lesion. So normally in the posterior canal, the eyeball physiological movement is downbeating, and again the fast beating is towards superiorly. So in the posterior canal disease, it is a posterior vertical torsional upbeating nystagmus. Vertical torsional upbeating nystagmus is the nystagmus present in BPPV. And what is the treatment for BPPV? Epley's maneuver, canalith repositioning maneuver. We have to replace the misplaced otoconial debris back into the utricle. That is a Epley's maneuver. And if the Epley's maneuver fails, we can do a nerve suction. What is that nerve suction called? Singular neurectomy. So singular nerve is a branch of inferior vestibular nerve that supplies a posterior semicircular canal. So if the patient is not having intractable vertigo, rarely this procedure, singular neurectomy, is performed to relieve the vertigo. Test for vestibular functions. What are all the clinical tests and lab tests we'll be doing? Dix-Hallpike maneuver and fistula test are the common clinical test, and caloric test and WIMP are the laboratory test. And what are all the MCQ points from these areas we have to do? No. Dix-Hallpike, what is the most common nystagmus will be getting? Of course, Dix-Hallpike is a test for BPPV, and the same thing, the vertical torsional upbeating nystagmus is the nystagmus we'll be getting in BPPV. And we will be applying these glasses to the patients. What is this glasses? Frenzel glasses. This is plus 20 diopter glasses because we have to abolish the optic fixation. If the patient is able to fix a target during this maneuver, the nystagmus will be abolished. So the patient should be given a ground glass like glass so that the optic fixation can be avoided, so that the nystagmus is well established and we can observe the nystagmus very clearly. On doing this Dix-Hallpike maneuver, based on the characteristics of the nystagmus, we can say whether this is a peripheral disease we are dealing with or a central disease we are dealing with. So what are the typical MCQ points, clinical points? The last point. See this. A persistent beating nystagmus, that is early onset and without any fatigability. It is beating persistently without any tiredness. A persistent beating nystagmus, or a direction changing nystagmus based on the gaze. On the right gaze, it is right beating. On the left gaze, left beating. That is disobedient nystagmus, direction changing nystagmus, or a pure vertical nystagmus. These kind of nystagmus, we have to think about central pathology. Please remember, this is the MCQ point. So when do you suspect the patient is having central pathology? A non-fatigable persistent nystagmus, direction changing nystagmus, or a pure vertical. I told you in peripheral diseases either it is horizontal nystagmus or a vertical torsional nystagmus is seen. If you see a pure upbeating or downbeating pure vertical without any torsional component, we have to look for central pathology. So this is the difference between the peripheral and central pathologies. A clinical patient, Paka. A cholesteatoma patient came with severe vertigo and tinnitus. On examination, fistula test was found positive. Of course, patient has cholesteatoma and vertigo. What is the pathology? Lateral semicircular canal fistula. And if you do a fistula test, a positive fistula test will be present. He refused treatment and came weeks later with severe deafness of the ear. So he refused treatment. So the labyrinthitis has established completely, that has destroyed the inner ear completely, and that will gone for a stage called deaf ear. Severe deafness of the ear. Now on examination, fistula test becomes negative. Initially it was positive, now it is negative. So what happened and what will be the Rinne's test? So why the fistula test becomes negative? So if you do not treat the labyrinthitis, suppurative labyrinthitis, it will completely destroy the inner ear structures and the patient will go for total deafness, profound total deafness, and that ear is called dead ear. All the neuroepithelium will be destroyed, degenerated. So there is nothing to get stimulated. So if you do a fistula test, there is nothing is there to get stimulated. So after the dead ear stage, the fistula test will be negative. That is false negative fistula test. That is very important. So if the patient is having a dead ear, profound or total deafness, what is the Rinne's test? Obviously it is false negative. That's all. False negative Rinne's test is seen in dead ear or profound deafness. That's what we have seen. So this is about the question answer. Fistula test. We will be doing the fistula test of the cegal speculum, increasing the pressure in the extremiatus, and that will be transmitted into the inner ear through the labyrinthine fistula if it is present. Okay. What are the inferences? Positive fistula test. Doing a fistula test and the patient experiences vertigo and nystagmus is present. So means cholesteatoma has caused a fistula or a fenestration surgery is already done for the patient. Negative fistula test. CSOM or cholesteatoma is present, but there is no fistula for the patient. So negative fistula test. It's very clear, straight. False positive, false negative. Two areas of MCQs. The false positive is seen in there is no true fistula, but the patient will be experiencing vertigo nystagmus. False positive. So which is typically seen in congenital syphilis and Meniere's disease. So the congenital syphilis due to the lax annular ligament hypermobile stapes foot plate will hyper excite the inner ear. And Meniere's, the endolymph will be plunging into the saccule oval window and get stimulated easily. So there is no true fistula, but the patient has vertigo nystagmus on doing the fistula test. This is again a pressure induced vertigo. That is a Henneberg sign like in the perilene fistula. A pressure induced vertigo, Henneberg sign is present. And false negative we have seen just now, dead labyrinth, everything has been destroyed, nothing to get stimulated. So it is there is a fistula There was labyrinthitis which has destroyed everything. So even though the fistula is present, pathology is present, since everything has been destroyed, no vertigo nystagmus for the patient. So it is false negative fistula test in dead labyrinth. True about caloric testing of the inner ear. Stimulates the posterior canal. Cold water causes ipsilateral nystagmus. Warm water is excitatory, head elevated to 60 degree. So stimulates the posterior canal? No, it stimulates the lateral canal. Cold water causes ipsilateral nystagmus? No, the famous mnemonic cows. Cold water opposite nystagmus and warm water same side nystagmus. Cows is a famous mnemonic. Of course, B is not there. Warm water is excitatory, head elevated to 60 degree. What we know very clearly is head is not elevated to head 60 degree, it is 30 degree head elevation. So the answer is C. How the C answer? Warm water is excitatory. Very simple from the same mnemonic. C, cold water is causing opposite side nystagmus and warm water is causing same side nystagmus. If the cold water is causing opposite side nystagmus, then what should be the cold water? Whether it is irritable or paralytic to the labyrinth, opposite side nystagmus, paralytic to the labyrinth. So cold water is hypoactive to the labyrinth. Warm water causes same side nystagmus, which is causing ipsilateral nystagmus, irritable lesion, hyperactive lesion. So warm water is hyperactive to the labyrinth. So warm water is excitatory to the labyrinth. That's why it is causing same side nystagmus. So this is a point here in this caloric testing. So the points to remember is head is elevated to 30 degree, and that's where the lateral semicircular canal becomes more vertical, then only it becomes more thermosensitive to the convection currents we are inducing with warm and cold water. So the vertical position, it becomes more thermosensitive, that is the lateral canal placed in the vertical position. Temperature plus or minus 7 degree from the body temperature, and this is the types of nystagmus that will be obtained during the caloric testing. And like BAER, we have a electrophysiological testing for the vestibular apparatus also. BAER for hearing and VEMP, vestibular evoked myogenic potentials for the vestibular apparatus. So a loud sound is produced, and I told you the oval window is placed partly over the saccule, and hence the saccule gets stimulated, and saccule is impulse are carried through the inferior vestibular nerve. So, one MCQ point here, the vestibular nerve has superior vestibular nerve and inferior vestibular nerve branches, bundles, and there is a mnemonic called IPS, Indian Police Service, simply. So, this inferior vestibular nerve supplies posterior semicircular canal and saccule. This is a mnemonic. So whenever the saccule is excited or posterior semicircular canal is stimulated or excited, the nerve through which it is carrying is inferior vestibular nerve. So when the saccule is stimulated, inferior vestibular nerve is getting stimulated to the nucleus, to the tract, and the sternocleidomastoid muscle is activated, vestibulospinal reflex. So sternocleidomastoid muscle is activated. So based on which we can assess this vestibular pathway. So commonly any lesions from the inferior vestibular nerve or like Meniere's disease involving this saccule can be identified with this VEMP. So this is the VEMP. Coming to the clinical areas of ear now. So from the external meatus and then middle ear, and then we have to look for a few diseases of middle ear and inner ear. So these are the areas to be covered. A 50-year diabetic male was referred to ENT surgeon for non-resolving severe ear pain with regular antibiotics. Okay, non-resolving severe ear pain. CT temporal bone showed extensive osteomyelitic changes. Which of the following is false? This two combo is very important. Any diabetic male patient with osteomyelitis of the temporal bones, which causes severe ear pain, skull base osteomyelitis or malignant otitis externa. That is the disease we are dealing about. So it's very clear. So which of the following is false regarding the condition? Caused by Pseudomonas aeruginosa? Yes, right. Granulation is seen in the external meatus? Yes, because from the external meatal bony part, the osteomyelitis will travel more medially. So due to the bony erosion, granulations will be present in the external ear. Very important classical feature of malignant otitis externa. Please remember. See, usually granulations we will be encountering commonly in the ear is middle ear, because in a disease called cholesteatoma, where the bony erosion is quite common and granulation formation is quite common in the middle ear. But if you see external meatal granulations, always think about malignant otitis externa. Radiotherapy can be given. No, it is purely infective. There is no role for radiotherapy. It is not a malignancy. It is called malignant because it is fulminant in course. That's why it is called malignant. Otherwise, there is no connection with the malignancy. Gallium scan is helpful for monitoring. Yes, nuclear scan are very typically helpful in one condition in ENT, that is where malignant otitis externa. So the answer is there is no role for radiotherapy. So it is the most common organism. We have seen it is commonly in immunosuppressed diabetic people, and while doing the bony erosion, it will also involve the cranial nerve. Seventh cranial nerve is the most common nerve involved. Of course, the facial nerve, which is the prime nerve of the middle ear, and 9, 10, 11, 12 in the skull base region, in the jugular foramen region will be involved, and we will classically see the granulation in the external meatus. Investigation, nuclear scans, technetium scan and gallium scans are very useful. Technetium is the useful in taken up by the osteoclast and blast, will be useful in early diagnosis of the disease. Even before the findings in CT scan, technetium takes up the lesions, and gallium scan is taken up by the inflammatory cells, and it is useful in early prognosis, because we need to know whether the condition is responding to the treatment or not. So the gallium scan is useful for early prognostic indicator. And treatment is systemic antibiotics for 6 to 8 weeks. Anything that is against pseudomonas, like from quinolones, third and fourth generation cephalosporins, aminoglycosides, all those things we can give for this malignant otitis externa. Plus radical debridement, radical mastoidectomy should be done to prevent any further progression. Few conditions of the external meatus. C, we can clearly see a black and white hyphae, fungal hyphae in the external meatus, which is called as otomycosis. And what is the most common organism causing this otomycosis? Aspergillus niger. Black colonies are the most common colonies. And KO, what is this? Keratosis obturans. A purely white keratin entrapment. It is not expelled properly, so the keratin gets engulfed or entrapped in the external meatus, and it causes massive impacts and causes surrounding bony expansion. The keratosis, due to the pressure effect, it causes massive bony expansion all around. So if you see the external meatus in these cases of keratosis obturans, it is ballooned out external meatus, which is a typical sign. A ballooned out external meatus due to bony expansion and erosion due to this keratosis obturans is typical finding. And under anesthesia, you have to expel all the keratosis obturans. It is a painful condition. And this is hematoma of the ear. It should be drained immediately. If you do not drain the hematoma of the ear due to any trauma, it will lead on to perichondritis. And again, perichondritis, the most common organism is Pseudomonas. Perichondritis pinna, Pseudomonas is the common organism. Again, if the patient is having a recurrent perichondritis, what is the condition? A crumpled and lobulated ear, that is called cauliflower ear. Recurrent perichondritis of the pinna. Coming to the otitis media. A child was brought by the parents with a history of teacher complaining non-listening in the classroom in recent days. Otoendoscopy shows the below pic, which is false regarding the condition. The one and only complaint is hearing loss for the babies. And on examination, very clearly a classical appearance, amber colored tympanic membrane and yellow colored, straw colored tympanic membrane with multiple air bubbles are present inside the middle ear. So this is a typical condition of serous otitis media. So which is false regarding the condition. Immediate myringotomy must be done. Type B tympanogram. The effusion of middle ear is sterile, most common cause of conductive deafness. So answer is there is no role for immediate myringotomy. We can give antihistamines, decongestants to decongest the eustachian tube, then it can spontaneously resolve in many times. So if it is not responding even after 3 months, then we can go for myringotomy and grommet insertion. So yes, type B tympanogram is the typical finding. Effusion is sterile. It is non-painful, non-infective otitis media. Okay, and most common cause of conductive deafness, yes, it is a very important MCQ, which is the most common conductive deafness in the children. Serous otitis media. It has many names: otitis media with effusion, mucoid otitis media, glue ear, silent otitis media. So these are all the names for this serous otitis media. So it is the most common cause of conductive hearing loss. Amblyopia, air bubbles and fluid levels are seen, and the treatment is we have to open the membrane like this. A radial incision is made in the antero-inferior part of the tympanic membrane. Let out the fluid, and a grommet tube is inserted. Okay, check. In case of a painful otitis media, infective and painful otitis media, see, any URI will cause ascending infections to the middle ear and cause a severe pain and infection in the middle ear. That is called AOM, ASOM, acute suppurative otitis media, where the TM will be with pus inside the middle ear. So the classical finding is congested tympanic membrane and radial vessels all around the tympanic membrane. This is called cartwheel appearance. Cartwheel appearance is the classical sign in acute otitis media. Again, in acute otitis media, the treatment is medical management, antibiotics against Streptococcus pneumonia, which is most common organism. And if it is not resolving, then only we can go for myringotomy. In acute otitis media, where will you do myringotomy? In what way? You will make a myringotomy in a curvilinear incision in the more dependent area, postero-inferior area, and let out the pus. If here we need not put a grommet, after once the pus are evacuated completely, everything will heal. So this is a point. And the point regarding the myringotomy MCQ is, in which quadrant you should not do myringotomy? The answer is, in a posterior-superior quadrant, you must not do myringotomy, because that is where the incudostapedial joint assembly will be present. Malleus, incus, stapes, the incudostapedial joint assembly in the oval window region. So if you put a knife in the posterior-superior region, you may accidentally dislocate the incudostapedial joint. That is why, very importantly, you must not do myringotomy in a posterior-superior quadrant of the tympanic membrane. Coming to the cholesteatoma. Levenson's criteria for diagnosing congenital cholesteatoma includes all. When will you say the patient is suffering from congenital cholesteatoma? It is called as Derlakis or Levenson's criteria. All except whitish mass behind intactium, normal pars tensa and pars flaccida, no attacks of otorrhea, prior history of ear surgery. So answer is D. So whitish mass behind an intact normal tympanic membrane. Yes. See, usually cholesteatoma is due to retraction pocket theory, or very rarely, quite rarely, a secondary acquired cholesteatoma. We will see that through a existing perforation. So there should be a perforation or a retraction pockets for a cholesteatoma to form acquired cholesteatoma. If the TM is completely intact and still you are seeing a white mass behind the middle ear, behind the tympanic membrane, that means congenitally some squamous cell rest are there in the middle ear that is growing into cholesteatoma. So that is behind an intact normal tympanic membrane. If you see a white mass, then you have to think about congenital cholesteatoma. And two other important criteria is, in the past there should not be any attacks of otorrhea. If there was any otorrhea, ear discharge, perforation would be there, and through the perforation the cholesteatoma would have been entered into the middle ear. So there should not be any history of ear discharge in the past. Again, there should not be any history of ear surgery in the past. Again, during ear surgery, accidental scraping of the external meatal epithelium into the middle ear can happen. So there should not be any history of ear surgeries. But here in the option, prior history of ear surgery, the option is given. So that is the answer. Okay, that is about congenital cholesteatoma. So we have this, how this safe type of CSOM, a central perforation will look like, and a retraction pocket in the attic region, pars flaccida, looks like, and this is a marginal perforation. See, the annulus is absent in case of a marginal perforation. These are all the various kinds of perforation, how it looks like. And there are two theories of cholesteatoma. They will ask you, one is acquired cholesteatoma, primary acquired. So through the existing retraction pocket through the prosoc space that happens, that is called Whitmark's theory or retraction pocket theory. This is called primary acquired cholesteatoma. Okay, and the second root of cholesteatoma formation is through a existing perforation, very commonly a marginal perforation where the annulus is absent. Cholesteatoma can enter through this perforation into the middle ear. The epithelium from the extremiatus, squamous epithelium, can enter into the perforation. So this is called secondary to the perforation. So it is called secondary acquired cholesteatoma. So secondary through this perforation is called secondary acquired cholesteatoma. So this theory is called Haberman theory. Like, to remember easily, Superman. The Superman jumps through the window, joint. So through an existing window, the epithelium jumps into the middle ear. So Superman theory or Haberman theory is for the secondary acquired cholesteatoma, and Whitmark theory is for the primary acquired cholesteatoma. Congenital cholesteatoma, the most common areas are middle ear, petrous apex, cerebellopontine angle, that we have seen the Levinson's criteria, and this is the white mass behind a intact normal tympanic membrane. Coming to the complications of otitis media, acute mastoiditis is characterized by all except deafness, sagging of anterior wall of meatus, obliteration of retroauricular sulcus, clouding of air cells. Just deafness will be present. Sagging of anterior wall of meatus. No, it is posterior wall of the meatus. Very simply, mastoid is related to the posterior wall of the extremiatus. So obviously it will erode into the posterior wall. So it is not. So sagging of the posterior wall. Obliteration of the retroauricular sulcus. Yes, due to the edema, the obliteration of the retroauricular sulcus will be present. And if you take X-ray, the air cells, the septations will be broken down due to the acute mastoiditis, and clouding of the air cells will be present. That is a classical finding in X-ray mastoids. Complication, the most common extracranial complication is mastoiditis, and the most common intracranial complication is meningitis. So few points regarding these complications. Coming to the acute mastoiditis, the signs are ironed out mastoid due to the edema. The periosteal edema inflammation will be present. Retroauricular groove is obliterated. Pinna is displaced. How it is been displaced? It is displaced forwards and downwards because the edema is there in the posterior superior part of the mastoid behind the ear. So forward and downward displacement, and the posterior superior canal wall sagging. If you through the external meatus, if you see, this is the mastoid antrum with the external meatus. So if there is the abscess is present, it will erode into the posterior meatal wall, and there will be a bulging in the posterior meatal wall. That is called sagging of the posterior meatal wall. So that is very, very important. And due to the pressure of the pus, it will come out like a lighthouse sign, a pulsatile discharge through the tympanic membrane, lighthouse sign. And from the mastoid abscess, the abscess can track down through the pathways. So what are all the areas through which it will track down? So if the abscess tracks down through the sternocleidomastoid muscle, this is called Bezold's abscess. And one more muscle attached to the mastoid is, we will know, posterior belly of the digastric. So tracking down the posterior belly of the digastric is called Citylis abscess. Rupturing into the external meatus is called Lux abscess, and tracking along the zygomatic process is called, there is no specific name, it is zygomatic abscess. So from below downwards, the mnemonic is BCL, B cell lymphoma. So through the sternomastoid, Bezold's, along the posterior belly of digastric, Citylis, into the external meatus, Lux abscess. So these are all the types of abscess. The mastoid abscess can track down into other areas. Classical dictum: if your CSOM patient is presenting with this associated condition or symptom, you have to think about this complication. So CSOM patient with diplopia, lateral rectus palsy, you must rule out petrositis, Grady-Nigo syndrome, very important. CSOM patient with severe headache and lethargy, and you will order a CT brain. In a CT brain, you are seeing a ring sign in CT brain. So otogenic brain abscess, very clear. CSOM patient with the torticollis and a delta sign in CT scan. So this is lateral sinus thrombosis. When the lateral sinus thrombosis is extending below into the internal jugular vein, the patient will be having torticollis and the patient will be having delta sign. We will see that in the pictures. So petrositis, Gradinego syndrome, 3Ds, persistent ear discharge, and it is diplopia due to the sixth nerve involvement which passes through the Gruber's ligament, Doralow's canal in the petroclinoid ligament, diplopia due to lateral rectus palsy, and the deep-seated pain due to the fifth nerve involvement, Gasserian ganglion in the Meckel's cave in the petrous apex. So this is the petrous apex area where we have the two important nerves, Gasserian ganglion of the fifth nerve and the sixth nerve through the Doralow's canal. So these two nerves will be involved. So persistent ear discharge along with diplopia and deep-seated pain are the typical 3Ds of Gradinego syndrome, petrositis. Please remember, these are all the quite common questions they will be asking you. A 45-year female with known history of chronic otitis media presented to emergency department with a history of fever, headache, lethargy. Chronic otitis media, fever, headache, lethargy. This triad itself is very necessary to rule out intracranial complication. That's very important. She also had 2 episodes of seizures, of course, extra point. Urgent CT brain was taken and shown, which is false about the clinical scenario. So the patient is having temporal lobe abscess, a ring sign in CT scan, a very clearly ring sign, temporal lobe abscess. It is a ring enhancing sign. Otogenic cause is a common cause. Yes, mastoidectomy should be done immediately for COM. Temporal lobe abscess is most common site. Yes, answer is which is false. C. If you are encountering any intracranial complication, meningitis and brain abscess are the most common intracranial complications. Meningitis and brain abscess. If you encounter the patient with these intracranial complications, the dictum is make the patient neurologically stable and then go for ear surgeries. Treat the ear condition, the primary pathology. So make the patient neurologically stable. So treat the meningitis or do a craniotomy and drain the brain abscess and then go for mastoidectomy. This is a typical dictum. So mastoidectomy should be done immediately. No, make the patient neurologically stable and then do the mastoidectomy. So that is the thing. All other things are right answers. So temporal lobe is the most common site and cerebellum is the second most common site for otogenic brain abscess. And in the temporal lobe abscess, the most important early sign is homonymous supraquadrantinopia due to the involvement of the optic radiation, the ipsilateral nasal and contralateral temporal visual field defects will be present. Homonymous supraquadrantinopia is the earliest sign, and Jacksonian localized seizures and nominal aphasias can be seen. And cerebellar signs we very well know: ataxia, dysdiadochokinesia, intentional tremors, severe irregular nystagmus, all those things. Lateral sinus thrombosis. It presents with a typical fever called picket fencing fever. Picket fencing fever. So the fever rises and comes down, rises and comes down. So irregular regularity will be present. This is called picket fence fever. For every emboli that is released into the bloodstream, the patient will be having fever. Okay. Greisinger's sign is a typical sign. What is Greisinger's sign? Due to the lateral sinus thrombosis, the emissary vein from the mastoid will also get thrombosed. Hence, pitting edema. Pitting edema of the mastoid will be present. That is called Greisinger's sign. Pitting edema of the mastoid in lateral sinus thrombosis. And what is this sign? Bluish discoloration of the mastoid. This is very clearly a battle sign. Of course, bluish discoloration is typically seen in temporal bone fractures, battle sign. Greisinger's sign is pitting edema in case of lateral sinus thrombosis. So these are the things. And if you take a CT scan, empty delta sign, the lateral sinus will be hypodense and the walls will be hyperdense. So this is called empty delta sign. So due to the thrombosis, the lateral sinus will be empty and the walls will be inflamed, empty delta sign. So here we stop with this and we'll go for a little break and we'll come back. Okay, we will start with the surgeries of otitis media. And of course, we have this tympanoplasty. So, tympanoplasty is repairing of the tympanic membrane with hearing reconstruction, ossicular reconstruction is called tympanoplasty. So, match the following of the tympanoplasty: Woolstein's tympanoplasty type 2, 3, 4, 5. Type 2 is the graft placed over the remaining incus, and type 3 is the graft placed over the stapes, that is called columella. Type 4 is placed over the foot plate, that is called cavum minor. And type 5, you are making a fenestra in the lateral canal fenestration surgery, but it is obsolete, not at all done nowadays. Okay. So type 1 is called the graft placed over the all intact ossicles, malleus, incus and stapes. And type 2 is placed on remaining ossicle, commonly incus. Type 2. And type 3, malleus and incus are absent, and hence the graft is placed over the stapes head. So since only the stapes is present here, it is a single ossicle like middle ear, like in the birds. So it is called as columella. That single ossicle is called columella. That's why the type 3 is called columella tympanoplasty. And the most common tympanoplasty done is also columella tympanoplasty. That is also an MCQ. The most common tympanoplasty done is columella tympanoplasty. Type 4, where malleus, incus and stapes superstructure is also been eroded by the disease. Only the foot plate is placed. So the graft is directly placed over the foot plate of the stapes. If the foot plate is only present, if you place the graft, the middle ear volume space becomes very much minimal. So that minimal middle ear space cavity is called cavum minor. So the type 4 tympanoplasty is cavum minor, is placed on the foot plate of the stapes. And if the foot plate of the stapes is also fixed, in olden days they were placing the graft over the lateral semicircular canal, making a fenestration and making the graft. So that is not done nowadays. Now we are doing a fenestration surgery in the stapes foot plate itself. So that is called type 5. So type 6 is placing the graft over the round window, and the sound wave will go into the round window and comes out of the oval window. That is called sono inversion. So these are all the things not at all done nowadays. The following are the steps of modified radical mastoidectomy, except. So we need to know what all the mastoidectomies and what are the basic steps of mastoidectomies, because often they are asking nowadays the mastoidectomies. So following are the steps of modified radical mastoidectomy, except reduction of facial ridge, mastoid is exteriorized, ET orifice is plugged, ossicular reconstruction is attempted. Of course, we should not plug the ET orifice in case of modified radical, in which mastoidectomy ET orifice is plugged or closed. It is done in radical mastoidectomy. So what are all the points we are doing in each mastoidectomy is cortical, modified radical and radical. See, in any cholestoma patient, we will be doing a modified radical to completely eradicate the disease. And in case of cholestoma with the dead ear, the ear is totally lost, no hearing at all. We cannot repair the hearing, or any carcinoma of the middle ear. We have to do a radical mastoidectomy, or in a case of malignant otitis externa. These are the conditions where we will do a radical. So simply the radical and modified radical are nowadays called as canal wall down mastoidectomy. Please remember the terminology. Canal wall up mastoidectomy is cortical or simple mastoidectomy. So if you do a mastoidectomy and you are retaining the canal wall, posterior canal wall, and you are doing a middle ear work separately, that is called cortical or intact canal wall mastoidectomy or canal wall up mastoidectomy. Okay. In certain conditions like cholesteatoma, we have to remove this canal wall, posterior canal wall, both the superior and the posterior canal wall should be removed, so that the middle ear and the mastoid becomes a single cavity, so that everything is well exposed. So disease clearance is very easier if you remove this posterior canal. I told you the hidden cholestoma will be present in the posterior mesotympanum, the facial recess areas and the sinus tympani areas. So to remove the colostoma completely, the posterior meatal wall should be completely removed. So that is what they are doing. So this part of the canal wall is called as bridge. See, the postero-superior part of the canal wall lateral to the Otitis is called as bridge. That bridge is removed, and this part of the canal wall again lateral to the vertical part of the facial nerve is called facial ridge. That is also removed. So facial ridge is reduced to the level of facial nerve. So if you do so, you will get a condition like this. This is the canal wall down mastoidectomy. You can completely remove the colostoma and then reconstruct the hearing mechanism. We have to reconstruct the ossicular destroyed ossicles. Hearing mechanism should be reconstructed. And end of the procedure, since you have converted in the middle ear and the mastoid into a single cavity, the mastoid has been exteriorized. We have to widen the external meatus. The cartilaginous part of the external meatus has been widened, and this is called meatoplasty. Please remember this. So meatoplasty should be done at the end of the canal wall down mastoidectomy, so that the whole cavity is visualized post-operatively, and cleaning of the cavity can be done properly if do a wide meatus. Meatoplasty should be done. Please remember this point. They will be asking you in the exams. So this is about the modified radical. In the case of radical mastoidectomy, there is no need for hearing. We are dealing with a dreadful diseases like carcinoma, where we have to entirely remove the ossicles and the all mucosa of the middle ear. So if you remove the entire mucosa and ossicles, the middle ear is made dead. So where is the point of making the middle ear hearing, conductive hearing? No way. So after making the middle ear dead, you are plugging the eustachian tube orifice with the fat or muscle, so that the further ascending infections will not happen in the middle ear. So middle ear itself is dead. What is the role of eustachian tube? There is no need for keeping the eustachian tube. That's why eustachian tube is plugged in case of a radical mastoidectomy. That is done in extensive carcinomas or colostoma with the dead ear. So this is about this radical and modified radical mastoidectomies. Coming to the diseases. So we have the 4 diseases. What are all the diseases we have to look for is a disease for the middle ear, otosclerosis. A disease for the inner ear, Meniere's disease. Tumor of the middle ear, glomus. Tumor of the inner ear, vestibular schwannoma. So these are the things we have to look for. So each disease has a classical triad. Any young female coming with a bilateral hard of hearing and on examination a very normal appearing tympanic membrane is classically, you have to think about otosclerosis. Young females, bilateral conductive deafness commonly, and tympanic membrane very normal is otosclerosis. And elderly man with vertigo, hearing loss, and tinnitus in the same hearing loss here. Triad, vertigo, hearing loss, tinnitus, Meniere's disease, triad, classical triad. Elderly lady with tinnitus. What kind of tinnitus? Pulsatile tinnitus. And on examination, a red mass in the middle ear, rising in appearance. So classically, glomus tumor, paraganglioma. And an elderly man with unilateral hearing loss, unilateral tinnitus, and loss of corneal reflex. So unilateral hearing loss, unilateral tinnitus with vertigo is Meniere's. Hearing loss and tinnitus with loss of corneal reflex should be suspecting vestibular schwannoma. So these are all the classical triads of presentation of these diseases. So these are all the important MCQ points we have to note. Where will you get paracusis willisii, otosclerosis, roaring tinnitus, Meniere's disease, Brown sign? We will be seeing this in the topics. Brown sign glomus, Phelps sign glomus, electrocochleography. It's a diagnostic test of Meniere's disease. Sudden sensorineural hearing loss. Where do you get? Vestibular schwannoma, very typical condition. Tullio phenomenon, vertigo to the loud sounds, Meniere's. Pink tympanic membrane, active stage of otosclerosis, Schwartz sign. Stereotactic RT is typically indicated in vestibular schwannoma radiotherapy. Perilymph gusser is a typical complication of which surgery? Stepidotomy or stepidectomy. Hitzelberger sign, again the sign in vestibular schwannoma. Tumarkin crisis, Meniere's disease. So these are all the important areas of MCQs. Please remember these points and we will be seeing that. True about otosclerosis, family history is usually absent. Males are affected twice than females. More common in Negroes, may present as unilateral deafness. True. It is very important. Family history is usually absent. No. Males are affected twice. No. Females are quite common. More common in Negroes. It is more common in white people, white raised people. It's very rare in Negroes. May present as unilateral deafness. Yes, very true. That's very important. Otosclerosis is commonly bilateral presentation, but in 10 to 15% of patients, it is unilateral presentation. That's very important. Unilateral otosclerosis is also happen. Stepidotomy includes removal of all except. So stepidotomy is a treatment of otosclerosis. Includes removal of all except anterior crura of the stapes, posterior crura of the stapes, stapedius tendon, lenticular process of the incus. So you must not remove any part of the incus. So you are removing only the suprastructure of the stapes. And the incus is retained for the piston to be hooked upon in the incus. We will see that in the picture. So stepidotomy, where you should not disturb the incus at all. Clinical features of the otosclerosis, the most common site is fistula antifenestrum. The anterior part of the foot plate is the most common site, and the second most common site is fistula post fenestrum, posterior part of the foot plate. Paracusis villi, the patient hears better in noisy surroundings. It's a simple logic where in the noisy surroundings, everybody increase their voice and hence they are able to hear their voice. That's all. So in any kind of huge conductive hearing loss patients, paracusis villi will be present, and which is typically seen in otosclerosis patients. Swatch sign in active stage of otosclerosis where there is more vascularity, there is more bony turnover in the bony labyrinth. So then since there is increased vascularity, the bony labyrinth will be seen as a pinkish bone. So that is called a flamingo pink tympanic membrane or Swatch sign. It is indicative of active focus with increased vascularity. Okay. What is the treatment of otosclerosis? So normally this active stage of otosclerosis is very rare. And what is the treatment in case of active otosclerosis? Sodium fluoride should be given to stop this active maturation or active bone turnover. So sodium fluoride for 1 or 2 years should be given in case of active otosclerosis. If we do not have this active stage, this pink TM, we have to go for stepidotomy or stepidectomy. And this Teflon piston or titanium gold pistons are available. So what do you do in the surgery? So we have to see, we have the fixed foot plate. We are not modifying the disease process, but we are making the patient to hear. So the suprastructure anterior crura and posterior crura has been cut, and the stapedius tendon attached with the pyramidal process is cut, and this incus is dislocated from the stapes is dislocated from the incus. The suprastructure is removed as in this picture, and then you make a small fenestra in the footplate of the stapes, or some authors suggest entirely remove the footplate itself. So stepidotomy, making a fenestra, or stepidectomy, both are accepted and the right kind of treatment. So after that, after making the perforation, you had to, this kind of Cuisinart like piston is hooked around the long process of the incus, and that is inserted into the stapes fenestra, so that when the incus moves, the piston moves and induces the inner ear. So this is the treatment of stepidotomy. So during this procedure, very rarely the perilymph may gush out of the inner ear into the middle ear. So while removing the foot plate or making a fenestra, there is a chance for perilymph gusser. If there is a perilymph gusser, which happens in 1% of the cases, there is a chance for dead ear. Complete loss of hearing can happen in the patient. So this is a rare possibility, rare complication of the otosclerosis. That's why in a single hearing ear, if the patient is having only the single hearing ear, the other ear is not hearing properly or already having total or profound deafness, in a single hearing ear, better to avoid stepidectomy or stepidotomy, which may lead on to a complete dead ear. So in these cases, hearing aid is advised for the patient in case of a single hearing ear available for the patient. So this is about the stepidotomy or stepidectomy. All are true about features of Meniere's disease, except sudden fall over the ground with LOC, vertigo to loud sounds, associated with oral fullness, can involve bilateral ears. Yes, very typical. This is Tullio's phenomenon. Yes, it is also the vertigo will be associated with oral fullness, very typical symptomatology. During the vertigo episodes, they will be feeling a blocking sensation in the ear. It may involve bilateral ears. Yes, the Meniere's is usually unilateral but can involve bilateral ear. So answer is it is the sudden fall over the ground without LOC, that is called Tumarkin crisis, that happening in the late Meniere's disease. With the LOC will be seen only in the central pathology, syncopal attacks, not in the Meniere's disease. So in Meniere's disease, loss of consciousness will not be present. So this is the answer for this question. So Meniere's disease, endolymphatic hydrops, this is typically episodic vertigo, fluctuating SN hearing loss, roaring tinnitus, oral fullness due to the increased endolymphatic volume, and this is due to the sodium and water retention or due to the endolymphatic sac ischemia, or idiopathically it can happen. So these are all the things. Tullio's phenomenon we have seen. Tumarkin crisis is sudden fall over the ground without LOC, which happens in the late stage Meniere's due to deformation of the otolithic membrane due to the increased endolymphatic volume and pressure. This otolithic membrane will be disrupted while walking, and there will be sudden fall over the ground in the utricle. So this is Tumarkin crisis. And Lermoyes syndrome is reverse Meniere's disease. The patient will be having hearing loss and tinnitus initially, that will be relieved by the vertigo attacks. So this is called reverse Meniere's disease, which is uncommon, but the syndrome they may be asking the MCQs, Lermoyes syndrome, reverse Meniere's disease. Electrocochleography, this is a diagnostic test in Meniere's, but it is a research methodology. It is not done commonly in clinical scenarios, but they will be asking in the MCQs. Electrocochleography is endocochlear potential, summation of microphonics, action potential of cochlear nerve, evoked potential generated in cochlea and auditory nerve. So basically, electrocochleography determines the potentials in the cochlea and the auditory nerve, and we are comparing the potentials between the cochlear potentials and the auditory nerve potentials. So it is evoked potentials generated in cochlea and the auditory nerve combined both together. So electrocochleography is the diagnostic test where the probe is placed in the round window region and we are measuring the cochlear potentials. The ratio is SP by AP ratio. What is SP? Summating potentials from the cochlea. All the potentials, endocochlear potentials in the scala media and the microphonics from the outer hair cell activities, the summating collective potentials in the cochlea is compared with action potential of the eighth nerve. If this SP by AP ratio is, if it is more than 30% or more than 0.3, because see in Meniere's disease the cochlear potentials will be more due to increased endolymphatic volume, very simply. Obviously the summating potential will be increased, hence the ratio will be raised. So if it is more than 30% or more than 0.3, it is diagnostic of Meniere's disease in electrocochleography. And we have already seen the audiometry findings, upsloping audiometry, inverted V-shaped audiometry, or the audiometry findings in Meniere's disease. And one clinical test is called oral glycerol. The oral glycerol is a dehydrating agent. Orally it is given. So before giving this glycerol, audiometry is taken. If it is showing SN hearing loss, after giving glycerol, once the SN hearing loss is relieved, if the audiometry becomes normal, that is indicative of Meniere's disease. So oral glycerol test 1 hour before and 1 hour after the glycerol is taken, audiometry is taken, and look for the difference. So this is indicative of Meniere's disease. Treatment. They will ask you which is the first line treatment for Meniere's. There is no surgical treatment as a first line treatment. Please remember, the first line treatment is always medical treatment. We have to try it for at least 3 to 6 months. Labyrinthine sedatives, diuretics like thiazides because it is endolymphatic retention, vasodilators like beta histine which increases the local blood supply to the inner ear, and steroids are all the medical management that can be tried. If it gets failed, then the next step of management, more MCQ importance, is intratympanic gentamicin therapy. It is called chemical labyrinthectomy. So chemical labyrinthectomy, intratympanic gentamicin, we know it is a vestibulotoxic, and there is a chance for 30% of SN hearing loss that we have to explain to the patient, of course. So if the intratympanic gentamicin, Silverstein method, a grommet can be placed or a catheter can be placed into the round window, and if you apply the medicine from the external meatus, it will go in through the round window into the inner ear, it will go. Gentamicin. So it causes ablation of the outer hair cells degeneration, and of course mainly vestibulotoxic. The type 1 hair cells of the utricle and the saccule are commonly destroyed by the gentamicin. So rarely, in 30%, the outer hair cell degeneration can happen. That is a thing to be explained to the patient. So intratympanic gentamicin therapy or chemical labyrinthectomy is a very typically indicated therapy in case of Meniere's disease. It can be given as a single dose, or a 2 or 3 doses in a weekly interval can be given, commonly in a single dose treatment. Surgical. A commonly performed surgery is endolymphatic sac decompression. I told you the Trotman's area where you will expose the sac and open the sac and the endolymph is drained. And selective vestibular nerve suction, intractable vertigo is a main problem for the Meniere's patients. So in this case, selective vestibular nerve suction can be done to relieve the vertigo. Sacculotomy, fixed procedure, we have to open or drain the saccule, distended saccule, so that the endolymph will be drained. Or at the end stage procedure, no procedure is helping the patient, then you can go for labyrinthectomy. Completely remove the labyrinth as a dead ear. There is no neuroepithelium to get stimulated. So that is the labyrinthectomy as the end stage procedure in Meniere's disease. Coming to the tumors of the middle ear and inner ear. A patient presents with unilateral pulsatile tinnitus. Autoendoscopy is shown, which is true. So very typically, a rising synapse, a red mass behind the tympanic membrane. So paraganglioma or the glomus tumor, which is true. Most common in males, common in second and third decade, benign fast growing tumor, rarely multicentric. So it is typically most common in females. It is a female preponderant tumor. It is typically common in 5th to 6th decade elderly people. It is a benign but a very slow growing tumor. Glomus is very commonly slow growing tumor. It is not a fast growing tumor. Rarely it may be multicentric. That is a typical pattern of the glomus tumor. Multicentricity should be always thought of while you are dealing with glomus tumors, paragangliomas. So it can be multicentric. That is a true statement regarding the glomus tumor. And regarding the age group, very simple, no big confusions. Except the otosclerosis, which is typically young age, the third decade, which is typically the third decade females, and males, of course, commonly in females. All other diseases like Meniere's disease, glomus tumor, vestibular schwannoma, all are common in elderly people, commonly 5th to 6th decade. Please remember this, very easy to remember. So Meniere's, glomus, vestibular schwannoma, all are common in 5th to 6th decade. Okay. Glomus tumor, these are the most common benign tumor of the middle ear. They are from the paragangliomas, or typically from 9th and 10th level nerves. Glossopharyngeal and the vagus nerves are commonly involved. And the most common site in the middle ear is hypotympanicum, that is glomus jugulare is common rather than glomus tympanicum. Rule of 10, 10% are familial, 10% secrete catecholamines, 10% are multicentric because the paraganglionic cells are dispersed all along in the skull base, in the jugular foramen, and the neck along the carotid body. Even the carotid body is the most common paraganglioma we know. So it can be multicentric. Clinical features, pulsatile tinnitus, earliest symptom because this is more vascular. So that is earliest symptom. Rising sun appearance in the initial period, the tumor from the jugular foramen, jugular bulb, it will then actually the tumor is from not from the jugular vein, it is from the paraganglionic cells around the jugular bulb, the 9th and 10th nerve, where all along the paraganglionic cell rest will be present, which will enlarge as a tumor. So brown sign, when it is occupying the middle ear like this, if you give pressure over the tumor by the Siegel speculum, it will blanch with pressure and it pulsates vigorously. So that is called brown sign. And if you occlude the carotid, and again the tumor in the middle ear will blanch, that is called aquinose sign, because this tumor gets the blood supply from the carotids through ascending pharyngeal artery. Ascending pharyngeal artery is the feeding vessel for the glomus, paragangliomas, ascending pharyngeal artery. So, point to note. So, this is Zell-Ballen appearance. Just remember the histopathological appearance, Zell-Ballen appearance. Zell-Ballen appearance, the group of cells that is called ball of cells, Zell-Ballen appearance around the vascular plexus. Regarding the spread of this vascular tumor, there are two important vascular tumors in ENT. One is glomus tumor of middle ear and another one is juvenile nasopharyngeal angiofibroma. Both are benign and both are locally invasive. So these two tumors has its specific way of spreading. So the spread, uh, what is that? The grades of spread should be known for the glomus tumor and the JNA. So the glomus tumor involving petrous part of the temporal bone, type A, B, C, D. So it is type C. So how to remember what is the grading of spread? Fish grading of spread. It's quite easy to remember. Whenever the tumor is occupying the middle ear, it is A. Of course, from the middle ear, where else the tumor can easily go into from the middle ear? Mastoid. So type B is the tumor involving the mastoid. From the middle ear and mastoid, of course, it goes more deeper inside the petrous part of the temporal bone, type C. Once from the type C, it will enter into the intracranium, that is type D, intracranial spread. So in the stage of type C only, it will involve the internal carotid artery. That's a vertical part and the horizontal part. While traveling into the petrous part, it will engulf the carotid artery. So in the type C is the stage where it engulfs the carotid artery. Phelps sign. So to differentiate between the glomus jugulare and the glomus tympanicum, the Phelps sign is useful. It is typically erosion of cortico-jugular bony crust. In case of glomus jugulare, not in the glomus tympanicum. See, in this normal side, this is the bone. So this is a carotid and this is the internal jugular vein. So between these two things, the bony crust is intact. If this bony crust is eroded by the glomus jugulare, so that is called Phelps sign, where the opposite side, that crust is been eroded. So Phelps sign, cortico-jugular bony crust is eroded by glomus jugulare tumor, not by the glomus tympanicum, because jugulare is enlarging in the jugular foramen region. So it easily erode that neighboring bony crust. Given below is the histopathology slide of an operated mass of 50-year male who had tinnitus and sensorineural hearing loss in right ear for the past 7 years. He also had disequilibrium, which is false regarding this pathology. So HP slide is given a 50-year male, tinnitus, sensorineural hearing loss, unilateral right ear. Obviously, a unilateral sensorineural hearing loss and a tinnitus. And he also had disequilibrium. So the pathology here is very clear, vestibular schwannoma. So with the question itself, we can say a unilateral hearing loss and tinnitus and disequilibrium, and a mass is operated, and that mass, the slide is given. So if it is a disequilibrium, even if you take it as a vertigo, in Meniere's disease, there won't be any mass. But here a mass is been operated. So obviously, which is false regarding this pathology, this is vestibular schwannoma. Very slowly progressive hearing loss. Yes, correct. That is the typical nature of the vestibular schwannoma. Sudden SN hearing loss may occur. Yes, a sudden hemorrhage occurring inside the cyst or sudden enlargement will lead on to sudden sensorineural hearing loss. Facial paresthesia is a future. Of course, the vestibular schwannoma may compress the trigeminal nerve. That is the first cranial nerve compressed by the vestibular schwannoma, and that will lead on to facial paresthesia. Facial palsy is a common presentation. Not. That is a false. Facial palsy is very rare to occur in vestibular schwannoma. So facial nerve is a motor nerve. Motor nerve is very resistant to any compression, motor fibers. And hence the facial palsy is very rare presentation. It is not a common presentation in vestibular schwannoma. And typically this HP slide they are asking in the recent days, spindle shaped cells dispersed all along. So this is a schwannoma, Schwann cells. From the Schwann cells the tumor arises, nerve sheath tumor, vestibular schwannoma. So if it is overcrowded spindle cells, it is called Antony A pattern, and a very dispersed cells which is called as Antony B pattern. So Antony A, Antony B. In a solid tumors, Antony A very closely packed cells, and loosely packed cells are present in a cystic tumor, Antony B pattern will be present. Sometimes both may coexist. So this is about the vestibular schwannoma. So this is the most common cerebello-pointon angle tumor, very typical point, most common cerebello-pointon angle, and this is unilateral in 90% of the cases, and 5th to 6th decade is common. Bilateral vestibular schwannoma is seen in neurofibromatosis type 2, where younger people will be having the bilateral vestibular schwannoma. Usually in sporadic cases, in elderly people is common, but in neurofibromatosis type 2, bilateral vestibular schwannoma in younger people, even in the second decade, it may present. And what is the boundary of cerebello-pontine angle? So cerebellum, pontine, and this angle is the cerebello-pontine angle. So medially by the pons, posteriorly by the cerebellum, and laterally by the petrous temporal bone is present. And what are the contents of the CP angle? Of course, we have this 8th nerve and we have the 7th nerve, or the two contents. And along with this, we have this anterior inferior cerebellar artery, which is the supply for the labyrinth. Labyrinthine artery from the anterior inferior cerebellar artery is the artery passing through the cerebello-pontine angle. And in the roof of the CPA is the trigeminal nerve. That's why the trigeminal nerve, when the tumor is enlarging in this CP angle, it will compress the trigeminal nerve easily. So the trigeminal nerve forms the roof, and floor, of course, the jugular foramen is the floor of this petrous bone, 9th, 10th, and 11th cranial nerves. The common tabular column of MCQs from the vestibular schwannoma. The most common nerve involved arising from the which nerve? The inferior vestibular nerve leads to vestibular schwannoma. The earliest symptom is unilateral hearing loss with tinnitus. The earliest cranial nerve to be involved, compressed by the nerve, is 5th cranial nerve. And the earliest presentation of 5th nerve compression is decreased corneal sensitivity. Second cranial nerve that gets compressed is facial nerve. That's what I told you. The motor fibers are very late to get compressed, and hence the second cranial nerve is facial nerve. And the earliest presentation of the 7th nerve is hyposthesia, numbness of the posteromedial wall, Hitzelberger sign. So very typically, this is all the typical common repeated MCQs from the vestibular schwannoma area. And investigation, gadolinium MRI, contrast MRI is a very typical. We can very clearly see a appearance called in the internal acoustic meatus. The tumor will be present. Once it is outgrowing into the CP angle, it will be like this. So it is an ice cream cone appearance of the internal acoustic in the vestibular schwannoma in MRI. Treatment, of course, is a benign tumor. Surgery is a treatment of choice. Tumor is radio-resistant, benign, but in one condition. Translabyrinthine approach is the most common approach for the resection of the tumor. In one condition, stereotactic radiosurgery or radiotherapy is given in any patient unfit for surgery, but the patient has compressive symptoms, trigeminal nerve compression, cerebellar compression, or facial nerve compression. If the patient has compressive symptoms where the patient needs the tumor resection but he is unfit for surgery, that is the situation where stereotactic radiotherapy can be given. So stereotactic radiotherapy is a single shot radiotherapy for the tumor. So precise radiotherapy avoiding injury to the surrounding structures of the intracranium. That's why it is called stereotactic radiosurgery. Why it is called surgery? Single shot, single day therapy. Unless the radiotherapy for the malignant tumors for prolonged period, single day, single shot radiotherapy. So cobalt is used, that's why it is called gamma knife surgery. It is not a very cold knife surgery, it is called gamma knife surgery, and hence it is done to arrest the growth of tumor. It will not ablate the tumor. Please remember this point. That's why the MCQ point is tumor is radio resistant. It is not radio sensitive. So since we have read about stereotactic radiotherapy, we should not put this point as radio sensitive tumor. It is not radio sensitive tumor, but the therapy is given to arrest the growth of tumor so that the further compressive symptoms will not happen for a unfit elderly people. So this is the role of stereotactic radiosurgery or gamma knife surgery in vestibular schwannoma. And last area is the facial nerve in case of the ear. Okay. Dryness of eye and absent stapedial reflex are seen in a patient with a facial nerve injury. Following are the probable sites of injury except. So, dryness of the eye, a patient with facial nerve injury presents with dryness of eye and absent stapedial reflex. So, there are topodiagnostic tests. Based on the symptomatology of the facial nerve functions, we need to assess where can be the common site of facial nerve injury, so that during surgery we can concentrate on that area to decompress the nerve and rejoining the nerve. So this is the importance of the topodiagnostic test. So if the patient is presenting with dryness of eye in a facial nerve injury, where is the common site of injury? And the question here is, following are the probable sites of injury except vertical segment, cerebellopontine angle, geniculate ganglion, labyrinthine part. So if there is a site of injury, site of presentation, the injury should be proximal to that branch. That's all, very simple. So the injury can be at cerebellopontine angle, geniculate ganglion, labyrinthine part, because dryness of eye will occur only when GSPN is involved, greater superficial petrosal nerve, which is parasympathetic supply to the lacrimation, and hence the injury can be at first genu, that is geniculate ganglion or CP angle, labyrinthine part, not in the vertical segment. If the injury is at vertical segment, patient will not be having dryness of eye and will not be having the absent stapedial reflex. Both will be functioning normally. So this is about the topodiagnostic test. So this is the nerve, facial nerve, which we need to know. From the brainstem, it passes through the intracranium and translabyrinthine, intralabyrinthine part, and it takes a first genu where it gives a first nerve called greater superficial petrosal nerve, and it takes a horizontal traveling and take a second genu just at the level of second genu, just after the second genu, it gives a nerve to stapedius, and it takes a vertical course inside the middle ear, and before exiting from the stylomastoid foramen, it gives cauda tympani, some 5 to 7 millimeter above the stylomastoid foramen from the vertical segment cauda tympani. After exiting from the stylomastoid foramen only, it is giving multiple motor branches, the auricular muscles, nerve to digastric, posterior belly of digastric, nerve to stylohyoid muscle, and the terminal branches, pes anserinus, like this temporal, zygomatic, buccal, mandibular, and cervical branches are given to the facial muscles. So this is the course, and the MCQ point here, which is the shortest and the narrowest segment of entire facial nerve course, labyrinthine segment. So it is 4 millimeter in length and 0.4 millimeter in thickness. So the entire course of the facial nerve, the labyrinthine segment is the narrowest and shortest segment, and hence any edema will commonly cause labyrinthine segment compression, and that is the most common site of compression due to edema, labyrinthine segment. In Bell's palsy also, the labyrinthine segment is commonly involved. That is the point. So topodiagnostic test for intratemporal lesions, we have to do a Schirmer's test for lacrimation, stapedial reflex test for nerve to stapedius, electrogustometry for the cauda tympani, and submandibular salivary flow test again for cauda tympani, and motor function test are been done. So very simply, see, if the nerve has been injured proximal to its all branches, the first branch, second branch, third branch. If it is proximal to all branches, or at least at the level of the first branch, all the functions will be lost. Lacrimation is out, nerve to stapedius is out, and the chorda tympani is out. So all the symptoms will be present for the patient. If all the symptoms are present, that means the injury is proximal to all the branches. Very simple. Okay. Let us consider the injury is at the horizontal segment. What is the problem? The lacrimation will be present normally, but the nerve to stapedius will be out and the chorda tympani will be out. Likewise, we have, if the nerve injury is at the after stylomastoid foramen, like in parotid abscess. After exiting from the stylomastoid foramen only, the nerve is being injured. Parotid tumors, malignancies, or parotid abscess. All the three functions will be present for the patient except the motor function. Lacrimation will be present, chorda tympani will be acting, and the nerve to stapedius will be acting, but the motor functions will be lost. So likewise, based on this topodiagnostic test, we can say where the probable lesion is at for the facial nerve. Patient with the Bell's palsy, all are true except immediate surgical decompression, sudden unilateral palsy, herpes simplex is a cause, virus is a cause, steroid is a treatment of choice. Of course, there is no role for immediate surgical decompression. Bell's palsy has a wonderful prognosis even without treatment many times. So there is no role for immediate surgical decompression. Only the conservative management helps. So another question from the Bells. A case of Bell's palsy took native medicine. He presented to ENT OPD after 5 days with complete palsy. Native medicine. After 5 days with complete palsy, he was put on oral steroids, but shows no improvement even after 2 weeks. Next step in the management is, so any Bell's palsy, no improvement at 2 to 3 weeks, complete palsy. No improvement, complete palsy. Please remember this term, complete palsy. So what is your the next step in the management? Increase the dose of steroid, vasodilators, surgical decompression, electrophysiological nerve testing. Of course, you can go for surgical decompression, but before going into the surgical decompression, we have to exactly know what is the level of degeneration the nerve has. So for that, we have to do a test called, answer is D, electrophysiological nerve testing. Electroneuronography, ENOG, should be done before considering surgical decompression for this patient. So that is the answer for this question. So this is the commonest cause of acute onset LMN facial nerve palsy. HSV1 is the etiology, site is labyrinthine segment, steroids and physiotherapy as a treatment, and the late complication of the Bell's palsy is due to synkinesis, faulty regeneration, gustatory lacrimation, crocodile tears. And what is the treatment of crocodile tears? Botulinum toxin injection to the lacrimal gland is the treatment, recent treatment for crocodile tears, gustatory lacrimation due to the faulty regeneration. The parasympathetic supply, instead of going to the submandibular salivary glands, it goes to the lacrimal glands, the parasympathetic supply. So there will be gustatory lacrimation. So botulinum toxin, it should be repeated every 6 months into the lacrimal gland to alleviate the symptoms. Okay. So at the end of 2 weeks, if the patient has this point, if the patient has no recovery at all, complete palsy at 2 weeks, complete palsy at 2 weeks, what will you do? You have to do electroneuronography. As in the picture, we have to stimulate the facial nerve at its exit point after the stylomastoid foramen and look for the muscle potentials. And if there is only one point, very simple, there is no much confusion. If there is less than 90% degeneration of the nerve, you have to do wait and watch with conservative management. Less than 90% is degenerated. If the fibers or nerve fibers are more than 90% degenerated, then you have to go for surgical decompression. So this is the one important criteria of electroneuronography. So the end of 2 weeks, so the patient has complete palsy, no recovery at all. So on doing electroneuronography, if there is less than 90% of degeneration, wait and watch, there is a chance for recovery of the facial nerve. If there is more than 90% of degeneration of the nerve fibers, better go for a facial nerve decompression. So this is surgical decompression, surgical treatment for the Bell's palsy. So this is the role of electroneuronography at the end of 2 weeks of complete palsy. Which is the correct statement regarding facial nerve palsy in temporal bone fractures? Temporal bone fractures where the facial nerve palsy is quite common. More common with the transverse fractures, more common with the longitudinal fractures. Facial palsy is always of delayed onset. It is not associated with CSF leakage. So very typically answer is this more common with transverse fractures. The facial nerve palsy has been transected. Facial nerve is cut in case of transverse fractures. It's quite rare in longitudinal fractures. So facial nerve is always of delayed onset. No, it can be immediate or delayed onset. Many times it can be associated with CSF leakage. Okay. Regarding the temporal bone fractures, few points to note in the temporal bone fractures. Either it can be a longitudinal fracture, as in the red line crossing longitudinally across the petrous bone, or it can be a transverse fracture. It cuts across the labyrinthine segment, across the petrous temporal bone. So, since in this fracture, it is cutting the inner ear across, there is more chance for cutting the facial nerve. So, the facial nerve palsy is common in transverse fractures. But the most common type of fracture we encounter is longitudinal fracture, because the fall of face during RTS commonly over the lateral aspect. So whenever the mode of injury is in the lateral aspect, longitudinal fracture is commonly occurring, which passes longitudinally across the petrous bone, which will cross away from the inner ear. So since it is away from the inner ear fracture line, it will not cut the facial nerve. So the most common fracture is longitudinal. See this tabular column. Most common fracture is longitudinal, but most commonly facial nerve is injured in transverse fracture. And once it is transected, cut in transverse fracture due to fracture line, it is immediate onset palsy. But in longitudinal, due to the surrounding edema that may develop, it may compress the facial nerve after 3 to 4 days. That is called delayed onset palsy. And the treatment in longitudinal fracture, it is not cutting the nerve, only the edema causing compression. Hence, give steroids, wait and watch is the treatment. But in transverse, the fracture line has cut the nerve, so immediately we have to decompress the nerve, rejoin the nerve, then only the fibers will regenerate. So surgical decompression is the treatment. So this is very important. So decompression is done whenever the palsy is complete and immediate, which happens in transverse fractures commonly. Most common cause of facial palsy, Bell's. Most common complication of Bell's is exposure keratitis. Late complication of Bell's is crocodile tears. Please remember, the most common cause of facial palsy at birth is birth trauma, forceps delivery. Most common anomaly, congenital dehiscence above the oval window region, which is quite commonly seen during surgeries. Most common site of traumatic injury, that is RTA injury, is around the first genu, perigeniculate ganglion, around the first genu, labyrinthine segment and first genu. Most common site of iatrogenic injury, surgical injury, please remember second genu, because the second genu is related to the mastoid. So whenever you are drilling the mastoid antrum, you may injure the facial nerve sometimes. So second genu is the most common site of injury, iatrogenic injury. So this is about some of the MCQ points in the facial nerve. Coming to the nose. So this is the area where we will be covering the nose and then the throat. So at this point, we'll go for a small break and then we'll be back after 5 minutes. Okay, so we'll start with the nose. See here, the basics of ear is always I take little more time usually for a little understanding of the concepts or understanding of all those basics of ear. So nose and throat, it's more like easy to understand. We can easily sail through the questions. So we can finish with the nose and throat in the remaining time. Okay, we'll start with the nose questions. The nasal valve is bounded by all except septum, columella, lower end of the upper lateral cartilage and inferior turbinate. So the answer is columella except. So medially it is bounded by the septum and laterally by the anterior end of the low inferior turbinate, and external landmark is the caudal border lower end of upper lateral cartilage. So this is the nasal valve region, and externally we have this the nasal structure is formed by the pair of nasal bones and the pair of frontal process of maxilla and a single nasal process of frontal bone. And the cartilaginous structure, we have this upper lateral cartilage pair of lower lateral cartilage and a pair of lesser alar cartilage and unpaired septal cartilage. That is very important. The septum also contributes, nasal septum contributes to the support of the external cartilaginous part of the nose. So this is about the external nose. And regarding this nasal valve region, which is the narrowest part of the nasal cavity, which provides some end expiratory pressure for our expiratory airflow. So medially this, see the hairy area is the vestibule and this structure area is the nasal valve region, the posterior part of the vestibule region. So medially by the nasal septum and laterally by the anterior part of the inferior turbinate, and externally the caudal border of the upper lateral cartilage forms the limit of nasal valve region. So these are all the boundaries of nasal valve region. Okay, and there is one more common MCQ on this nasal valve. If there is any obstruction at the nasal valve region, for example, a deviated nasal septum at the nasal valve region, by pulling the cheek away, this obstruction will be relieved, and this test is called Cottel's test, which is the test for patency of nasal valve area. That is the point regarding Cottel's test. Coming to the lateral wall, turbinate that articulates with the ethmoid is superior, middle, inferior, all the above. So it is a simple question but a tricky question. See, turbinate that articulates with ethmoid. What are the parts of ethmoid? Superior and middle turbinates are the parts of ethmoid basically. So which turbinates articulate with these two turbinates? Obviously the answer is inferior turbinate. Very important, please remember this. So inferior turbinate is the turbinate that articulates with the ethmoid, both superior and middle. That's a very important point. Coming to this sagittal view, please remember what all the structures, how it looks like. This is the inferior turbinate, middle turbinate and superior turbinate, and this is the anterior sinus is the frontal sinus, and the posterior sinus is sphenoid with its sella turcica for the pituitary. And this, the cristogalli cribriform plate, this is the cristogalli, and the cribriform plate is the anterior skull base is this line, and the superior and middle turbinate, all this together forms the ethmoid bone. So ethmoid bone is present in the middle part of the sinonasal region, anteriorly frontal, posteriorly sphenoid on either side by the maxilla and the orbit. So this is the arrangement of the ethmoid bone in the middle of the sinonasal region. And if you take the coronal picture of the sinonasal region, the green lines are the typical ethmoid bone. So the ethmoid bone has the perpendicular plate of the nasal septum, cristogalli. See, cribriform plate on either side of the cristogalli, cribriform plate, and we have the superior turbinate and the middle turbinate with the ethmoidal air cell system for each nasal cavity, ethmoidal labyrinthine system, and lateral wall of the ethmoidal bone which is called as lamina papyracea, and this lamina papyracea forms the medial wall of the orbit, lateral wall of the sinonasal region and medial wall of the orbit, and thinnest wall of the orbit is also this lamina papyracea, but the weakest wall of the orbit is inferior orbital wall where we have this infraorbital foramen, infraorbital fissure. So the weakest wall is of the orbit is inferior orbital wall where the blowout fracture will lead on to contents, herniation of the orbital structures. So lamina is the thinnest wall of the orbit. So these are all the structures of the this ethmoidal bone. So this is how it will be seen in the CT scan. See, the nasal septum is present here, and we have this inferior turbinates, and we have the middle turbinates, slender turbinates, and this wall is the lamina papyracea, and this is the crista galli, and this is the cribriform plate of ethmoid, the skull base region. So the whole bones with this middle and superior turbinate are all the ethmoid bone. So we have this orbit on either side and maxilla on either side. So this is about this ethmoid arrangement. Okay. And these turbinates encloses meatus spaces, inferior, middle and superior meatus, and in each spaces certain structures drains into that area, and middle meatus is a very important area. So in the inferior meatus, we know the nasolacrimal duct drains, and what is the direction of nasolacrimal duct from the lacrimal sac into the inferior meatus? DOB, downwards, outwards, backwards. DAM is the mnemonic for the eustachian tube, and DOB, date of birth, downwards, outwards, backwards is the mnemonic for the nasolacrimal duct pathway, and it opens at the junction of anterior 1/3 and posterior 2/3 of the inferior turbinate is the highest point and is closed by a valve called Hasner's valve, univalvular structures, Hasner's valve. And in the middle meatus, we have the three important sinuses, frontal, maxillary, and the anterior ethmoidal group, all opens into the middle meatus. That group is called osteomeatal complex. And superior meatus, we have the posterior ethmoidal sinuses, and sphenoethmoidal recess is the where the sphenoid sinus between the septum and all the turbinates on one side. Sphenoethmoidal recess, sphenoid sinus. And in the middle meatus region, if the middle turbinate is broken down, two important structures are visualized. Please remember, the prominent bullous air cell of the ethmoid is called the bulla ethmoidalis, and the boomerang shaped bone is called, this is the bone, uncinate process. So this bone covers the maxillary sinus. So uncinate process and the bulla ethmoidalis are the two important components of the osteomeatal complex, and the bulla ethmoidalis is the most prominent and persistent ethmoidal air cell. The following form the boundaries of osteomeatal complex except basal lamella, lamina papyracea, middle meatus, middle turbinate. It's a very classical thing, very simple to answer. See, basically the osteomeatal complex is present in a space called middle meatus. It is not a boundary. All other things forms the boundary of osteomeatal complex. In what way? I tell you. See this. The osteomeatal complex, the components are the maxillary and frontal sinus ostium, bulla ethmoidalis and uncinate we have seen now, and two spaces, infundibulum and hiatus semilunaris. What are they? Infundibulum and hiatus semilunaris. See this picture. So this is the inferior turbinate and this is the middle turbinate. This is the middle turbinate and this is the inferior turbinate. So the space enclosed by the middle turbinate is the middle meatus where the osteomeatal complex is present, and this is the bulla and this is the uncinate bone. See this is the uncinate bone, a slender bone covering the maxillary sinus ostium here. Okay, the pathway from the ostium to the tip means this pathway from the ostium to the tip of the uncinate, the free border of the uncinate is called infundibulum, and The opening between the free border of the uncinate and bulla is called hiatus semilunaris. So simply from the maxillary sinus, the mucus drains through a pathway is called infundibulum and exit out of the gate is called hiatus semilunaris. The free border of the uncinate and bulla, that is the gate, is called hiatus semilunaris. So this is about the infundibulum and hiatus semilunaris in the osteomytal complex. Regarding the boundaries, it's very again simple. This osteomytal complex. So this is the osteomytal complex, and obviously laterally it is bounded by the lamina papyracea, and medially it is bounded by the middle turbinate, and superiorly it is bounded by the skull base. Of course, the fovea ethmoidal is the skull base, and posteriorly, see this. This is the picture again. Posteriorly, the ground lamella of the middle turbinate, the oblique part of the middle turbinate is the posterior limit. So these areas are anterior ethmoids and these areas are posterior ethmoids covered by the superior turbinate. So if you breach the ground lamella, you will enter into the posterior ethmoids. So this is the ground lamella. Which is the ground lamella or basal lamella? Basal lamella or ground lamella. The attachment, the oblique attachment of the middle turbinate is called ground lamella or basal lamella. So this is the anterior vertical attachment of the middle turbinate, and this is the posterior horizontal attachment of the middle turbinate, and in between is the oblique attachment of the middle turbinate, which separates anterior ethmoids and the posterior ethmoids. Please remember this. That is called ground lamella or basal lamella. Okay. It is a posterior boundary of the osteomytal complex. Diagnosis of a marked area on the CT scan. This is been marked. What is the diagnosis of the marked area on the CT scan? Of course. So what is the sinus we are seeing? We are seeing the posteriormost sinus above the choana. See this choana. Choana is seen very clearly. So the sinus above the choana will be the sphenoid sinus. So in the sphenoid sinus, a cell is been marked. What is that sphenoid sinus? Optic nerve, Onodi cell, Haller cell. So the answer is it is Onodi cell. There are certain named cells inside the sinonasal region which are having a very typical anatomical and clinical significance. What are they and how to identify those cells? A pneumatized middle turbinate. See this, on the left side it is a normal middle turbinate, and on the right side see this. This is the pneumatized middle turbinate, the air containing middle turbinate, that is called as concha bullosa. That is called concha bullosa. So this causes obstruction of the maxillary sinus drainage and causes maxillary sinusitis, and this is the most common anatomical variant of the ethmoidal air cell system. So the ethmoidal air cell system only, it is pneumatizing this middle turbinate also. So concha bullosa. Next, these two pictures. The anteriormost ethmoidal cell sitting in the floor of frontal sinus is called agar nasi. The anteriormost ethmoidal cell. See, even the maxillary sinus has not been originated. Only the inferior turbinate is seen on both sides. So at this level, a cell is present. That is the anteriormost ethmoidal cell. So that is agar nasi, which sits in the floor of the frontal sinus, can obstruct the frontal sinus drainage. This is a coronal picture we are giving. If you see with the sagittal picture, see this. Again, we have this frontal sinus, the posteriormost sphenoid sinus. This is the agar nasi cell. This cell is the agar nasi cell. Anteriormost cell is the agar nasi cell. So that is sitting in the floor of the frontal sinus, agar nasi. Okay. Any cell sitting in the floor of the orbit is called Haller cell. That may obstruct the maxillary sinus drainage. Haller cell, infraorbital cell is the Haller cell. And coming to the Onodi cell. the posterior most ethmoidal cell, the violet cell, posterior most ethmoidal cell entering into the sphenoid and engulfing the optic nerve. This is optic nerve, engulfing the optic nerve. The posterior most ethmoidal cell entering into the sphenoid and engulfing the optic nerve is the Onodi cell. O for optic nerve. So Onodi cell engulfs the optic nerve. A for anterior ethmoidal cell, agar nasal cell. O for optic nerve, Onodi cell. So when there is Onodi cell, it will be seen like this. See, the sphenoid sinus, it will be divided into a vertical, by the vertical septum into two sphenoidal sinuses. Whenever there is a cell above a horizontal septum, that is a Onodi cell. So whenever you see a cell above a horizontal septation inside a sphenoid, that is a Onodi cell. Very simple. That is, the Onodi cell will engulf the optic nerve. This is optic nerve. This soft tissue is the optic nerve on both sides of the sphenoid. Inside the sphenoid, there are two important structures: optic nerve and the internal carotid artery in the lateral wall of the sphenoid sinus. Very important. So these two important structures are passing through the sphenoid sinus, and these structures can be dehiscent in 10% of the patients. So you should be very careful in operating inside the sphenoid. Again, if you find a node cell, the optic nerve will be very close to your operation surgical area. So you should be very careful. You should not injure the optic nerve. That is the significance of optic nerve. And again, you will have a correlation with this sagittal section. See this. I told you the anterior most cell is the ethmoidal cell, the agar nasi. See, the posterior most cell encroaching into the sphenoid is called Onodi cell. Simple. When this posterior most cell, if it encroaches into the sphenoid, then it is called Onodi. So obviously there will be a horizontal septation like this, so above which the Onodi cell will be present. So this is about the Onodi cell, which engulfs the optic nerve. Coming to the nerve supply. Surgeon gives infiltration as shown in the picture. Which nerve is he infiltrating? Very clearly, he is infiltrating at the junction of a bony and cartilaginous junction of the external nose. Infratrochlear nerve, anterior ethmoidal nerve, nasopalatine nerve, infraorbital nerve. So typically he is infiltrating the anterior ethmoidal nerve. So we need to know where is this anterior ethmoidal nerve and what are the other areas of infiltration to know about this. So what are all the nerve supply of the nose we have to see. See, we will see that. The nerve supply of the nose, internal supply and external supply of the nasal cavity, sinonasal region. The internal supply we will see. Internally, the roof we have the olfactory fibers. Apart from that, the lateral wall, the upper part of the lateral wall is supplied by the V1, the anterior and the posterior ethmoidal nerve, and remaining part are supplied by the V2, nasopalatine branch of the maxillary division of the trigeminal nerve. That's all, V1, V2. In the lateral wall, the upper part is supplied by, upper 1/3 is supplied by the V1, and the whole remaining part will be supplied by the V2, nasopalatine nerve. There is the internal supply. So externally, again, it's easy to demarcate with these two box-like things. From the root, dorsum and the tip, this box is supplied by the V1, and the lateral part of the nose and the vestibule area and the cheek area are all supplied by the V2, infraorbital nerve. So these are the two divisions. So please remember, in the V1 and V2 divisions, in the lateral wall, V1 is through the anterior and posterior ethmoidal nerves. We know that is the ethmoid area, superior turbinate and the middle turbinate. So obviously anterior and the posterior ethmoidal nerves. And all the remaining nerves are by the nasopalatine or sphenopalatine nerve from the V2, V1, V2 or the supply for the sensory supply for the nose. And externally also, that from the root and to the tip is V1, and V2 is by the infraorbital nerve through the infraorbital foramen, supplies the lateral part and the vestibule. And in the V1 region, please have some good anatomy. So in the V1 region, in the nasociliary nerve, from the ophthalmic division V1, it gives a branch called nasociliary nerve. The nasociliary nerve has infratrochlear branch, anterior ethmoidal nerve, and posterior ethmoidal nerve. Nasociliary nerve has infratrochlear, anterior ethmoidal, posterior ethmoidal. So this is the point of exit of infratrochlear nerve below the trochlea. So infratrochlear nerve obviously supplies the root of the nasal cavity, and at the junction of the bony cartilaginous junction, the external branch of the anterior ethmoidal nerve. We know the lateral wall we have the anterior and the posterior ethmoidal nerve supplying, and external branch of the anterior ethmoidal nerve supplies the tip and the dorsum of the nasal cavity. So these are the two nerves externally from V1 supplies, and V2 through the infraorbital nerve. So now look at the points of infiltration. So if the patient is been infiltrated at this point between the medial boundary of the eyebrow and the inner canthus, this is the point, is the exit point of infratrochlear nerve. If the infiltration is given deep in the medial wall of the orbit, that is nasociliary nerve itself is been infiltrated. Common, the main branch itself, nasociliary nerve itself is been infiltrated. But if the infiltration is shown at this point of infratrochlear nerve, that is the infratrochlear nerve, and then exit point for the anterior external branch of anterior ethmoidal nerve, the bony cartilaginous junction. So that is the point of exit of external branch of anterior ethmoidal nerve, and at the level of infraorbital foramen, that is the mid level of this infraorbital ridge, is called infraorbital nerve infiltration. So these are all the areas of infiltration of the nasal cavity. So obviously in this question it's at the level of C, bony cartilaginous junction, external branch of anterior ethmoidal nerve. If the infiltration is given at this level, that is infratrochlear nerve, and if it is deep into the medial wall, then that is the nasociliary branch. So these are all the infiltration sites of this nerves. A newborn child develops cyanosis at rest and relieved by crying. There was profuse mucus stasis in both nasal cavities, which is not associated with the condition. So we are starting with congenital anomalies of the nose. A newborn child develops cyanosis at rest and relieved by crying. Very typically it is called paradoxical cyanosis or cyclical cyanosis, which is been given. Usually in congenital heart diseases, cyanosis will be aggravated by exertion and relieved by rest. But here cyanosis at rest and relieved by crying. There was profuse mucus stasis in the both nasal cavities. So obviously the diagnosis is choanal atresia, the most common congenital anomaly of the nose, which is not associated with the condition. Absent cold spatula test, congenital heart defect, positive Furstenberg test, McGovern's technique. So answer is positive Furstenberg test. The positive Furstenberg test is typically seen in encephalocele. It is not seen in choanal atresia. All other things, since it is atresia choanae, cold spatula, no fogging. Congenital heart defect is a typical association charge syndrome, and McGovern's technique is the urgent treatment in bilateral choanal atresia because it is an emergency situation, urgent situation. So points regarding this choanal atresia, the unilateral is common, right side is more common. Cyclical cyanosis or paradoxical cyanosis, whenever there is a bilateral choanal atresia, the babies, the neonates are obligate nasal breathers because the soft palate and the epiglottis will be touching each other, highly placed larynx. They can breathe and swallow simultaneously. So whenever their nose is occluded, they cannot breathe through the mouth because larynx is highly placed larynx. So they'll go for cyanosis. So cyanosis at rest, and during crying, the more air will be gushed inside the larynx and the cyanosis is relieved. So that's why it is relieved by crying. It is common in females, and the atresia will be mixed kind of atresia, bony and membranous atresia in more than 70% of the people, and Charge syndrome is the common association in more than 50% of corneal atresia. This is coloboma iris, heart defects, atresia corneae, retarded growth, genitourinary anomalies, and ear defects are the association of Charge syndrome. So this is how a unilateral corneal atresia looks like, but the bilateral corneal atresia is a emergency. So whenever you want to relieve the cyanosis, immediately you will place a wide bore nipple inside the oral cavity so that the air will enter into the oral cavity and that cyanosis will be relieved. This is called McGovern's technique. And the definitive treatment is endoscopic or transpalatal widening of the corneal area so that the baby will be relieved, and stenting should be done for at least 6 to 8 weeks to prevent restenosis. And again, a common question will be asked in these areas. The mitomycin C is applied at the end of the surgery, at the area of surgery, to prevent restenosis, to prevent refibroblast activation. So antifibroblast factor is the mitomycin C. It is applied at the end of the surgery. So this is the treatment about corneal atresia. Furstenberg test. Where will you see? Soft, pulsatile, compressible, transilluminant swelling, either externally or the intranasally. Any child, infants coming with a polyp, unilateral polyp, which is soft, a bluish, pulsatile, transilluminant, and it increases on crying. Whenever there is increased intracranial pressure, or if you apply pressure over the internal jugular vein bilaterally, this will improve, it will increase in the size. That is called Furstenberg test. So this is called congenital meningoencephalocele. Immediately you have to advise a MRI where you can encounter a skull-based defect, and the meninges and the brain will plunge into the nasal cavity as a polyp-like structure. So treatment is you have to resect this polyp, and you have to redefine the skull base, or we have to close the skull base. So that is the treatment of this congenital meningoencephalocele. You should not, the MCQ point here is you should not pluck or take a biopsy. It will lead on to profuse years of leak. Which is false regarding submucous resection of the nasal septum. Coming to the nasal septum and the disorders of the nasal septum. So which is false regarding submucous resection of the nasal septum? Killian incision is made, not indicated in children, caudal strut is left behind, septal spur is left behind. Which is false regarding SMR. There are two kinds of surgery of the nasal septal deviation: submucosal resection and septoplasty. So what are they? Which is false? Killian incision is made in SMR. Yes. It is not indicated in children. Definitely you should not resect the major part of the septum in children. Caudal strut is left behind, septal spur is left behind. Actually, you should remove the septal spur. Any spur associated with the septal deviation should be removed. You should not leave back the spur. But the caudal strut is left behind in case of submucous resection. What is that caudal strut? We will see that. This is a very important point in submucous resection. See, there are two conditions. Two types of surgery, SMR and septoplasty. SMR is a radical resection of the deviated nasal septum, and septoplasty is a conservative approach. So you should not resect any major septum, but you have to realign the septum in the midline. So this radical resection of the septum, SMR, is contraindicated in two situations. One is in the anterior deviation, and another one is children less than 17 years. So in these two conditions, if do not do SMR. So if you resect the anterior part of the nasal septum, it will lose the support to the columella on the dorsum, and saddle nose deformity will occur. And under the 18 years, 17 years, it will lead on to mid-facial growth affection. So you should not do. In these two conditions, the surgery that is indicated is septoplasty. So septoplasty is more conservative surgery. Okay, and the incision made is Killian's, and here it is called Freer's incision. Okay, in SMR, two struts should be left behind. See, in case of submucous resection of the nasal septum, while removing the spot of the nasal septum, this dorsal strut, which gives support to the dorsum of the nose, and caudal strut, which gives support to the columella of the nose, these two struts should be left behind so that the support is lost, not lost to the external nose. So if you remove these two areas, the anterior part of this dorsal and caudal struts, saddle nose deformity will occur. So this is a very important point to note. So this L-shaped strut is always left behind while removing any deviated nasal septum in SMR. So this is a point for preserving the support to your external nose. So this is the point regarding this SMR. Dorsal strut and caudal strut are left behind. And this is the caudal test, pulling the cheek away, and if the nasal obstruction is relieved, that means we are dealing about nasal valve obstruction. An young female presents with nasal obstruction, nasal discharge, and loss of smell for 2 years. On examination, the nose is filled bilaterally with yellow-green crust with feet hair. Which of the following will be the most likely finding in the nose? So obviously we are dealing with young female, nasal block, nasal discharge, anosmia, yellow-green crust, and feet hair, bad odor. So very typically atrophic rhinitis, very typically. Which is the most likely finding in the nose? Roomy nasal cavities, nasal polyps, foreign bodies, inferior turbinate hypertrophy. So the answer is roomy nasal cavities. So atrophic rhinitis is a typical diagnosis we are making here. And in the atrophic rhinitis, every turbinate will be shrunken, all the atrophy of the mucosa will happen, and the roomy nasal cavities, no humidification at all, and profuse thick yellow-green crustings will be present, and these crustings occupy the entire nasal cavity and more nasal block for the patient, and even the olfactory fossa will be lost, will be atrophied, and complete anosmia will be present. And the triad is roomy nasal cavities, foul-smelling dry crustings, and merciful anosmia. Why it is merciful? The patient herself cannot able to perceive her own bad smell, but the neighbors will perceive the bad smell. So God has shown some mercy upon the patient. She is not perceiving her bad smell. It's such a bad odor the patient will be having. So this is called a merciful anosmia. Medical treatment, again and again they will be asking these areas very commonly. Alkaline douching, irrigation of the nasal cavity is must. Sodium bicarbonate, sodium biborate, and 2 parts of chloride. So sodium salts are taken as single part, and chloride salt is taken as 2 parts. So regular irrigation of the nasal cavity should be done to improve the nasomucociliary clearance, and 25% glucose and glycerin packings are done to prevent the proteolytic organisms and for the hygroscopic action of the glycerin. And regarding the surgery, closure of the nasal cavity, external nares, Young's operation, if you leave behind a small opening, that is called modified Young's, and injection in the lateral wall to augment the lateral wall to increase the surface area is called Lawton's-Logger operation. And what is rhinitis sicca? See, atrophic rhinitis is a condition that will be a diffuse atrophy of the entire nasal cavity, which is idiopathic in nature, genetic predisposition is there. But sicca, the dryness will be present only in anterior 1/3 of the nasal cavity. It is not involving the entire nasal cavity. It is typically seen in the people working in the hot areas, like fast food cook. These are all the people, they will be developing this rhinitis sicca. So just avoiding the workplace and regular nasal saline douchings will improve the dryness of the anterior part of the nasal cavity. That is called rhinitis sicca. Vidian neurectomy is done for vasomotor rhinitis, rhinitis sicca, allergic rhinitis, atrophic rhinitis. So very typically, Vidian nerve is the combination of GSPN plus deep petrosal nerve, which is a parasympathetic and sympathetic supply to the sinonasal regions and the palatal and pharyngeal glands. So since there is a idiopathic parasympathetic overactivity in the vasomotor rhinitis, so vasomotor rhinitis is otherwise known as idiopathic rhinitis, there will be a parasympathetic overactivity, excessive rhinorrhea or congestion. So in these cases, again, topical steroids are the treatment of choice as the initial treatment. When it is becoming intractable, Vidian neurectomy can be done. You can cut the parasympathetic supply and the vasomotor rhinitis will be relieved. And what is this? This actually pale blue turbinate. So this is not the vasomotor rhinitis. This is a sign of allergic rhinitis. Please remember, The appearance of the mucosa in allergic rhinitis, very, very important. A simple question you should not forget. It will be pale or bluish due to venous congestion. It is pale or bluish in nature. So this is a typical mucosa in allergic rhinitis. A middle-aged male presents with atrophic dry nasal mucosa, extensive crustings with woody hard external nose, which is false. So if you find a question like this, a male presents with atrophic dry mucosa, extensive crustings, takkani you should not enter into the answer of atrophic rhinitis. So the next point is very, very important. See, woody hard external nose, which is a very classical appearance in case of rhinoscleroma, which is very important granulomatous disease of the sinonasal region, which is false regarding the condition. Waterborne infestation with Klebsiella rhinoscleromatis may lead to subglottic stenosis. Mucolic cells are diagnostic. Long-term medical treatment. Each and everything is a MCQ point. Various in a separate MCQs they will be asking. So, which is false? It is not a waterborne infestation. It is an airborne infestation with Klebsiella rhinoscleromatis. That's quite important. Yes, it has a cicatricial stage. Subglottic stenosis is a very classical pathology that can occur in the rhinoscleroma. Mucolic cells are diagnostic, a very common MCQ point. Long-term medical treatment is given, yes, against this gram-negative bacteria. Nasal smear from a bleeding mass of a farmer is shown, which is true. There are certain HP slides which are very important in ENT, and one among these is this. One is vestibular schwannoma. We have seen this Antony A and Antony B pattern, and at the nose, this is the next one, HP or a smear slide, where you can very clearly see a sporangium with endospores, multiple sporangium with endospores within. So this is typically rhinosporidiosis, which is true regarding this condition. Most common organism is aquatic bacteria seen in immunocompromised patients, can be multicentric, can be diagnosed by identification on culture. It is not aquatic bacteria, it is aquatic protozoa. Seen in immunocompromised people, no way, it is not at all related to any immunocompromised state. It is seen even in a healthy people. Can be multicentric, very, very important. Not only in the nose, it can even involve the oral cavity, conjunctiva, genitalia, even in the skin. So rhinosporidiosis can be multicentric sometimes. It can be diagnosed by identification on culture. No way, it is protozoa, not a bacteria. It cannot be isolated. Okay. So this is a presentation of these two commonly asked granulomatous diseases. So woody hard external nose due to the subdermal granulomas, Hebra nose, rhinoscleroma, and what is this kind of pink polyp with white spots here and there? This is called strawberry polyp, which is very clearly strawberry polyp, very important. Strawberry polyp in rhinosporidiosis. And this is the oropharyngeal and the conjunctival rhinosporidiosis. So this is a commonly asked MCQs from the rhinoscleroma and rhinosporidiosis. Few points to note are: organism is Klebsiella, airborne, common in northern India, 3 stages: atrophic stage, granulomatous stage, stenotic stage, cicatricial stage in rhinoscleroma, where at this stage only subglottic stenosis happens. So woody nose and absent uvula sign. Uvula will be cicatrized and stenosed. Absent uvula sign is a very typical sign, but a rare sign in rhinoscleroma. And the investigation, the HP shows mucolic cells, the macrophages containing the bacilli and Russell bodies are typically seen in rhinoscleroma. And medically, anything against gram-negative tetracycline, cipro, rifampicin are the treatment. And anywhere the stenosis happens in the airway, we have to dilate surgically. So surgical dilatation is necessary. And regarding this rhinosporidiosis, it is Rhinosporidium seabury protozoa, waterborne protozoa, aquatic protozoa, southern India, and the 3 stages are not for the disease but for the life cycle of the organism: trophocyte, sporangium, and endospores. Endospores is the infective stage, endospores, and the appearance is strawberry polyp. Smear study is the diagnostic of rhinosporidiosis, and surgically we have to remove the tumor and cauterize the base entirely. This is very important. Even if you leave behind a small endospores, that will go for recurrence, massive recurrence. So cauterization of the base is very, very important. And nowadays, laser treatment is a wonderful treatment for rhinosporidiosis. And another MCQ, DAP zone is indicated for recurrence. A very recurrent rhinosporidiosis, DAP zone is indicated. So these are all the differences between this rhinosporidiosis and rhinoscleroma. Coming to the sinusitis, X-ray, commonly asked question, the X-ray. Caldwell view is done for sphenoid sinus, maxillary sinus, ethmoid sinus, frontal sinus. Of course, it is frontal sinus. Caldwell view. So we have the two important views X-rays. First is Caldwell view. This is the first is we will see Waters view. This is Waters. Occipitomental view. See, the patient is standing with the chin touching the X-ray plate and the beam is along the occipitomental. So occipitomental view with mouth wide open is the Waters view, where we can easily see all the sinuses. This is the occipitomental view. The frontal sinus, maxillary sinus, ethmoid sinus and sphenoid sinus through the open mouth. Please remember, Waters view is the occipitomental view with the mouth open, definitely. So there is no doubt about this. So this is Waters view. So this is the X-ray view where we can see almost all the sinuses clearly in the single X-ray. If you want to know exactly the dimensions of the frontal sinus, now sometimes the external surgeries are done for the frontal sinus. So for which we need exact dimensions of the frontal sinus. To catch that, to get that, we are taking a view called Caldwell view. This is called as occipitofrontal view. The frontal area is placed against the X-ray plate and X-ray beam is passed 15 to 20 degree caudal to the orbitomeatal line. So in this view, we can very clearly see the dimensions of the frontal sinus, only for the frontal sinus, that is called Caldwell view. And we can very clearly see the scalloping margins of the frontal sinus. These are the bony septations inside the frontal sinus, scalloping of the frontal sinus. And there is one condition where the scalloped margin is absent, absence of scalloping of the frontal sinus in a condition called mucocele. Very important. Frontal mucocele is a condition where the scalloping, the bony septations will be lost. So this is Caldwell view, occipitofrontal view. The next area of importance in sinusitis is complications of the sinusitis, where we will get some questions. Infection within the cavernous sinus. So cavernous sinus thrombosis is a very important mortal complication of sinusitis. We need to know what are the signs of cavernous sinus thrombosis. Infection within the cavernous sinus results in the following signs, except constricted pupils in response to light, engorgement of the retinal veins, ptosis of the eyelid, ophthalmoplegia. It is not the constricted pupils, it is a dilated pupils. Of course, retinal veins engorgement, ptosis of eyelid, ophthalmoplegia are very, very important signs of this cavernous sinus thrombosis. We will see the anatomy and then we can easily correlate with this. There is a channelless classification based on the gradings of the orbital complications of from the sinusitis. So if the cellulitis involve only the eyelid, it is called preseptal cellulitis. And if the cellulitis involves the whole orbit, it is called orbital cellulitis. If the sinus abscess breaches the lamina papyracea, pushing the periorbita, that is called a subperiosteal abscess. If the periosteum is breached and the abscess enters into the orbit, it causes orbital abscess. Till then, all the grades are unilateral on the side of sinusitis. But from here, the infection can spread retrograde manner into the cavernous sinus. So the cavernous sinus thrombosis is the dreadful complication. So once it enters into the cavernous sinus, it becomes bilateral in presentation. So the bilateral presentation of the cavernous sinus is due to this alignment. See the anatomy of the cavernous sinus. So cavernous sinus is present on either side of the sphenoid sinus, and it has multiple interconnecting sinuses. So one side cavernous sinus thrombosis will mostly involve bilateral cavernous sinus involvement, and hence the cavernous sinus thrombosis is bilateral in presentation. Okay, that's why it causes bilateral conjunctival chemosis, bilateral proptosis, cavernous sinus thrombosis. Abrupt onset of cavernous sinus thrombosis will occur, bilateral conjunctival chemosis and bilateral proptosis. Okay. And the relation of this cavernous sinus on either side, see the sphenoid sinus, this is a pituitary. On either side we have the cavernous and the blue venules, blue sinuses, blue colored structure. Okay, inside which we have this internal carotid artery. Along with it has a nerve called sixth nerve. So whenever there is cavernous sinus thrombus, the first nerve to get involved, the first nerve to get palsied is sixth nerve, abducens nerve palsy, abductor palsy will be present, sixth nerve palsy. And on the lateral wall, the nerves related are 3, 4, V1 and V2. So ophthalmic division and maxillary division. So these are all the nerves that are related to the cavernous sinus, and hence the first nerve involved is sixth nerve, and then the third nerve, and then the fourth nerve. So all the nerves of the orbit all involved. So what are all the typical presentation? Abrupt onset, bilateral presentation, sequential involvement of the sixth, third and fourth nerves, and the first nerve is the sixth nerve, and the sixth nerve involvement will cause diplopia first point, and then the third nerve involvement will cause drooping of the eyelid. So 3Ds, please remember, in the cavernous sinus thrombosis also, diplopia, drooping eyelid and dilated pupils, again due to this third nerve involvement, dilated pupils. So this is very, very important 3D presentation of the cavernous sinus thrombosis. Diplopia, sixth nerve involvement, and drooping of the eyelid and dilated pupils due to third nerve involvement. And at the last, since all the nerves are involved, ophthalmoplegia will be having. Retinal veil engorgement, edema, pale optic disc, and later on blindness will happen, and septicemia will happen. So these are all the features of cavernous sinus thrombosis. And very commonly they will be asking question from the frontal mucosal, a chronic swelling of the frontal sinus. All are true about frontal mucosal except eggshell crackling, non-axial proptosis, painful frontal swelling, loss of scalloping. And very typically, it is not a painful condition, a chronic condition. Once it gets infected like pyocil, then it becomes painful, but till then it is a non-painful condition, a chronic condition due to frontal sinus ostium blockade. Either it can be inflammatory or a post-traumatic frontal sinus ostium block. If the ostium gets blocked, the mucus gets retention there in the frontal sinus and it keeps on enlarging the epithelial lined mucus containing sac, that is a mucosal. It keeps on engorging very slowly and causes destruction of all the thin septations of the frontal sinus. That is called loss of scalloping. And coming to the pictures so that we can understand easily. See this. The frontal mucosal, it enlarges and pushes the orbit, non-axial proptosis, outwards, laterally and downwards. So this proptosis will be laterally and downwards. And if you palpate over this mucosal swelling due to the thin bone broken down due to the chronic enlargement, that eggshell crackling will be present. That is very, very important. And then these are all the scalloped frontal sinus I told you, but in the frontal mucosal, the frontal sinus becomes smoothened sinus. The loss of scalloping will be present. And the treatment is endoscopic drainage of the frontal mucosal. And in any condition causing a painful frontal swelling is Pott's puffy tumor. A painful frontal sinus swelling. This is due to osteomyelitis, commonly involving the anterior table of the frontal sinus where the marrow is present, and it is called a Pott's puffy tumor, painful tender frontal sinus swelling due to osteomyelitis, which is an acute complication of frontal sinusitis. Mucosal is a chronic complication. Unilateral multiple nasal polyps in an young male with the CT scan is given. Which of the statements is false? So very typical. See the appearance of the sinonasal pathology, a heterogeneous opacification inside the sinonasal region. So whenever the opacification is like this in the brain, that is called homogeneous opacification. But here a dark gray and light gray are mixed, heterogeneous opacification. So unilateral polyps in a young male with a CT scan, and this is very classical diagnostic appearance of the particular disease. What is the disease? This is called AFRS, allergic fungal rhinosinusitis. Which of the statements is false regarding this AFRS? It is IgE mediated fungal sinusitis. Yes. Peanut butter mucin. Yes, very typical symptom. Bony expansion and erosion not seen. Smear positive for fungus. Yes, it should be positive for fungus. Of course, bony expansion and erosion is seen even though this is not an invasive fungal sinusitis. Due to the pressure induced expansion, the thin bones to get eroded will be eroded. So this is a typical feature of allergic fungal rhinosinusitis. Very important. Okay, check. So next, there are two kinds of fungal sinusitis: non-invasive fungal sinusitis and invasive fungal sinusitis. In the non-invasive AFRS, allergic fungal rhinosinusitis is quite common, and in invasive fungal sinusitis, we will be getting more questions on mucormycosis. So the next question is a diabetic patient with severe facial pain and necrotic nasal mucosa. Necrotic nasal mucosa, diabetic patient, a severe facial pain and necrotic nasal mucosa. Nasal smear picture is shown, which is false. Very typically this picture, again a slide which is very important. A broad aseptate fungi, which is mucormycosis. So rhizopus is a common organism. Yes, in mucormycosis, rhizopus is a common organism. Angioinvasion is present. Yes, it is an invasive fungus. So angioinvasion is present. That's why it causes necrosis after ischemia. Massive necrosis will happen due to angioinvasion. Radical resection is necessary. Yes. Voriconazole is drug of choice. That is a point. Voriconazole is active against aspergillosis, not the mucormycosis. So what is the drug of choice against the mucormycosis? Amphotericin B is a drug of choice, and then oral is posaconazole. So it is a drug of choice for mucormycosis. So fungal sinusitis, a mere presence of fungal material in a sinus, either a sphenoid or a maxillary sinus, called fungal ball. And the most common fungal sinusitis, fungus involved in fungal sinusitis, is Aspergillus fumigatus. In ear, please remember it is Aspergillus niger. And in the sinonasal region, the most common fungus involved is Aspergillus fumigatus. Allergic fungal rhinosinusitis, the common organisms are Alternaria and Bipolaris. Allergic mucin, and treatment is typically steroids. Please remember this point. AFRS, even though this is a fungal rhinosinusitis, oral antifungals or systemic antifungals are not indicated in AFRS. This is very typically, as the name implies, allergic reaction to the fungal material. IgE mediated reaction, and hence steroids are indicated. There is no role for antifungals. So we have to do a FESS, and then steroids, topical steroids are to be indicated, plus or minus oral steroids. There is a criteria called Bent and Kuhn criteria for AFRS, very important criteria. If a patient satisfies this criteria, then only he is called as, the disease is called as AFRS. The first thing is IgE mediated type 1 hypersensitivity reaction like allergic rhinitis, and the minor criteria corresponding to this point is eosinophilia. That's all. Minor criteria. We will see the minor criteria adjacent. It is very simple to correlate. Nasal, it presents as nasal polyposis. And the minor criteria is it may be unilateral nasal polyposis. Third, if you take a CT scan of the picture of the patient, heterogeneous opacity of the CT scan, double density sign, very important double density sign like this. Due to this iron, manganese, and the fungal hyphae present inside this cell wall of the fungus, this heterogeneous opacity will occur. So this is called double density sign of this AFRS. Very, very important. And this is where the minor criteria is bony expansion erosion may be present, So bone expansion and erosion may be present due to the increased load of fungal material that causes massive expansion and erosion of the minor thin bony walls. Okay. Eosinophilic allergic mucin. The patient will complain of thick, tenacious, peanut butter-like mucus. Very thick mucus the patient will be having containing the fungal material. So this is allergic mucin, and the minor criteria, this mucin contains charcoal-laden crystals. This is a degraded eosinophils. Charcoal-laden crystals are filled in this allergic mucin. And positive fungal smear study will be present, tissue invasion will be absent. Means if you take a mucus, see the fungus will be present in the secretions. But if you take a mucous membrane, mucus and submucosa, the fungus will not be invading into the tissues. So tissue invasion should be absent, please remember. So that's why there is no role for systemic antifungals. So the invasive fungus is mucor and non-invasive is AFRS. And the minor criteria for this last point is nothing but fungal culture is positive. Fungal smear is positive. Sometimes if you are not able to identify, fungal culture will be positive. So these are all the major and minor criteria of this fungal sinusitis, AFRS. Okay. And fulminant invasive fungal sinusitis is rhino-orbitocerebral mucormycosis. It is invasive form in uncontrolled immunocompromised people. Angioinvasion, tissue invasion is present. Black necrotic material due to massive ischemia, and the contrast MRI shows black turbinate sign. So since the turbinates, middle turbinate, typically middle turbinate will be involved due to the ischemia of the middle turbinate, it does not take up the contrast. So it appears as a black turbinate in MRI, contrast MRI. And amphotericin B with massive radical surgical debridement plus posaconazole for a long-term treatment, 3 to 6 months may be necessary for the mucormycosis, which is active against mucor. Posaconazole, not voriconazole. Voriconazole is against aspergillus. This is posaconazole. So this is a black turbinate sign in the mucormycosis, where on the healthier side, it is taking up the contrast, and on the arrowed side, it is not taking up the contrast due to the ischemia of the turbinate. A few dictums of nasal polyposis. Unilateral polyp in an infant, always rule out meningoencephalocele. Bilateral polyps in child less than 2 to 10 years, cystic fibrosis should be ruled out. Unilateral polyp in adolescent, young children, antrochoanal polyp should be thought of. Bilateral multiple polyps in adult is a usual eosinophilic allergic polyps. Samtus triad, of course, commonly asked triad, aspirin sensitivity, asthma, and severe recurrent polyposis. And what is the treatment for the Samtus triad? Aspirin desensitization. Aspirin desensitization. This is a Samtus triad, aspirin sensitivity, asthma, and polyps. Polyps with heterogeneous opacity in the CT scan, that's what we have seen AFRS. Very classical picture. Please remember that picture, heterogeneous opacity in sinuses, double density sign, which is very typical of AFRS. Bleeding polyp in an older person, malignancy. So antrochoanal polyp, how it presents in the CT scan? The polyp will go from the maxillary antrum into the choana. So in the oropharynx, you can see the hanging polyp behind the soft palate. So this is the appearance, and this is called crescentic sign of air. Between the polyp and the nasopharyngeal mucosa, the black air shadow is present. This is called dot sign or crescentic sign. So in case of any nasopharyngeal mass like adenoid, or the mass attaches to the nasopharyngeal mucosa like JNA, this crescentic black, this is the point. This is about what I am meaning. The crescentic air shadow between the mass and the nasopharyngeal mucosa will not be present in nasopharyngeal masses, but it is present in antrochoanal polyp. Functional endoscopic surgery was done for a patient with extensive nasal polyposis. In the immediate postoperative period, patient develops unilateral periorbital swelling and crepitus. This complication would have been caused by the surgeon during operation in which of the sinuses? That's a quite important point. Complications of FESS, where we have to know in each sinuses there are specific complications that can occur. So what are all the complications that we will encounter? In case of this periorbital crepitus and swelling, periorbital air leak, emphysema, air leak, crepitus, subcutaneous crepitus, in which sinuses it will happen as a complication? Typically, it happens in ethmoid sinus. Ethmoid sinus. So we'll see the complications of the this FESS. So if you are operating in the maxillary sinus, just anterior to the maxillary sinus ostium will be your nasolacrimal duct that may get injured, nasolacrimal duct injury that may occur. And many complications will be occurring in the ethmoids. See this, ethmoids. These are the ethmoids we are seeing from the beginning. So you may injure the lamina papyracea and air leak inside into the orbit, and the periorbital subcutaneous crepitus will occur in the immediate postoperative period, but that will resolve on its own. That is not a dangerous complication. But if you go deep inside and if you injure the medial rectus muscle, that may lead on to persistent permanent diplopia. That is very dangerous. Okay. Other thing, what is this projection? A nipple-like projection on either side. See this, a nipple-like projection in the lamina papyracea region. So that is the anterior ethmoidal artery entry into the nasal cavity. So hence in the ethmoids, you may tend to injure the anterior ethmoidal artery. The artery may recoil into the orbit and causes orbital hematoma, which is a dreadful complication that may cause optic nerve compression. So that hematoma should be relieved by doing a lateral canthotomy. By making an incision in the lateral canthus, that orbital hematoma should be relieved. Lateral canthotomy should be done. Okay, that is anterior ethmoidal artery injury, and that area, that projection in the CT scan is the site of anterior ethmoidal artery entry, and that area is called Kennedy's nipple. That is called as Kennedy's nipple. Very important. A nipple-like projection where the artery enters into the nasal cavity. And again, you may injure the skull base, CSF Rhinorrhea. The skull base injury can be happen. So the CSF Rhinorrhea can happen when you are operating in the ethmoid. So lamina papyracea injury, anterior ethmoidal artery injury, CSF Rhinorrhea due to skull base injury. These are all the typical complications of ethmoid sinus operations. And coming to the sphenoid sinus, which is very dreadful, if the dehiscent optic nerve or internal carotid artery are present, you may injure the optic nerve or ICA, which are dreadful complications of sphenoid sinus. And of course, you may injure the skull base again, CS rhinorrhea can occur. Which is the most common complication of FESS is synechia formation. Due to the repeated instrumentation, the mucosal surfaces may have adhesive bands may occur. Synechia formation is the typical and most common complication of this FESS surgery. Most common cause of epistaxis in a 3-year-old child. Coming to the epistaxis. So, takkunu we will enter into, we will mark the answer as foreign body. A very common mistake in our students will be doing. Please remember, foreign body is not the most common cause of epistaxis in a child. URI, upper respiratory catarrh, is the most common cause of epistaxis in a 3-year-old child. Very important. Please remember that. So, when will you mark foreign body as the answer? Only if the question contains this point, a foul smelling epistaxis. A foul smelling epistaxis, that's kind, a foul smelling, that's kind of discharge, then only you have to think about foreign body, a retained foreign body. Otherwise, foreign body is not a most common cause. Okay. So the points to remember: most common site is little area, most common cause, actually it is idiopathic. If you find the term idiopathic in the MCQ options, boldly trust me, you can answer the point idiopathic. This is obtained from the Scott Brown recent edition. Idiopathic is the most common cause irrespective of the age group actually. A child with foul smelling epistaxis foreign body, profuse and recurrent epistaxis JNA, and an elderly look for hypertension or malignancy. And lines of management will be asking, whenever the patient is having profuse bleeding, what will you do? If you are able to identify a point of bleeding, able to identify the point of bleeder, then you have to do a direct therapy cauterization. Either you do with a cautery, electrical cautery, or a chemical cautery. A silver nitrate solution, 10% silver nitrate solution can be used as in this picture. Just dip in the solution and place it over the place of bleeding. And if there is patient having profuse bleeding as in the posterior epistaxis, where Woodruff's area, the posterior part of the inferior turbinate, just posterior to the inferior turbinate is the Woodruff's plexus, where which is common in posterior epistaxis, where it will be massive bleeding will be present. And in this aspect, in this case, you have to do a packing. Pack the nose, wait for 1 or 2 days, let the bleeding stops, and then remove the pack, re-explore the nose for finding the bleeding points. So second is indirect therapy. It is not a treatment, just to arrest the bleeding at that point. And the third line, any patient coming to you with recurrent epistaxis and there is no bleeding point at all, bleeder cannot be found out, but the patient is having idiopathic recurrent epistaxis. What is the treatment? TESPAL, transnasal endoscopic sphenopalatine artery ligation should be done. So that is the treatment for idiopathic recurrent epistaxis. So sphenopalatine artery will enter into the, see this, posterior end of the middle turbinate is the sphenopalatine foramen. So posterior end of the inferior turbinate is the Woodruff's plexus. The posterior end of the middle turbinate is the site of sphenopalatine foramen, where you find the sphenopalatine artery. Expose that and cauterize it or ligate with clips. So this is sphenopalatine artery ligation in case of idiopathic recurrent epistaxis. And fourth line, any bleeding tumor like JNA, do a angiography and embolization. So these are all the treatment aspects of epistaxis. Coming to the trauma. While playing football, 18-year-old boy was hit on the nose and developed a deviation of the nose. On examination, the septum was not deviated. The patient has deviation of the external nose, but septum was not deviated. The following about the patient is true. He should be taken up for open reduction 1 week later. He should be taken up for closed reduction as soon as the overlying edema subsides. Septoplasty should be done in the same sitting. Conservative management. So since there is a nose deviation, we have to treat the patient. So there is no role for conservative treatment. Septoplasty, there is no septal deviation, there is no role for septoplasty. So the either A or B answer. So the typically there is no need to open reduction in this case. The typical treatment is he should be taken for closed reduction as soon as the overlying edema subsides. So usually immediately after the nasal bone injury, edema will be present. So with the edema you should not reduce, so that you cannot correctly align the nasal bones in the midline. So once the edema subsides in 5 to 7 days, then you can go for close reduction. So this is a treatment option. So whenever there are grades of this nasal bone fracture. Fracture is present, but there is no external deviation or deformity. There is no external deviation. It is undisplaced fracture. What is the treatment? No treatment at all, conservative. You need not do any surgical maneuver for the patient. It is undisplaced fracture. Okay. If it is a displaced fracture like this, external deformity is present, you have to do closed reduction by using the forceps, Walsham's forceps. So this is done as a closed method. You need not do any incisions, open reductions. So typically this should be done at the range of 1 week, and that should be done within 3 weeks. Within 3 weeks should be done this closed reduction. Beyond 3 weeks, if the patient presents to you, that may lead on to the fibrous union formation, where the breaking the bone becomes very difficult, and hence you have to go for open rhinoplasty. Wait for 3 months and then do a open rhinoplasty in any patient coming a late presentation after 3 weeks. This is very important. So close reduction can be done up to 3 weeks. Beyond that, close reduction will not be successful. So this is a point regarding the treatment of this displaced fractures. And many of the displaced nasal bone fractures will be associated with septal fractures. In the question, it was not fractured, but many times it may be associated with septal fracture. So what are the types of septal fractures? Chevalier and Georgieve fracture, very important. It is based on the force of injury. When a less force injury is there, a fracture just under beneath your dorsal part of the nose will happen. This is a vertical line fracture just beneath your dorsal part of the nose. This is a Chevalier fracture. When the force of injury is huge, the whole quadrangular cartilage will be dislocated from the surrounding structures. So from the vomer, from the perpendicular plate of ethmoid, it will be dislocated. So the Georgieve fracture will be like J-shaped fracture like this. J-shaped, the whole quadrangular cartilage will be dislocated away from the surrounding structures. So Chevalier is a linear fracture and Georgieve, as the name implies, J for J-shaped fracture. Very easy to remember. The whole septum will be dislocated from the surrounding structures. So this is Chevalier and Georgieve fractures. If there is septal fractures, you have to correct the septal fracture. Means septal correction should be done. That's all. Septoplasty or submucous resection should be done for the patient. All the following statements about CSF leak are true except common site of CSF leak is roof of ethmoids. Yes, cribriform plate. Beta 2 transferrin estimation is highly specific for diagnosis. Yes. Traumatic leaks can be conservatively managed. Yes, it can be managed conservatively. There is no need to venture into the surgeries immediately. MRI T1 image are best for diagnosis of site of active leak. It is not T1 images, it is T2 images. So the answer is D. So these are all the points, very important, very commonly asked MCQs. The most common site is cribriform plate, and the specific diagnostic marker is beta 2 transferrin, and the traumatic leaks RTA after RTA, we can wait for 2 to 3 weeks. Once the leaks gets subsided by fibrous union happens, the leak will subside on its own. Then you can leave the patient. You need not do any surgery for the patient. So for the diagnostic purpose, MRI T2 images, I will show the pictures. So beta 2 transferrin is a diagnostic, and imaging modality of the choice is CT cystinogram. You have to give dye in the intrathecally in the spinal lumbar puncture, and then that leak is identified in the CT scan, CT cystinogram, or T2 weighted MRI, where you can very clearly see the CSF as a white structure, white material. And this is a clinical method after RTA. This is halo sign, double ring sign, target sign. The blood will be present in the middle and the thin CSF will leak out beyond the blood stain. And this is the T2 weighted MRI. Why it is T2? Very simple. The CSF will be seen as white. So this is the CSF. So on the left side, the skull base intact. But on the right side, see a small dripping of the CSF into the nasal cavity. So T2 weighted MRI is useful for this CSF rhinorrhea. And treatment in a post-traumatic case, we can wait and watch. There is no need for any ventures. Successful closure can happen. So transnasal endoscopic hadad fracture nasoseptal flap covering over the CSF leak can be done. So this is endoscopic approach. Nowadays there is no need for intracranial or craniotomy. Endoscopic CSF leak closure has a very good success rate. So this is about the CSF leak closure. So we'll go for a little break and we'll come back after. So we'll start with this tumors of the sinonasal region. And very common areas of questioning will be again one benign tumor for the nose and one malignant tumor for the nose, one benign tumor for the nasopharynx, discharge often, and HP shows inversions of the epithelium into the underlying stroma, and very clearly they have given itself, which is true regarding the condition. So see this typical picture, and there will be multiple inversions of the epithelium into the stroma. If you see this, this is called typically inverted papilloma. So inverted papilloma is a notorious papilloma of the sinonasal region, which is very important academically and clinically. So which is true regarding the condition. Is common in children, recurrence is rare, always benign, can be pre-malignant. Very typically, it can be pre-malignant. It is typically common in elderly people, 5th to 6th decade again. Recurrence is quite common. Even if you leave a small area, again, your papilloma will recur. Yes, of course, it's a benign tumor, but it is not always benign. It can be a pre-malignant condition. It is a pre-malignant condition. And even in the first time presentation itself, there can be simultaneous squamous cell carcinomatous foci within the tumor. So this is a very typical of inverted papilloma. So the most common benign tumor of the sinonasal region is a plain squamous papilloma. But and this inverted papilloma is notorious tumor to know. So it is otherwise called as transitional cell papilloma, Schneiderian papilloma, Ringer's tumor. Lateral nasal wall is a typical site of origin, unlike the papillomas which are common. Squamous papillomas common in septum, but here it is originating typically from the lateral nasal wall. It is benign and locally invasive, and in few percentage of cases there can be a simultaneous carcinomatous foci, and it is a pre-malignant condition. And complete removal is very, very important for this inverted papilloma, and the procedure we are recommending is medial maxillectomy. The medial wall of the maxilla is to be excised for the complete removal of the tumor. Medial endoscopic medial maxillectomy, it should be done. A complete removal should be done of the tumor, otherwise it may recur or may lead on to malignancy. Maxillary carcinoma involves pterygoid plates. What is T staging? See, I tell you, if they are asking such a question, don't get fumbled and don't feel, oh, we have not seen all the T stagings. So there is a little tricky things here in assessing the T stages, easy ways to assess. So simply for any malignancy, T4 stage is nothing but extra organ spread. So if a malignancy is present, for example, a tongue malignancy or a maxillary malignancy or a laryngeal malignancy, the T1, T2, T3 are the stages where the malignancy will be present within that organ itself. It may be a smaller, it may be a bigger, plus remember within the organ. If any of the extra organ is been involved, that is T4. Very simple. So even if I have not read about the T staging of the maxillary carcinoma, it's quite easy. The malignancy has involved pterygoid plates. Pterygoids are the part of sphenoid. They are not a part of maxillary sinus. So obviously the stage is T4 stage. Likewise, very simply, a maxillary malignancy, if it involves any of the orbit, pterygoid place, infratemporal fossa or the cheek mucosa or the cheek skin, everything is becoming a T4 stage. So this is about skull base, everything is a T4 stage. So T1, T2, T3 all will be within the maxillary sinus. It may erode its own sinus wall, lateral wall erosion, posterior wall erosion, medial wall erosion can be there, but the growth has not involved the adjacent structures. If it involves the adjacent structures, it should involve, then only it becomes T4. So that is a simple logic behind this kind of questions. So that is the point you have to know. So maxillary carcinoma, typically the etiology is not very typically smoking, nickel and chromium workers, leather industries, mustard gas industries, and anybody working with a hard wood dust, hard wood, African wood of mahogany, they may get adenocarcinoma of the ethmoids. So that is called as woodworkers carcinoma, a simple MCQ. Woodworkers carcinoma is nothing but adenocarcinoma of the ethmoids. And most of the carcinoma here, it is squamous cell carcinoma. And prognostic lines, they will be asking you Ongren's line, root of the nose to the angle of mandible, a line is drawn imaginary. Any growth involves in the inferior part has a good prognosis. Anything that involves go behind this line because it may involve the orbit and skull base, of course, a bad prognosis. This is Ongren's classification. And the Lederman, two lines in the floor of the orbit, two lines in the floor of the maxilla. Anything in between has a good prognosis. Anything breaches above and below will have a bad prognosis. And the treatment of all stages of maxillary carcinoma, there is no big confusion. We have to do a total maxillectomy plus or minus radiotherapy based on the margins of the tumor. So total maxillectomy is a treatment of choice. When the orbit is breached, when the periosteum of the orbit is breached, then we have to do a extended maxillectomy, that is called maxillectomy with orbital exentration, total extended maxillectomy. So this incision is called Weber-Ferguson incision. We have to elevate the cheek skin, remove the entire maxilla and replace the cheek skin. Weber-Ferguson incision for the maxillectomy. Coming to the tumors of the nasopharynx, a benign tumor, the most common benign tumor is JNA. Radowski stage of JNA involving the sphenoid sinus is, again, I tell you, an easier way of assessing. We have seen the staging of glomus tumor, A, B, C, D, easier way of the glomus tumor spread. Again, the Radowski stage of JNA spread is also quite easier. I tell you an easier way. A, B, C, D, 1A, 1B, 2A, 2B. So the answer here is 1B. I tell you how, and easier way of grading is present. Few MCQ points. This is the most common benign tumor of nasopharynx. Most common site is phenopalatal foramen, where the remnant of the first branchial arch artery is present. So that acts as a nidus of this vascular tumor JNA. Seen almost exclusively in the males, 10 to 20 years of adolescent males. This is testosterone dependent tumor. It will not be seen in females. That's quite important. Of course, we know that very well. And the JNA profuse bleeding is due to the muscular coat of the vessel walls will be absent, and hence even a sneezing will induce a profuse bleeding of the JNA. And coming to the staging of the JNA, we have the time 1, 2, and 3. An easier way of this assessment is, see this. So usually this JNA, it starts in the sphenopalatine foramen, the posterior part of the nasal cavity. We know the sphenopalatine foramen is the posterior end of the middle turbinate region, near the nasopharynx region. So JNA, J, juvenile nasopharyngeal angiofibroma. How will you write the J? We will mark the first line as J and the second line a curved line for the J. So these are the two stages, stage 1 and stage 2, based on which we can easily stage the tumor. How will you stage the tumor? See, the tumor initially originates in the sphenopalatine foramen region, and that enlarge into the nasal cavity and the nasopharynx here. So this is how it enlarges. So in stage 1, the tumor is present within the nasal cavity and nasopharynx. From the nasal cavity, where else a neoplasm can grow into? Any of the paranasal sinuses, obviously. So 1A is nose and nasopharynx, and 1B is any of the sinuses. Commonly, which is the sinus above the nasopharynx? Sphenoid sinus. So commonly it involves the sphenoid sinus. So 1A is nose and nasopharynx. 1B is any of the sinuses, commonly sphenoid sinus. This is stage 1. So the first line, see this, we have marked the first line here for the J. So the first line is over. Stage 1 is over. Okay. From here, where else the tumor goes into? It goes into the crevices. This is a benign tumor, basically grows into the crevices, any preformed pathways. It just goes behind and hide in the sphenopalatine fossa, pterygopalatine fossa. That is where the second stage starts. So from the nasal cavity and nasopharynx, it goes and hides into the pterygopalatine fossa. From there, it has the stages. Initially, it will push the maxilla, posterior wall of the maxilla forwards. That is called antrum. Maxillary antrum is pushed forwards. So antral sign 2A is the antral sign. from the pterygopalatine fossa, which is a superior boundary of the pterygopalatine fossa, inferior orbital fissure. See the picture here. Inferior orbital fissure. This is the pterygopalatine fossa behind your maxilla, and from here it will enter into the orbit. So that is the through the inferior orbital fissure. So that is, if it enters into the orbit, it will causes proptosis. Eyeball is pushed forwards. So in 2B, we have the eyeball proptosis will be present. So eyeball proptosis is very typically seen 2B. B for eyeball proptosis. Okay. From here, pterygopalatine fossa, again, it will enter laterally into the infratemporal fossa. It will enter laterally into the infratemporal fossa and causes swelling in the cheek. So that is C to C. The cheek swelling will be present. 2C is the infratemporal fossa, cheek swelling. So these are all the points regarding the stage 2. So from the pterygopalatine fossa, 2A, 2B and 2C all happens. What is stage 3? Intracranium. From there, intracranium, very simple. 3 is intracranium. Intracranial and intracavernous sinus is 3B. So 3 is intracranium, very simply. So this is the picture where the tumor is present in the pterygopalatine fossa and pushes the posterior wall of the maxilla, and this classical sign, bowing of the posterior wall of the maxilla, is called Hallman-Miller sign, which is a very classical sign, diagnostic sign of JNA. No other tumor behaves in this way. So Hallman-Miller sign. So extensive JNA, if it involves from the stage 2, pushing the maxilla, pushing the eyeball 2B and pushing the cheek, so it causes frog face deformity in extensive JNA. Pushing the eyeball, pushing the cheek and causes swelling, it causes frog face deformity. So this staging is very quite important and quite easier to remember. 1A, 1B sinuses. 2A is antral sign. 2B is eyeball sign. 2C is cheek, infratemporal fossa and cheek swelling. So these are all the spread. 3 is intracranium. And the surgical treatment extension is treatment of choice. Endoscopic approach is the preferred approach due to extensive vascularity. Preoperative embolization of the internal maxillary artery is done. That is the feeding vessel of the JNA. And hormonal treatment, flutamide, is to reduce the size and vascularity of the tumor. And radiotherapy and chemotherapy are also indicated in this benign tumor. Please remember, this is MCQ in case of intracranial extensions. So these are the treatment options for JNA. Which among the following is not true regarding nasopharyngeal carcinoma? Bimodal age distribution, Epstein-Barr virus is implicated in etiology, neck swelling is the common presentation, diplopia, conductive deafness, palatal fixity forms a triad. So bimodal age distribution, very typical, that is very true in nasopharyngeal carcinoma. Epstein-Barr virus is implicated, yes. Neck swelling is a common presentation, a single very important MCQ point. Nasopharyngeal carcinoma, the early presentation, the commonest presentation of nasopharyngeal carcinoma is neck swelling. Secondary is neck in the posterior triangle lymph nodes. Very important. Please remember this point. And there is a trial called Trotter's triad. Diplopia, conductive deafness, palatal fixity. No. Answer is D. It is not diplopia. It is deep-seated pain due to the involvement of V3, mandibular adhesion of trigeminal in the foramen ovale in the skull base. So deep-seated pain, conductive deafness due to occlusion of the eustachian tube orifice causing serous otitis media, and any elderly patient coming with serous otitis media, it is an ominous sign. You have to look for nasopharynx to rule out nasopharyngeal malignancy. Very important. And of course, it pushes the soft palate forwards, palatal fixity. So it is most common in China, Taiwan and Indonesia, and most common site is fossa of Rosenmuller in the nasopharynx. Epstein-Barr virus is the typical etiology, and IgA against viral capsid antigen is used as a serological marker, which is very important marker, sensitive marker, and IgA against early antigen is a very specific marker. Environmental nitrosamines in the dry salted fish, and these people are consuming lots of dry salted fish. So nitrosamines, which also has etiological role in this nasopharyngeal malignancy. First peak is at the second decade and the second peak at the fifth to sixth decade. Bimodal age distribution, very important. Nasopharyngeal malignancy, there is a typical young age peak will be there. And Trotter's triad, conductive deafness, deep-seated pain due to V3 involvement in foveal and palatal fixity. And of course, the treatment is in all stages, like in maxillary carcinoma, any stage maxillectomy is a treatment. And in the nasopharyngeal malignancy, it is a very fantastic radiosensitive tumor. Radiotherapy is indicated in all the stages of nasopharyngeal malignancy, radiation. And please remember, the lymphatics goes to the posterior triangle nodes, and the neck node, a hard neck node swelling is a common presentation of nasopharyngeal malignancy. Yes, and WHO classification of this nasopharyngeal malignancy is there, where in stage type 1 is keratinized differentiated squamous cell carcinoma, and 2 is non-keratinized differentiated squamous cell carcinoma, that is A, and 2B is undifferentiated. So first is keratinized differentiated, 2A is non-keratinized differentiated, and 2B is undifferentiated nasopharyngeal carcinoma. So in this undifferentiated is has a more local spread, but it is fantastic radiosensitive tumor. The radiosensitive is more with undifferentiated malignancy. That's quite important in nasopharyngeal carcinoma. So this is about the points regarding the nasopharyngeal malignancy. So we'll start with the throat. So throat, we have this pharyngology and laryngology. So we'll have this discussion based on this. We'll start with the anatomy of the pharynx and then move on to the diseases and the larynx. Okay, the first patient in the throat, which is not a part of hypopharynx. So pharynx, we have the divisions: nasopharynx, oropharynx, hypopharynx. And in the hypopharynx, very typically we need to know the subsides of hypopharynx, which is not a part of hypopharynx. Postcricoid region, aryepiglottic folds, posterior pharyngeal wall, pyriform fossa. The answer is aryepiglottic folds. So aryepiglottic folds belong to larynx. The subsides of hypopharynx are pyriform fossa, postcricoid region, posterior pharyngeal wall. We will see that in the pictures. So we have this 3 segments of pharynx. And regarding the hypopharynx, which is quite important to understand, see this. If we cut open, go behind the pharyngeal tube, cut open the pharynx from behind, the area behind your nose is called nasopharynx, behind your oral cavity is called oropharynx, and behind your larynx, the funnel shaped larynx, is called hypopharynx. Okay, if we take this hypopharynx, see this, the funnel shaped larynx, the epiglottis, aryepiglottic folds, arytenoids, within which the larynx is present. Epiglottis, aryepiglottic fold, arytenoids, within which the larynx is present. And on either side of this larynx, 2 fossae. These are the pyriform fossae on either side of the larynx. This is a part of the hypopharynx, pyriform fossae. Okay. And next thing, the mucosa covering the posterior lamina of the cricoid cartilage is the postcricoid area. And the cut open posterior pharyngeal wall is another subsite of the hypopharynx. That's all. So the pyriform fossa, green side, and the mucosa covering the posterior lamina of the cricoid cartilage, the violet, that is a postcricoid region. That is where the upper esophageal sphincter is present. We will see with the muscles. And the posterior pharyngeal wall is a third subsite. So these are all the subsites of the hypopharynx. So simply it is like The hypopharynx is hugging the larynx from behind. Larynx in the middle and the hypopharynx is hugging the larynx from behind. This is the structure. And again, for your pictorial representation, so this is epiglottis. This fold is aryepiglottic fold with its cuneiform cartilage, and here it will be the arytenoid cartilage, within which we have this false vocal cord and the true vocal cord very clearly. And these two fossae on either side of this larynx is called pyriform fossae. So the pyriform fossae extends from above to below. What are the boundaries means? Coming to the same picture. Remember the boundaries. So superiorly, the pharyngoepiglottic fold. So pharyngoepiglottic fold superiorly. Inferiorly, up to the lower border of cricoid cartilage. Laterally, thyroid cartilage, of course, the whole thyroid cartilage within which the larynx is present in the middle and the whole hypopharynx is hugging the larynx. So laterally it is within the thyroid cartilage, and medially the point is aryepiglottic fold, arytenoid and the cricoid cartilage. Everything forms the medial boundary. Aryepiglottic fold, arytenoid and the cricoid cartilage forms the medial boundary. So these are all the boundaries of the pyriform fossa. So please remember this diagram so that you can easily answer. Everything is within the thyroid cartilage. Okay. So this is about the hypopharynx. Coming to the layers of the pharyngeal tube. What are the layers of the pharyngeal tube we have to know? Capsule of the tonsil is formed by pharyngobasilar fascia, buccopharyngeal fascia, deep cervical fascia, none of the above. It is by the pharyngobasilar fascia. So what are all the layers of the pharyngeal tube from above? So innermost layer is the epithelium, non-keratinized stratified squamous epithelium, and the next layer is Waldeyr's ring, subepithelial lymphoid tissues. We know adenoid in the nasopharynx. Over the eustachian tube orifice, torus tubaris is the tubal tonsils, that is called Gerlach tonsil, and over both sides of the oropharynx we have the regular palatine tonsil, and in the base of tongue the aggregates of the lymphoid tissue is called lingual tonsils. So these are all the Waldeyr's ring, internal Waldeyr's ring, and from here the true layer starts. The innermost layer is the pharyngobasilar fascia, and the next layer is the muscular layer, superior, middle and the inferior constrictors, and the outermost layer is the buccopharyngeal fascia. So this is how it covers the entire pharyngeal tube. So simply pharyngobasilar fascia, constrictor muscles and buccopharyngeal fascia. To remember, buccopharyngeal fascia is BP fascia. So I always tell this to remember BP cuff. We will be cuffing this BP cuff all around the arm, all around externally. So the external around the whole pharynx is the BP fascia, buccopharyngeal. So obviously the internal fascia is the pharyngobasilar fascia, and hence the pharyngobasilar fascia can be the capsule of the tonsil. See this, that forms the capsule of the tonsil. So the tonsil on its lateral surface is lined by condensation of the pharyngobasilar fascia, and the brown layer is the muscle layer, constrictors, and the outer layer is the buccopharyngeal fascia. So this is about this linings of the pharyngeal tube. And regarding this constrictors, very importantly, we have the superior, middle and inferior constrictors. The inferior constrictor is divided into thyropharynges are formed by and cricopharynges. The thyropharyngeus muscle and cricopharyngeus muscle. And obviously the dehiscence between these two muscles is called Killian's dehiscence, gateway of tear, or this dehiscence through which diverticulum will appear, that is called Zenker's diverticulum, or during your esophagoscopy there is more chance for tearing this area, Killian's dehiscence. So Killian's dehiscence is over. And another thing, this cricopharyngeus muscle is nothing but upper esophageal sphincter. Very important. The cricopharyngeal sphincter or upper esophageal sphincter is the narrowest part of the GI tract. Any foreign bodies will get obstructed at this upper esophageal sphincter level. So that is about the cricopharyngeus muscle. So this is about the Killian's dehiscence. There are important structures that pierce the pharyngeal tube to enter into the structures. So we need to know what are all the structures that pierce the pharyngeal tube. Thyrohyoid membrane is pierced by which of the following structure? Thyrohyoid membrane is pierced by which of the following structure? Glossopharyngeal nerve, superior laryngeal nerve, recurrent laryngeal nerve, stylohyoid ligament. So answer is superior laryngeal nerve. So easy to remember again. If you understand the anatomy, you have a good clinical orientation here. See, SPC, superior constrictor, middle constrictor, inferior constrictor. We have the three constrictors forming the pharyngeal tube from the skull base, and it descends as the esophagus. So this is the thing. Okay. See, the defect between the superior constrictor and the skull base, sinus of Morgagni. What is the first opening enters through the skull base and the nasopharynx? Eustachian tube. So pale structures. Eustachian tube, its muscles, levator vale palatine and tensor vale palatine, and artery, ascending palatine artery, both P and A. So from back to front, pale structures. Eustachian tube, levator vale palatine and tensor vale palatine and ascending palatine artery are the structures that enters through the sinus of Morgagni from the skull base and the superior constrictor defect, the superior defect. Okay, the first defect is over, through which the structures are over. Okay, and then second, the nasopharynx is over. Behind your oral cavity is a oropharynx. What is the nerve supply of oropharynx? The sensory supply, glossopharyngeal nerve. What is the only muscle of the pharyngeal musculature supplied by the glossopharyngeal nerve? Motor supply, stylopharyngeus muscle. So obviously these are the two things. In gap 2, the stylopharyngeus muscle and the glossopharyngeal nerve enters through between the superior constrictor and the middle constrictor. Okay. Next, the middle constrictor and the inferior constrictor. Gap 3. So this is nothing but superior part of the larynx, and gap 4 between the inferior constrictor and the esophagus. Inferior part of the larynx. Inferior part of the larynx. So the structures passing in the superior part of the larynx should be superior laryngeal nerve and the superior laryngeal artery. So the superior laryngeal nerve typically pierces the thyrohyoid membrane. So that is the superior part of the larynx, of course, the thyrohyoid membrane. So superior laryngeal nerve pierces the thyrohyoid membrane at the gap 3. Okay. And the inferior laryngeal part, what should be the nerves and vessels? Very simply, inferior laryngeal nerve and inferior laryngeal artery. There is no name called inferior laryngeal nerve. What is that nerve? It is called as recurrent laryngeal nerve. That's all. So recurrent laryngeal nerve from the tracheoesophageal groove, it enters between the inferior constrictor muscle and the esophagus into the larynx. So this is the gap 4 in the inferior. So these are the gaps through which the structures enter into the structures. Okay, nasopharynx, oropharynx, upper part of the larynx, lower part of the larynx. So these are the structures. So if you have a close look of the superior laryngeal nerve, the superior laryngeal nerve, SLN, it divides into the internal branch and the external branch. The internal branch pierces the thyrohyoid membrane, that is the sensory supply to the larynx and hypopharynx. Superior laryngeal nerve, which is a branch of vagus, very simple. And the external branch gives a motor supply to only one intrinsic muscle of the larynx, that is cricothyroid muscle. That is the intrinsic muscle of the larynx supplied by the external branch of the superior laryngeal nerve. And lower See, in the tracheoesophageal groove, the recurrent laryngeal nerve enters into the larynx beneath this inferior constrictor and supplies the sensory supply and motor supply. So we will see what are the differences between this supply. So this is the external surgical anatomy where it is seen as in the anatomical picture, which do not form membrane over the tonsils. Coming to the tonsils and its pathology. Candidiasis, diphtheria, Vincent's angina, Ludwig's angina. Obviously, it is Ludwig's angina. Ludwig's angina is nothing but a deep neck space infection, submental and submandibular space infection. It cannot produce membrane over the tonsil. And of course, candidiasis, diphtheria, Vincent's are very typical conditions that causes membrane over the tonsil, and very typically Vincent's angina produces black or gray membrane over the tonsils. So regarding this differential diagnosis, we have to know certain important things in each area. We have this streptococcal membranous tonsillitis, very quite common membranous tonsillitis, and diphtheria, very notorious and very mortal. And what are the symptomatology of the diphtheria? What are the clinical features? We will see that. Vincent's angina, this is due to the combination of the anaerobe and spirogate. This is trench mouth fever due to the anaerobic conditions in the trenches in the First World War. The soldiers experienced this disease and ulcerative necrotizing gingivostomatitis. So they have the black or gray necrotic membrane over the oral cavity and oropharynx. This is called Vincent's angina. And infectious mononucleosis is again an important condition causing membrane over the tonsil caused by Epstein-Barr virus. And the triad is membranous tonsillitis, multiple cervical lymphadenitis, and hepatosplenomegaly, infectious mononucleosis. Okay. Diphtheria, and it typically produces a gray leathery membrane, a thick gray leathery membrane, and on peeling the membrane there will be bleeding underneath, very typical. And this membrane will spread beyond the tonsil. That is very, very important. This membrane not only confines to the tonsil, it will spread beyond the tonsil into the palate, into the oropharynx, into the nasopharynx, into the larynx. Very, very important. So the membrane spreads beyond the tonsil and causes laryngitis, laryngeal obstruction, stridor, which may lead on to death for the patient. And the more typical death is due to myocarditis due to the exotoxins produced by the diphtheria. And the second important appearance is bull neck appearance, massive cervical lymphadenopathy. So yeah, leathery membrane beyond the tonsil plus massive cervical lymphadenopathy, bull neck appearance is very typical combo of the diphtheria. Membrane beyond tonsil and bull neck appearance. Of course, the treatment is very important. We have to immediately start antitoxins if you suspect diphtheritic tonsillitis, and along with this, macrolides or the typical penicillins or macrolides or the typical antibiotics work against diphtheria. True about quinsy. What is quinsy? Coming to the complications of this tonsillitis, peritonsillar abscess, quinsy. True about quinsy. Voice change and trismus. Abscess is located within the capsule, commonly occurs bilaterally. Immediate tonsillectomy should be done. So true is yes, typical voice change and trismus. Any deep neck space abscess will produce trismus. Typically trismus, difficulty in opening the mouth is called trismus. This is typically due to this irritation of the constrictors, spasm of the constrictors, and then medial pterygoid muscle, which is very close to the pharyngeal tube, medial pterygoid muscle, please remember. So due to the trismus, due to the medial pterygoid muscle spasm, the patient will be having trismus in any case of a deeply located abscess in the pharyngeal area. What is the voice change? Hot potato voice, very typical. Abscess is located within the capsule. No, it is located outside the capsule, external, lateral to the capsule in the peritonsillar space. It is always unilateral. It is not bilateral, always unilateral. Immediate tonsillectomy should be done, should not be done. It may lead on to septicemia. So we have to do a tonsillectomy called interval tonsillectomy should be done after 6 to 8 weeks of IND. After healing of this peritonsillitis, we have to go for interval tonsillectomy to prevent recurrence. So the peritonsillar abscess quinsy is due to this abscess collection in the peritonsillar space lateral to the capsule of the tonsil, that is a free space. Since the abscess is located in the peritonsillar space, it pushes the tonsil medially and uvula to the opposite side, and massive uvular edema will be present. And it is unilateral always, hot potato voice, trismus is due to medial pterygoid muscle, and torticollis. Torticollis keeping the neck on the side of abscess. And very important, 3 T's please remember. The patient will be toxic due to pus in the pharyngeal area, trismus in case of medial pterygoid muscle spasm, and torticollis, keeping the neck on the side of the abscess. These 3 T's are very typical of a deep neck space infections. A toxic patient with the trismus, with the torticollis, you must always rule out deep neck space abscess. You have to take a CT scan to confirm the deep neck space abscesses. Very typical presentation. 3 T's are very important in deep neck space abscess. And what is the treatment? IND intraorally, we have to make IND at the maximal bulge region in the soft palate region so that the pus can be drained. And then once the healing happens after 6 to 8 weeks, we have to do an interval tonsillectomy to prevent recurrences. Which is false regarding this method of tonsillectomy? It's been asked the recent method of tonsillectomy, very important. Which is false regarding this method of tonsillectomy? You can very clearly see they are using a black colored wand and it is dissecting the tonsil from its bed. So this wand is called coblator wand. Please remember, the recent method of tonsillectomy is not laser tonsillectomy, coblator tonsillectomy, coblation tonsillectomy, and the wand is called coblation wand or coblator wand. So it is a hot tonsillectomy. Yes, it uses the thermal energy. Thermal injury is minimal. Yes, that's why it is very helpful nowadays, even though it is used of thermal energy. Unlike the cauterization, conventional cauterization, the thermal injury to the surrounding structure is very, very minimal. It is less than 70 degrees Celsius. But unless in the cauterization, it is 200 to 400 degrees Celsius. Less bleeding. Yes, that's very important usefulness of this coblation. Ultrasonic energy is used? No, it is used as the radio frequency energy. The radio frequency energy disrupts the tissue bands and remove the tonsils from its bed, and the thermal energy helpful in lessening the bleeding, because hemorrhage is a very important complication of tonsillectomy, and this coblation tonsillectomy is a very useful recent method of tonsillectomy in reducing the bleeding and reducing the pain in the immediate postoperative period. Hemorrhage following tonsillectomy. What are the points to note? The most common cause of bleeding, peritonsillar or paratonsillar vein or external palatine vein. And the hemorrhage is divided into primary hemorrhage, reactionary hemorrhage, secondary. At the time of surgery, primary, how will you stop? Either pack or ligate or cautery. Reactionary, within 24 hours of surgery. This is due to slippage of the knots and dislodging of the clots. Very important. If there is a reactionary hemorrhage, we have to take the patient back to OT, anesthetize the patient, and then religate, remove all the clots, religate the bleeding vessel under GA in OT. That is the treatment for reactionary hemorrhage. And secondary, it is due to 5th to 10th postoperative day due to infection of the tonsillectomy fossa. So we have to give antibiotics, and blood transfusion is a treatment for secondary hemorrhage. So rose position, placing the sandbag underneath the shoulders, is called rose position. This is the post-operative patient lying in the comatose position, in a coma position, to prevent aspiration inside the lungs, because there may be little bleeding in the tonsillectomy fossa. So patient should be placed in the coma position in the post-operative period, please remember. Again, these are the coblation tonsillectomy, the coblator wand, how it looks like. Please note, make a note of this picture questions. Complications of adenodectomy are all except adenodectomy. Complications of adenodectomy are all except hyponasality of speech, velopharyngeal insufficiency, hemorrhage, Grisel syndrome. So, hyponasality of speech, rhinolalia classa. When there is a nasal block, that will cause hyponasality of the speech. Basically, hyponasality is seen in as a problem of adenoid hypertrophy. But here we have removed the adenoid. So more air will leak into the nasopharynx into the nose. So what will be the speech like? Hypernasality of the speech. So the answer here is, it is not hyponasality, it is hypernasality. And that hypernasality is due to velopharyngeal insufficiency. It is nothing but nasopharyngeal insufficiency. And hemorrhage, of course, can occur. Greisel syndrome, quite rare, but it's a complication of adenodectomy. So the points note here, the Greisel syndrome is a non-traumatic subluxation of the atlantoaxial joint, is due to excessive cauterization during the procedure, where it is commonly seen in Down syndrome. Because already the subluxation, weak joints will be present in case of Down syndrome, it will be aggravated, and the postoperative period the patient will have torticollis and fever, and they will be having this atlantoaxial subluxation. So we have to give a cervical collar, and anti-inflammatory measures should be taken. Okay, and the second quite important complication, that Greisels is quite rare, but the quite important commonly encountered is velopharyngeal or nasopharyngeal insufficiency. Nothing but, see, this is a adenoid, how it looks like in the nasopharynx. If you remove this huge bulk of adenoid from the nasopharynx, immediately in the postoperative period, the more air will be entering into the nasopharynx. Even during drinking the water may regurgitate into the nasal cavity, which is a transient problem for the patient. So this is called rhinolalia aperta, more air leaking into the nasal cavity. So hypernasal voice or rhinolalia aperta is seen in immediate postoperative period. So just reassurance is necessary. Once the soft palate closes the nasopharynx adequately in a few days or a couple of weeks, everything settles down. So this is about post-adenodectomy. Coming to the deep neck space infections. Okay. An infant was brought to emergency department with a history of acute onset fever, refusing feeds. The baby was found to have drooling saliva and unable to extend the neck, torticollis, keeping the neck in the flexed position, unable to extend the neck, flexed position. The physician advised urgent X-ray neck lateral view, and it is given, which is not true about the condition. So very typically in the X-ray neck, soft tissue neck lateral view, one thing is it is not extended, it is a flexed neck, the cervical vertebra is flexed, and very clearly a prevertebral soft tissue widening. So we can see the laryngeal tracheal air column here and the pharyngeal air column here. See this. And behind this, between this and the vertebra, a huge prevertebral soft tissue shadow and a air fluid level very clearly is seen in this picture. So this is retropharyngeal abscess, and every point given in the question is very important. It is quite common in infants, young children less than 3 years, fever, toxic, and they refuse feeds, will be severe painful condition. So drooling of saliva, they will not be able to swallow the saliva, and I told you toxic, trismus, and torticollis. They will keep the head and the neck in the flexed position. They cannot extend because of the prevertebral muscle spasm. So it is seen in the retropharyngeal abscess, which is not true about the condition. Intraoral IND is done. Yes, correct. Swelling in the posterior wall of the pharynx. Yes. Torticollis will be present. Caries of cervical spine is usually the common cause. That is the problem. So answer is D. In acute retropharyngeal abscess, especially in infants, it is not the caries of the cervical spine. The caries of cervical spine, the pod spine, is a very typical etiology for chronic retropharyngeal abscess. In infants, very typically, suppuration of the glands, lymph nodes, or the typical reason for acute retropharyngeal abscess. It is not the pod spine. Pod spine leads to chronic abscess, acute abscess commonly in infants due to suppuration of the glands. Otherwise, all the other things are true. Intraoral IND is done, yes. Postopharyngeal wall bulge and torticollis. And coming to this anatomy of the retropharyngeal space, so this is the pharynx, where the blue line, outer blue line here, is the buccopharyngeal fascia. See this, BP fascia surrounding the pharynx. And we have the cervical vertebra here posteriorly, which is lined by this fascia, prevertebral fascia proper. In between these two fascia, a thin fascia is present. This is the alar fascia. So this alar fascia is between the buccopharyngeal fascia and the prevertebral fascia. With these three fascias, it is divided into anterior retropharyngeal space, middle retropharyngeal space, and the posterior or prevertebral space proper, posterior retropharyngeal space. So these are the three spaces. Okay. And in these spaces, between the alar fascia and the buccopharyngeal fascia, a midline raphe will be present. In the infants, Henle's glands will be present. It may get suppurated in infants less than 3 years also, young children, and that will cause pus formation and cause a unilateral bulge in the posterior pharyngeal wall, unilateral bulge, and that is the typical retropharyngeal abscess. If in case of pot spine vertebra, then there the whole vertebral pot spine will lead on to the bulge, the abscess formation, and that will present as a midline bulge in the posterior pharyngeal wall in chronic retropharyngeal abscess. So these are all the points, and again the spaces. This is the simple pictorial line, and this is a sagittal line, pictorial line. See this BP fascia surrounding the pharynx, prevertebral fascia lining the vertebrae, and the green line alar fascia. So this prevertebral posterior space will lead up to the coccyx, and the anterior space lead up to the T4 level and blends with the BP fascia, and this middle space will dip into the posterior mediastinum, diaphragm level, up to the diaphragm level, and that space, the middle retropharyngeal space, is called danger space of the neck. MCQ point. The middle retropharyngeal space between the alar fascia and the prevertebral fascia is the middle retropharyngeal space, danger space of the neck. Why? It is dipping up to the posterior mediastinum. This is a pakka theoretical point, but for clinical purpose, any abscess in any of these retropharyngeal area can breach the fascia and can lead on to mediastinitis. So that is a mediastinitis is a dreadful condition of this deep neck space infections. One of the important cause for mortality of this retropharyngeal parapharyngeal abscess is mediastinitis. That is quite important. So the answer, the MCQ point is the middle retropharyngeal space is called danger space of the neck. That's the point to note. So it is common in less than 3 years, and Henle's glands suppurate and causes unilateral bulge, and the chronic is due to TB, pot spine, and ATT is the treatment. And for this chronic abscess not responding to ATT, external IND should be done. Trismus in parapharyngeal abscess is due to spasm of course, I told you the medial pterygoid muscle, which is adjacent to the pharyngeal tube. So medial pterygoid muscle spasm. Coming to the anatomy of the parapharyngeal space, please have a look again. The BP fascia medially, alar fascia is a thin fascia that is not considered as anatomical landmark. So PV fascia, prevertebral fascia posteriorly, and laterally the deep lobe of parotid, and this muscle, medial pterygoid muscle forms a lateral boundary. So this space is called parapharyngeal space on either side of the pharynx. Retropharynx is just behind the pharynx, but parapharyngeal space on either side of the pharyngeal tube. So 1 and 2 parapharyngeal spaces, which contains this neurovascular bundle, internal carotid artery and internal jugular vein, and the cranial nerves, 9, 10, 11, 12 cranial nerves. All those cranial nerves will be finding its way here. So these are all the things about the boundaries of the parapharyngeal space. Okay, so the presentation of the parapharyngeal space, that's quite important. I told you the parapharyngeal space is between the pharyngeal tube and externally by the parotids and the middle pterygoid muscle. So it will produce a external bulge behind your angle of mandible. That's very important. And intraorally, if you see into the intraorally, a bulge will be seen on the lateral pharyngeal wall. So two bulges will be present in parapharyngeal abscess. Intraorally, the lateral pharyngeal wall will be medialized, pushing behind your posterior pillar, and externally a bulge will be seen behind the angle of mandible. So this is the presentation of parapharyngeal abscess, and if you want to drain the parapharyngeal abscess, make incision at the hyoid bone level and retract the sternomastoid, and then go and drain the parapharyngeal abscess externally. And last, Ludwig's angina, submental and submandibular space infection. Ludwig's angina, submental and submandibular space infection. This initially it will be massive cellulitis will be present, and the treatment is an IND below the chin, and we have the oral diaphragm called mylohyoid. Split open the mylohyoid, and the abscess will be draining from the floor of the mouth. So this is about the Ludwig's angina. So these are all the deep neck space infection and common questions from these areas. All statements about Plummer-Vinson syndrome are true except. So Plummer-Vinson syndrome is quite important syndrome. Sideropenic dysphagia, Patterson-Brown-Kelly syndrome. Except Boca sign is positive, common with iron deficiency, common in females, pre-malignant. Yes, it is common with iron deficiency. It is typically common in females. It is a pre-malignant condition. And Boca's sign will be positive in not in the Plummer-Vinson syndrome stage. It will be positive in the post-cricoid malignancy stage. If it is going into a malignancy, there only Boca's sign. What is Boca's sign? Absent laryngeal crepitus, which is a very typical sign of post-cricoid malignancy. So Boca's sign is positive in post-cricoid malignancy. So this sideropenic dysphagia very typically produces present with glossitis, stomatitis, chylonychia, and achlorhydria. And 10% of the patients will lead on to post-cricoid malignancy. And how will you diagnose? This is due to the sideropenic dysphagia is due to upper esophageal web due to the anemia, hypoxia. In this cricopharyngeal region, a mucosal web will be present. This is upper esophageal web causing dysphagia for the patient. If you leave it untreated, iron supplements and boogies to dilate that area of the treatment, and if you leave it untreated, that will lead on to malignancy in 10% of the people, and that is called post-cricoid malignancy. Simply I told you the upper esophageal sphincter is at the level of post-cricoid region. So post-cricoid malignancy. So if anything is present in the post-cricoid region, this movement of this cricoid cartilage over the vertebra, which produces a grating sensation normally, will be lost. So this is absent laryngeal crepitus. Boca sign positive in case of post-cricoid malignancy. Again, the point is the only aerodigestive tract malignancy which is common in females is post-cricoid carcinoma, because most of this aerodigestive malignancy are due to smoking and alcohol, which is quite common in males. But in females, due to iron deficiency anemia, this post-cricoid malignancy is very typically common in females. Okay. At this point, you have few points regarding this Zenker's diverticulum. So it is a pulsant diverticulum through the Killian's dehiscence. It is a false diverticulum because it do not have the muscular coat. The gurgling sensation present during the palpation of the neck will be present. Here, this pouch will be prolapsing through this Killian's dehiscence. Again, if you palpate the neck, a gurgling sensation due to the presence of undigested food material which gets collected in this pouch will happen. And that sign is called, what is that sign? The gurgling sensation, Boy's sign. And this X-ray barium's fellow will produce typically the future of the Zenker's diverticulum, which compresses the esophagus and will produce a dysphagia, intermittent dysphagia, and this undigested food material gets aspirated in the night time. Nocturnal cough due to aspiration will be present. What is the treatment? And of course, the Dollmann's procedure, endoscopic stapling of the diverticuloesophageal septum. See this, put endoscope, you can see this septum. This is the esophageal cleft, and this is the huge Zenker's diverticular pouch. If you remove this, the esophagus and the diverticular pouch becomes a single cavity, and hence there is no stasis in the pouch. So this is endoscopic Dollmann's procedure. So this is a treatment for this Zengus diverticulum. Coming to the oral cavity. Pre-malignant lesions of oral cavity includes all except. It's a very common, quite important area to note. Erythroplakia, oral hairy leukoplakia, submucous fibrosis. So the answer for this is oral hairy leukoplakia. So oral hairy leukoplakia, even though it carries the term like leukoplakia, it is not a pre-malignant condition. And the most common pre-malignant condition is leukoplakia, and the notorious having more chance of turning into malignancy is erythroplakia, and oral hairy leukoplakia is not a pre-malignant condition. So these are all the pre-malignant conditions: leukoplakia, erythroplakia, candidal leukoplakia, chronic candidiasis, chronic hyperplastic candidiasis, which may lead into malignancy. Erosive type of lichen planus, please remember, erosive type of lichen planus is a pre-malignant condition, and oral submucous fibrosis, as some of they will call it as, is a pre-malignant condition. So these are all the picture questions, how it looks like. So the leukoplakia, you cannot remove the patch of the white patch. In candidiasis we can remove, but leukoplakia you cannot remove the patch easily. You have to do a surgical excision only. So this is leukoplakia, and the angle of the mouth is a common site of leukoplakia, and this is oral hairy leukoplakia. This oral hairy leukoplakia is due to Epstein-Barr virus, which is typically seen in HIV patients. A white, feathery, vertical lesion in the lateral border of the tongue. And this is a bad prognostic indicator on HIV, but it is not a pre-malignant. It is due to Epstein-Barr virus infection. So this is about this oral hairy leukoplakia. What is this? A median rhomboid glossitis due to chronic candidiasis anterior to the foramen cecum, the rhomboid shaped erythematous region devoid of papillae. This is typically commonly due to chronic candidal infection, median rhomboid glossitis. And what is this picture question? Geographical tongue or migratory glossitis, which is a benign condition. There is no much significance. There is nothing to worry about this condition. It keeps on changing its position. That's why it is called migratory glossitis. And this is black hairy tongue. Again, it is a benign condition where there will be, due to xerostomia, increased chromogenic bacterial infiltration will happen and causes a black coat to the tongue. Keeping the hygiene of the oral cavity is a treatment of this black hairy tongue. Young female presents with burning sensation of mouth for 4 months, and hence she totally avoids spicy food. She gives history of regular areca chewing. Her oral cavity picture is given, which is false regarding the condition. Burning sensation of the mouth and regular areca chewing, and typically the oral cavity picture is C, a blanched mucosa. A very usually it is pinkish in appearance, but here a blanched mucosa is present, and this condition is very typically oral submucous fibrosis. So this, in this condition, which is false regarding the condition, trismus is present, pre-malignant, commonly seen in tongue, steroid is treatment. So every point is very typical of oral submucous fibrosis. A gross trismus will be present due to the increased fibrosis, just subepithelial fibrosis, that is called submucosal fibrosis, gross trismus, and very severe burning sensation to the spicy food due to the epithelium will be denuded. It is a pre-malignant, yes, very important, it is a pre-malignant condition, commonly seen in tongue. So that is the answer. The common site is not tongue. We have seen many conditions of the tongue, but remember, this oral submucous fibrosis involves the palate, soft palate, retromolar trigone region, and facial pillars region. These are all the areas, and buccal mucosa are the areas of oral submucous fibrosis, not the tongue. What is the treatment? Intralesional steroid treatment with hyaluronic acid. Steroid with hyaluronic acid is a medical management. Intralesional multiple site should be given to relieve the fibrosis to relieve the inflammatory process, and hence the patient will be having a little good opening of the mouth. And in the end stage where it does nothing works, mucosal or split skin grafting can be done for the patient. This is about oral submucous fibrosis. So all the points are MCQ points, very important. Okay, yes. A few picture questions. A bluish translucent swelling in the floor of the mouth in the oral cavity. Very typically it is called ranula. Ranula is nothing but the mucus retention cyst of sublingual salivary glands. Mucus retention cyst of sublingual salivary gland. This is very, very important, ranula. And a very important MCQ point here is this ranula can plunge through the floor of the mouth, can present as a swelling in the just below the chin in the submental region, and that is called as plunging ranula. And which muscle it plunges through? It plunges through mylohyoid muscle, that is called plunging ranula. Okay. A purple lesion in the oral cavity, specifically in the palatal regions, is Kaposi sarcoma. This Kaposi sarcoma is typically the tumor of HIV patients, and the treatment of this Kaposi sarcoma is intralesional chemotherapy and local radiotherapy can be given. So this is a purple tumor in HIV patients, a Kaposi sarcoma. An edentulous patient had carcinoma of the tongue infiltrating into the lower alveolar margin, that is into the mandible, lower alveolar margin. All the following are possible treatment options except segmental mandibulectomy, marginal mandibulectomy, radiotherapy and commando operations. So very typically a dictum is a tongue malignancy, oral cavity malignancy infiltrating into the bone, you should not give radiotherapy. If you give radiotherapy in these conditions, that may lead on to osteoradionecrosis. Similarly, any laryngeal malignancy, if the malignancy involves the cartilage, the major cartilages, thyroid or cricoid cartilage, if the malignancy involves the cartilage, you must not give radiotherapy. It will lead to radiochondronecrosis. So very, very important. So in any oral cavity malignancy involving the bone, that should be excised before giving radiotherapy. So radiotherapy is not indicated in this scenario. You can do any kind of mandibulectomy, depends on the involvement of the mandible, either a marginal mandibulectomy or segmental mandibulectomy or a total hemimandibulectomy, commando, hemimandibulectomy. Commando is combined mandibular and oral resection, can be done, but you should not give radiotherapy as the primary treatment in this scenario. So the point is simple. Malignancy involving the bone or the cartilage, you should not give radiotherapy. It will lead on to necrosis, osteonecrosis or chondronecrosis. So tongue malignancies, before that the oral cavity malignancy, the most common site of oral cavity malignancy in India is gingivobuccal sulcus or alveobuccal sulcus, because our people have the habit of keeping the tobacco quid in the sulcus. So the most common site is alveobuccal sulcus in Indian population, very important. Worldwide, it is a lateral border of the tongue, ulcerative lesion, which is the most common in the lateral border of the tongue. And the T1, T2, T3, T4 is T1 is less than 2 centimeter, T2 is more than 2, less than 4 centimeter, and T3 is more than 4 centimeter, and T4 I told you invades the adjacent structures extra to the tongue, extra organ involvement. Even if it is a deep muscles of the tongue, it is an extra organ. Deep muscles has attachment to other structures, mandible and hyoid are there to get attached. So deep muscles of the tongue, the bone, the mandible commonly, and pterygoid muscles and pterygoid plates. So all these structures are extra organ. So T4 is the extra organ involvement. And the node of tongue is jugulo-omohyoid. This is the level 3 node. The level 2 is jugulo-digastric, and level 3 is a middle deep jugular, jugulo-omohyoid. Any tongue malignancy, the lymphatics can go up to the jugulo-omohyoid node. So jugulo-omohyoid is the level to which the lymphatic spread can happen commonly. And warty growth, papillaceous growth like this is called verrucous carcinoma. Very few points about verrucous carcinoma is it is a low variant or non-virulent form of the squamous cell carcinoma, and it has no metastasis commonly. And here it is radio resistant. Most of the times it responds to the surgical resection. It will not respond to the radiotherapy as a regular squamous cell carcinoma. So this is about the verrucous carcinoma. Okay. Treatment of the tongue carcinoma is very simply T1, resect that area of the tumor, partial glossectomy, or do a hemiglossectomy. T3, total glossectomy. Simply the grades of glossectomy increases. T4, I told you, when it involves the mandible, we have to do a commando. So glossectomy, total glossectomy with the mandibulectomy should be done in the T4 lesions. This is quite important in carcinoma of the tongue. There is a deformity called after resecting the mandible. If you remove the anterior arch of the mandible, the patient will not be having the mandible for chewing mastication. So this deformity is called anti-gump deformity after resection of the anterior arch of the mandible, anti-gump deformity. So there will be functional loss for the patient, very important. So in this situation, after if you do a mandibulectomy, that should be reconstructed with a bone. So which is the common bone used for reconstructing the mandible? Fibula. So remember that fibula is used for reconstructing the mandible after resection. So that is about this mandibulectomies. So with this, we'll have a little break and we'll be back after 5 minutes. Okay, we are back into the class. Identify this investigation. The girl is lying with all sorts of leads attached all over the body while sleeping. Of course, this is polysomnography, sleep study. The point is, this is the gold standard investigation of obstructive sleep apnea syndrome. So, polysomnography to assess the severity of OSAS, the gold standard investigation in OSAS. Okay. The question is 25-year-old male snorer with OSAS with hypertension and polysomnography shows 10 apneas per hour. What is the next line of treatment? So again, the gold standard treatment for OSAS is CPAP, continuous positive airway pressure. If the patient is having the range of apnea and with any comorbidities like diabetes, hypertension, coronary artery disease, then it is better to go for the treatment CPAP, continuous positive airway pressure, to alleviate this apneic episodes. So we have to do this. So UPPP, if any obstruction is given at the level of oropharyngeal regions or tongue base region, then only we have to go for a surgical procedure. If the patients do not give any obstructive lesions at any particular point, there is no need for a surgical procedure. So, continuous positive airway pressure should be advised for the patient. So, basically, the point to note here is common areas of questioning is there is an index called apnea hypopnea index. What is apneic spell? That is the first definition. Any apneic spells, the cessation of breathing that lasts up to 10 seconds is called one apneic spell. That is very important. That cessation of breathing that lasts for at least 10 seconds is taken to be considered as one apneic spell. So in 1 hour, if the apneic spells, hypopnea or apneic spells is less than 5, that is normal. 5 to 15 apneas per 1 hour is mild OSAS, and 15 to 30 is moderate, and greater than 30 is severe. So first line treatment is CPAP, and the criteria for providing CPAP is in all cases of AHI, apnea hypopnea index more than 15, that is moderate and severe cases, we have to give CPAP. But even in mild cases, 5 to 15 mild cases, if the patient is already having some comorbidities like hypertension or diabetes or CAD, we have to provide CPAP. So that's what in the question, the patient is having a mild OSIS, but along with that, he has hypertension. So the treatment of choice is CPAP. And regarding the pathophysiologist, the points to note, the MCQ points are usually this upper airway collapse due to loss of muscle tone happens in which stage of sleep? REM sleep. So the active a brain in an inactive man, the dream stage, is where the muscle tone will be lost. So at that stage, everything collapses down and the apneic spells will occur. And that will lead on to repeated apnea and repeated arousals, and hence this repeated apnea causes hypoxia, and hypercapnia leads to pulmonary hypertension. Repeated arousals lead on to raised catecholamines, and this metabolic diseases and excessive daytime sleepiness. So these are all the pathophysiology of this obstructive sleep apnea. So the points to note regarding the CPAP is very important, which produces a continuous positive airway pressure to alleviate, to avoid any airway collapse during the sleep. Coming to the laryngeal anatomy, the following is unpaired regarding the muscles or other structures: interarytenoid, corniculate, vocalis muscle, cricothyroid muscle. The answer is interarytenoid muscle. So the transverse interarytenoid is an unpaired muscle of the larynx. Other things, corniculate, cartilage, vocalis muscle, cricothyroid muscle are all paired structures. So in the laryngeal muscles, the only abductor is posterior cricoarytenoid. We know that. Adductors, all the things, tensor is here. So lateral cricoarytenoid, interarytenoid, transverse, interarytenoid, oblique, thyroarytenoid, external part, all the adductors of the vocal cords. And the only tensor of the vocal cord is cricothyroid, very important. So cricothyroid is a wonderful drug and it has many MCQ importance. The only tensor of the vocal cord. It also has adductor function, but the only tensor is the cricothyroid, and the only muscle which is placed outside the laryngeal box, the thyroid cartilage, is the cricothyroid muscle, and the only intrinsic muscle which has a different nerve supply, motor supply, is called cricothyroid. All the intrinsic muscles has its nerve supply, motor supply by the recurrent laryngeal nerve, except cricothyroid, which has its supply from the external branch of the superior laryngeal nerve. That is the importance of cricothyroid, very, very important, which is not the boundary of paraglottic space. There are two spaces in the larynx which are quite important, pre-epiglottic space and paraglottic space. So which is not the boundary, cricovocal membrane, quadrangular membrane, thyroid cartilage, thyrohyoid membrane. So the answer is thyrohyoid membrane, which is more superior than the vocal cord level, paraglottis. The glottis is at the level of middle part of the thyroid cartilage. So the thyroid cartilage forms the lateral boundary, not the thyrohyoid membrane, which is more superior than the vocal cord level. Very simple to answer. So thyrohyoid membrane is not the boundary for the paraglottic space. So coming to the spaces, two spaces, see, any space lateral to the glottis is a paraglottic space. And obviously, the medial boundary will be the false and the true vocal cords. The skeleton of this false and true vocal cords, they will be given in the answer. They will be giving in the answers as the MCQ points. The quadrangular membrane, which forms the skeleton of the false vocal cord, and cricovocal membrane, that forms the conus elasticus, forming the true vocal cord, forms the medial boundaries. Quadrangular membrane above, cricovocal membrane below, forms the medial boundaries of the paraglottic space. And of course, I told you it is well within the thyroid cartilage. See, this is a thyroid cartilage. This is the thyroid cartilage. It is well within the thyroid cartilage. So it is in the thyroid cartilage region. So lateral boundary is the thyroid cartilage. And posteriorly, the hypopharynx hugging the larynx from behind. So the pyriform fossa mucosa forms the posterior boundary of the paraglottic space. And coming to the pre-epiglottic space, as the name implies very clearly, the space in front of the epiglottis is the pre-epiglottic space. Here only thyrohyoid membrane forms the anterior boundary, the epiglottis itself forms the posterior boundary, and the hyoepiglottic ligament forms the superior boundary. So these are all the spaces, pre-epiglottic and paraglottic space, and these spaces are continuous with each other. So any malignancy in any of these spaces can enter into the other space and involves the opposite side of the larynx. So these are the importance of this free spaces of the larynx. Coming to the nerve supply, see this, from the inferior vagal ganglion, the superior laryngeal nerve divides into the internal branch and external branch, and the vagus nerve proper descends down on the right side, winds around the right subclavian artery, and left side descends deep into the mediastinum, winds around the arch of aorta, and ascends as the recurrent laryngeal nerve in the tracheoesophageal groove. If you have a close watch, the superior laryngeal nerve divides into internal branch and external branch, already we have seen, and the recurrent laryngeal nerve goes in the tracheoesophageal groove. Okay. This superior laryngeal nerve has internal branch which is sensory above the vocal cord, external branch which is the motor for the cricothyroid muscle. The only intrinsic muscle receiving the different nerve supply is cricothyroid, external branch of the superior laryngeal nerve. Recurrent laryngeal nerve, it has a sensory supply and motor supply. Sensory below the vocal cords and motor all the intrinsic muscles of the larynx. And the Gallen's anastomosis between this recurrent laryngeal nerve and superior laryngeal nerve sensory supply at the level of glottis. Regarding the diseases, congenital lesions of the larynx, where the most common congenital lesion is laryngomalacia. And commonly the questions will be from laryngomalacia. False regarding laryngomalacia. The most common cause of stridor in newborn, yes. Elongated omega-shaped epiglottis, yes. Inspiratory stridor, yes. Stridor worsens on lying in prone position, no. The answer is D. So stridor will be worsens on supine position due to the more sucking effect of the epiglottis and epiglottic fold. If it is placed in the prone position, the sucking effect will be decreased and hence the stridor decreases. So the most common cause of stridor in children is don't go into the laryngomalacia, don't mark laryngomalacia. Very important. Please have a clear look. There are usually quite easy, simple like questions, but tricky questions will be there in any subject. So most common cause of stridor in children. If the question is like this, please remember the answer is CRU. Acute laryngotracheobronchitis. CRU is the very typical answer for this in children. If the laryngomalacia is to be the answer, the question should be the most common cause of congenital stridor or the most common cause of stridor in neonates. Neonates. So this is the area point where laryngomalacia is to be the answer. In children, if the question is broadly in children, the answer is CRU, acute laryngotracheobronchitis. Of course, not again foreign body. It is not the common cause. CRU is the common cause of stridor in children. Please remember, this is very tricky question. Many times you may mark the wrong answer. So laryngomalacia and congenital laryngeal stridor, the most common congenital anomaly of the larynx, and it is starts shortly after birth within first few weeks of the life. It is inspiratory, intermittent stridor, normal cry. And very importantly, any lesion involves the supraglottic level will produce inspiratory stridor. Any lesion at the glottis and the subglottis level will produce biphasic inspiratory and expiratory stridor. And also the trachea, cervical trachea, these things, glottis, subglottis and cervical trachea will have the biphasic stridor, and any lesion that involves thoracic trachea and bronchi will have the expiratory stridor. So inspiratory stridor, biphasic stridor and expiratory stridor. This is one point. And any lesion involving the vocal cords will produce hoarse cry. Any lesions that doesn't involve the vocal cord, the cry will be normal. So these are all the points to note. So with this laryngomalacia, it is the epiglottic folds and the epiglottis which are very flaccid and that is sucking with each inspiratory thing, supraglottic flaccidity. So that is why inspiratory stridor. And the intermittent stridor, of course, when the patient is placed in the semi-prone position, the stridor decreases, and in supine it increases. And it is involved only supraglottis. Glottis is normal in these patients. So the cry is normal in laryngomalacia. Treatment, reassure the patient, you need not do anything. In a severe cyanosis only, we can go for ariepiglotoplasty. And the sign is omega shaped epiglottis, curled up epiglottis and ariepiglottic fold due to increased flaccidity. The second most common cause of congenital stridor is vocal cord palsy. And the third most common cause of congenital stridor is subglottic stenosis. So where Meyer-Cotton staging is used. So simply Meyer-Cotton staging is used in subglottic, assessing the severity of subglottic stenosis. That's a very common MCQ they will be asking. Laryngocele. Remember, laryngocele is different from the laryngomalacia. So laryngocele is due to the trumpet blowers, nathoswரம் blowers, glass blowers, due to the increased transglottic pressure. The saccule, oil can of the larynx will get distended with the air, and that will prolapse either internally or that may breach the thyrohyoid membrane, MCQ point. The external, it may present as a external swelling. So the external laryngocele comes out through which membrane? They will ask you in the MCQs, thyrohyoid membrane. Okay. And there is a classical sign called Bryce sign. We have seen a sign called Boy's sign in Zenker's diverticulum, the gurgling sensation over the lateral aspect of the neck. Here it is a Bryce sign. If you compress this external laryngocele, the air will gush out of the this laryngocele. So it is Bryce sign. Easy to remember. I usually tell laryngocele is nothing but air containing saccule. So air containing balloon. If you release the balloon immediately, if you release after blowing up the balloon, if you release the balloon, it will fly with the air escaping out of the balloon. What is the sound you will encounter? It is like brrr. The balloon will fly with the sound, the air, the turbulent air escaping from the balloon with brrr sound. So brrr sign, Bryce sign, brrr. So the Bry sign, just to remember, so easy to remember, the Bry sign is seen in laryngocele and the Boy's sign is seen in Zenkus diverticulum. So this is about the laryngocele. If it is an internal laryngocele, endoscopic procedure is warranted, and if it is an external laryngocele, external procedure with removing the upper lamina of the thyroid cartilage is warranted. So this is about the laryngocele. A 6-year child brought to OPD with sudden onset dyspnea, stridor, fever. 6-year child, a little older, with sudden onset dyspnea, stridor and fever, with child sitting in this posture. Diagnosis. So this is classical posture called tripod posture. The child sitting with both arms on the side supporting the thoracic region with the chin extended for air hunger. So this is typically the tripod posture which is seen in acute epiglottitis. Diagnosis: retropharyngeal abscess. The patient will be having a flexed neck due to prevertebral muscle spasm, not extended chin. ALTB, they will not be much dyspneic and they will not be sitting in this tripod posture. Acute epiglottitis, that is the answer. Foreign body trachea again is not the typical presentation. So acute epiglottitis, sudden onset dyspnea, stridor, fever, and the child sitting in this posture. Again, in the foreign body trachea, there will not be fever. So it is an infective condition, acute epiglottitis. So tripod posture, the arms on the side to support the thoracic cage for more breathing. So you support the breathing, and with chin extended, because epiglottis is swollen and closing the larynx. With the chin extended posture, the closure of the larynx is a little avoided so that the baby can breathe a little. So this is called tripod posture. And on taking the X-ray, we have this enlarged epiglottis, very classically thumb sign, enlarged epiglottis. And there are two kinds of infections of the larynx: acute epiglottitis and ALTB crew. And this sign, see, this is a classical steeple sign. So in ALTB, as the name implies, acute laryngotracheobronchitis, the entire airway is inflamed and the maximal inflammation, narrowing will be present in the subglottic region, because subglottis is the narrowest portion of the larynx in children and the glottis is the narrowest part in the adults. So hence there will be a steepling sign in the subglottic region. Steeple is nothing but the steeple of the church. The church will be narrow at the tip, at the apex. So this is called steeple sign. And the point says it is bacterial, this is viral, this is school going children, it is young children less than 3 years. And acute epiglottitis is more mortal. Within few hours, the patient will be having severe stridor and they may go for hypoxia and collapse. So, and the thumb sign is a classical sign in X-ray, and the treatment is IV antibiotics are indicated because it is bacterial Haemophilus influenza type B, and oxygen racemic adrenaline mixture to relieve the inflammation of the epiglottis. Adrenaline nebulization is very, very important in acute epiglottitis. Always be ready with intubation or tracheostomy. If the patient suddenly goes for any hypoxia, we have to intubate or tracheostomize. But ALTB is very gradual. Barking seal-like cough, barking seal-like cough, which is croupy cough, they will say. The painful croupy cough will be present in the croup, and stridor will be only in the late stages, and it is not very severe. So on the steeple sign is the sign in the X-ray, and humidified oxygen, supportive measures, steroid nebulization are all indicated. And antibiotic has no primary role in the ALTB because the typical organism is virus, parainfluenza virus, not the bacteria. TB larynx features, very typically they will be sometimes asking the TB larynx. See the appearance of the TB larynx: a granular mucosa, turban epiglottis, mouse nibbled ulcers of the vocal cords, painful dysphagia, very important, painful, very painful. It will be eroding all the mucosa and the nerve endings will be exposed and there will be very painful dysphagia. And mammillated arytenoids, due to the multiple tubercles, it is producing as a mammillated arytenoids. So these are all the typical terminologies. Turban epiglottis due to pseudoedema of the epiglottis. Turban epiglottis, mouse nibbled ulcers, mammillated arytenoids are the typical features of TB laryngitis. So coming to the vocal cord palsy, a few points to concentrate, and we need to understand the vocal cord palsy. What are the points to note here? On laryngoscopy, vocal cords are described as being in cadaveric position. This means they are paralyzed and abducted, paralyzed and bowed, fixed, none of the above. It cannot be the none of the above. Fixity is the word used in malignancy. Any malignant growth infiltrating the deeper part of the vocal cord or in the vocalis muscle that causes immobility of the vocal cords. Fixity is the term used only in malignancy. Okay. It is typically they are showing an anatomical position called cadaveric position. So it cannot be the fixity. Cadaveric position. This means they are paralyzed. Okay. That first point is okay. Abducted or bowed, which is the thing. Cadaveric position is a position where the point is neither adduction nor abduction, and it will be present in between positions. So the paralyzed and bowed, it becomes flaccid. So vocal cord, it is not be tensed, it is little flaccid. So it is called bowing of the vocal cord. So it is paralyzed and bowed. Regarding the vocal cord palsy, points to note are recurrent laryngeal nerve supplies all the abductors and adductors of the larynx except only one muscle, cricothyroid, and that cricothyroid is supplied by the superior laryngeal nerve. Hence, if we cut the recurrent laryngeal nerve, all the abductors and adductors are lost except one muscle, cricothyroid. What is the action of cricothyroid? Both tension and adduction. So due to the cricothyroid action, it keeps the vocal cord in the adducted position. So which movement is absent now? Cricothyroid is doing its adductor function. So in oral and palsy, which function is lost? Abduction is lost clinically. Hence, please remember in MCQs, they'll be using these terms. Oral and palsy is called abductor palsy because vocal cord is in the adducted position due to the cricothyroid action. Okay. If RLN and SLN are both are been palsied or defective, not functioning, then the vocal cord is neither adducted nor abducted. That adducted function is also lost now. That adducted function by the cricothyroid is also lost now. Hence, both RLN SLN palsy is called as adductor palsy. Please remember this. RLN palsy, abductor palsy, because cricothyroid is existing and it's doing its adductor function. But if you cut both RLN and SLN, no adduction, no abduction, that existing adductor function is also lost now. So the vocal cord is present in the cadaveric position. So it is called as adductor palsy. So these two things very important to note. So it can be called as adductor and abductor palsy, of course, but which is very important function of the larynx? Adduction. Adduction only, it prevents the foreign body entry into the larynx. It is a watchdog of the lower airways. It prevents aspiration. So the vocal cord is in the cadaveric position, adduction is lost and more aspiration happens. So the adductor function is lost here. So it is called as adductor palsy. So the both nerves are gone, it is called adductor palsy. Okay, this is based on this Wagner-Grossman theory, where the oral and palsy, the cricothyroid is working and keeps the cord in the median, paramedian position or adducted position. So what are the this functional positions or anatomical positions of the vocal cords? If the vocal cord is present in the midline like this A, it is called median position, or if the vocal cord is present just away from the median position is called B position is called paramedian position. So for clinical purpose, both A and B are called adducted positions. That's all. Both are similar, median or paramedian positions or adducted position. And D is abducted, far away. No adduction, no abduction. What is the position? C, cadaveric or lateral or intermediate position. Neither adduction nor abduction. Okay. So, in case of RLN palsy, cricothyroid is working. Hence, the cord may be either in median or a paramedian position, adducted position. If you cut both RLN and SLN, no muscle is working, no adduction, no abduction. Please remember. So it is occupying the cadaveric, intermediate or lateral position. Okay, that's all. In case of isolated SLN palsy, only the cricothyroid will be non-functioning, but all other abductors and adductors by the RLN will be functioning. So the patient do not have any immobility. The vocal cord will be mobile very normally, but since the cricothyroid, the tensor is gone, a little flaccidity, bowing of the vocal cord is present in the isolated SLN palsy. So isolated SLN palsy will not cause much problem for the vocal cords other than for the singers, professional singers, where they need to increase the pitch of the voice, where the cricothyroid is very important for tensing the vocal cords. So this is a point regarding this vocal cord palsy. Coming to the clinical scenarios. Before that, the most common vocal cord palsy is left vocal cord palsy. This is due to left vagus nerve dips more deep into the mediastinum. It has a long course. So left vocal cord palsy is common. And the most common cause for the vocal cord palsy, most common cause for the vocal cord palsy is idiopathic or thyroidectomy. See, there are standard textbooks which clearly says idiopathic is more common, and equally some other standard textbooks giving as thyroidectomy as a common cause. Trust me, hope they will not confuse you with this question. So there is a little dilemma between this standard textbooks. So idiopathic or thyroidectomy common cause for unilateral. Bilateral vocal cord palsy, again thyroidectomy is the most common cause for bilateral vocal cord palsy. And these are all the points to remember. And one more point, the ominous cause for left vocal cord palsy. No, the left vocal cord dips deep into the mediastinum. So bronchogenic malignancy can infiltrate the left vagus nerve. So any person coming with left vocal cord palsy, particularly in adults and elderly people, you must rule out bronchogenic malignancy. That is not the most common cause, but that should be ruled out. So left vocal cord palsy, if any patient is coming to you, you must rule out bronchogenic malignancy. That's all the points regarding the common causes. Okay. Coming to the clinical scenarios. In bilateral palsy of the recurrent laryngeal nerves, there is bilateral palsy of the recurrent laryngeal nerves. What happens? Bilateral abductor palsy. What happens? Both vocal cords in the paramedian position or median position. So if the both vocal cords in the median or paramedian position, they can adduct, they cannot abduct. So it is bilateral abductor palsy. So the speech is normal, aspiration can be prevented, breathing will not be present, severe stridor. So in any case of vocal cord palsy, three symptoms to be assessed. What happens to voice, what happens to aspiration, and what happens to breathing. This is very, very important, based on which only the treatment is being determined. Voice, aspiration, breathing. Of course, these are the functions of the larynx. That's all. So in a bilateral palsy of the recurrent laryngeal nerves, there will be a preserved speech with a severe stridor, both in the paramedian person. So speech is preserved, but severe stridor will be present. In bilateral abductor palsy of the vocal cords, following is done except the same question, but the terminology they have changed. So in bilateral recurrent laryngeal nerve palsy, that is called as abductor palsy, the same previous scenario. In bilateral abductor palsy of the vocal cords, following is done except which should not be done. Fat injection, cordotomy, nerve muscle implant, arytenoidectomy. Again, both the cords in the paramedian or median position, adduction is present, which is the main problem for the patient here. There is no space for breathing. So we need space for breathing for the patient. So we can do cordotomy, we can do nerve muscle implant for any sort of vocal cord palsy, we can do arytenoidectomy to create a space for breathing. But already there is no space for breathing. We should not do injection laryngoplasty, we should not do fat injection. So fat injection is done in a different kind of pathology. We will see what. So we have the four scenarios. So with this diagram, I will explain you what are all the treatment that can be done with this four scenarios. See, the upper two diagrams are unilateral vocal cord palsy. We will see one by one for your understanding. And the lower two diagrams are bilateral vocal cord palsy. So the upper diagrams are unilateral vocal cord palsy and lower diagrams are bilateral vocal cord palsy. Okay, sure. Now, coming to the each variety, the first one. The first picture, please concentrate on only this picture, forget all other pictures. Okay, sure. Assume the patient is having right oral palsy, right abductor palsy. What happens to right oral palsy? This vocal cord will be placed in the median or the paramedian position. So that is immobile. The right vocal cord is immobile in the median or paramedian position. So this is a point. My right vocal cord is not working. What happens to the left vocal cord? It is working very normally. So my right cord in the median position and my left cord is coming and touching and going away, coming and touching and going away. So during its touching the opposite cord, adduction happens properly. So voice is more or less normal, aspiration is prevented, and going away, a good space is present for breathing. Abduction is also happening with the opposite normal cord. So breathing is good. So voice, mild hoarseness may be present, no big aspiration, and breathing there is no problem. And hence, in this first variety and the unilateral recurrent laryngeal no palsy, unilateral recurrent laryngeal no palsy or unilateral abductor palsy, there is no big problem for the patient, no much treatment is necessary, just to give a speech therapy to improve his hoarseness. So that is about the unilateral abductor palsy. Okay, please forget about the first picture. Coming to the second picture, please remember, forget all the other pictures, please forget. In this condition, let us assume the patient is having right-sided both RLN, SLN organ, right-sided both RLN and SLN organ. What happens? The right cord will assume a cadaveric position like this, in the lateral position away from the midline. So the right cord is immobile. So right is deceased, right cord is immobile. The left cord is doing its normal function, coming to the midline for adduction, going away for abduction. During adduction, since the right deceased cord is away from the midline, there is a space between these two cords during adduction. So the patient has breathy voice, and there is a chance for aspiration because the space is existing. And during abduction, the normal cord is going away very normally and breathing is quite normal. So what happens? Breathy voice and aspiration is happening in this variety, unilateral adductor palsy, or simply this is a symptomatic variety of unilateral where you need treatment. What is the treatment you can do? You can do two things. Either you can inject something to make the cord bulge so that it stands in the midline, so that that gap is been obliterated, the symptoms are alleviated, or push the cord from externally to the medial part, medialization thyroplasty. So you can do a injection laryngoplasty or a medialization thyroplasty to obliterate that existing space, which is a problem for the patient here. So this is simply one variety of unilateral is asymptomatic, no much problem. But another variety of unilateral is symptomatic vocal cord palsy. So unilateral adductor palsy is symptomatic where you need a medialization thyroplasty. This one type where MCQ important. And only one more type is there for MCQ important, just to understand, that's all. Now coming to the bilateral varieties. Bilateral RLN palsy is present for this patient. Both the cords are been cut and commonly seen in thyroidectomy. What happens if the both organ are been cut? Both the cords will be in the median or paramedian position. That is what the question we have seen now. So both the cords in median and paramedian, it will adduct. Since it is a bilateral recurrent laryngeal nerve palsy, it is bilateral abductor palsy. It will not abduct. It will adduct and will remain in the median or paramedian. So what happens? Voice, yes, good. It is adducting. Aspiration, there is no aspiration. Breathing, very difficult. Severe stridor will be there for the patient. So we have to do a immediate tracheostomy for the patient to relieve the stridor, and we need some good treatment for creating some gap. What are all the treatments available? Either we can lateralize one cord a little, that is called lateralization thyroplasty, or we can remove the arytenoid on one side to create a good space, endoscopic arytenoidectomy. Of course, little aspiration happens, that one indicated treatment, this endoscopic arytenoidectomy. And one more very important treatment in this variety is we are doing cordotomy like this. See, we are creating a gap here at the level of membranous vocal cord and the cartilaginous vocal cord, anterior 2/3 and posterior 1/3. Cut the cord at this level so that we can create a good gap in this level through which the patient can breathe. This is called cordotomy, and this cordotomy is called Kashima cordotomy. So this is a very important surgical procedure being done for bilateral abductor palsy to produce a gap. So with this anterior part of the vocal cord, the patient can phonate. With this posterior part of the vocal cord, the patient can prevent aspiration. With this middle opening, the patient can breathe at least without tracheostomy. The patient cannot do strainful activities, but at least without tracheostomy, they can survive. So these are all the treatment for the bilateral abductor palsy. Last variety, bilateral RLN, SLN, everything is lost. Bilateral adductor palsy. Both the cords are present in the cadaveric position. There is existing no adduction, no abduction. A gap will exist. Massive aspiration and aphonia will be present. This is a very, very rare situation where either laryngectomy can be done because no important function of voice and aspiration is lost. So laryngectomy can be done, or tracheoesophageal diversion procedures are there, can be done for the lost variety, which is very rare variety. So the common questions will be between this unilateral abductor palsy, unilateral adductor palsy, that is symptomatic, where we did injection laryngoplasty or a medialization thyroplasty, or bilateral abductor palsy where we did lateralization thyroplasty or a cordotomy procedure. So these are the two important areas where we need treatment for the patient commonly, where we commonly encounter the patients. So this is about this vocal cord palsy. And there are certain thyroplasties called type 1, 2, 3, 4 naming. That's all. Type 1 is called medialization, where we have done in the unilateral vocal cord palsy, and type 2 is lateralization, we have done in the bilateral abductor palsy. Type 3 is shortening, which is done in puberphonia, because puberphonia is mutational voice, the adolescent voice, where they will be having still a feminine voice. So what happens? To get male voice, we have to shorten the vocal cord. So shortening of the vocal cord, it decreases the pitch, and hence the feminine voice is converted into masculine voice, the puberphonia. But remember, the prime treatment for puberphonia is speech therapy. If it fails only, we have to go for a surgical therapy. And type 4 is lengthening of the vocal cords, which is done in the androphonia or transgender surgeries for the patient for whom, if their feminine voice is to be converted, sorry, a masculine voice is to be converted into feminine voice, we have to stretch the vocal cord, lengthening of the vocal cord. So remembering this type 1, 2, 3, 4 is quite easy. I tell you, see, if we have two vocal cords, if you medialize the vocal cord, what is the number you are getting? 1. So type 1 is medialization, which is done in unilateral adductor palsy. If you split the two chords, lateralize the chords, it becomes number 2, 1 and 2. So type 2 is lateralization of the vocal cords, which is done in bilateral abductor palsy. Type 3, type 4, which is smaller 3. So shortening is type 3, lengthening is type 4. So puberphonia, if you shorten the vocal cord, the feminine voice is converted into masculine voice. In transgenders, for whom they want a feminine appearance and a feminine voice, their vocal cords is stretched so that it becomes high pitched voice, a feminine voice, which is for the transgenders. So this is types of phonosurgeries or thyroplasties. Coming to the malignancies, tumors, neoplasms. All the following are true regarding juvenile papillomas except HPV11 is virulent, laser surgery is a treatment, stridor is common, has malignant potential. So the juvenile papillomas do not have the malignant potential. Yes, HPV6 and 11 are commonly indicated as the etiology. Laser surgery is indicated. Stridor is that common presenting symptom of juvenile respiratory papilloma. Is massive papillomas will be there, and only the adult papillomas has malignant potential. So this is a massive recurrent papillomatosis of the childhood, and this is a single solitary adult papillomas. And the main differences between, remember, recurrence is very common in juvenile papillomas, and interferon alpha, cidofovir, bevacizumab, monoclonal antibodies are indicated to prevent recurrence. But malignant potential is very typically common in adult onset papilloma. So adult onset papilloma is a pre-malignant condition. Okay. Coming to the malignancy of the larynx, where staging, understanding the staging is quite important. So what is the stage of laryngeal carcinoma shown here? Again, they have clearly mentioned with the arrow marks, the thyroid cartilage is breached by the malignancy growth. I told you, if it is extralaryngeal, extra organ. So thyroid cartilage and the cricoid cartilage is the extra organ. Only the mucosa is the laryngeal structure. So if the cartilage is involved, it becomes T4. So there is no big confusion, N1 or whatever, it is T4 malignancy. So thyroid cartilage is breached here, and hence the malignancy has become T4 malignancy. A professional voice user developed glottic cancer. He is afraid of losing his voice after treatment. His laryngeal endoscopy shows bilateral mobile vocal cords with growth as given, which is the preferable management. So many laryngeal malignancies, they will be asking the treatment based on the staging. So I will come to this question later. What is the staging easily we can remember? So T1 and T2 are the early malignancies. T3 and T4 are the late malignancies. See, T1 easily to remember if the question carries this point, mobile vocal cords. This will be either T1 or T2. Very simple. A growth with mobile vocal cords, whether it is a supraglottis or glottis or subglottis, whatever the growth it is. Please remember, it is if the question carries the term mobile vocal cords, it is T1 or T2. Smaller growth is T1 and a bigger growth is T2. Okay, easy to understand. I am telling you in a easier way to find in the questions. If the word fixity occurs, fixed vocal cord or immobile vocal cord. Fixity is a very typical term they will be using. Or hemilarynx is fixed due to the infiltration inside the paraglottic space. Fixity is used. Then T3, the stage is T3. If you find the point cartilage invasion, either it is a thyroid or cricoid, a bigger cartilage invasion, or the term perichondritis, please remember, perichondritis of the cartilage is present. If the term perichondritis is used, that itself means thyroid or cricoid invasion is present. So the stage has become T4. Even in a small growth, if it breaches the cartilage, like anterior commissure growth, which is very near to the thyroid cartilage, even if the growth is very smaller, but if the perichondritis is present in the quiescent, that means it is T4 stage. Please remember, if the cartilage is involved, we have to go for laryngectomy. There is no other option. So this is the treatment based on the staging. So staging is very important to understand in the questions. So coming to the questions there, A professional voice user developed glottic cancer. He is afraid of losing his voice after treatment. His laryngeal endoscopy shows bilateral mobile vocal cords with growth as given. See, a circumscribed growth is very clear margins is given, which is a preferable management nowadays. Transoral CO2 laser, radical radiotherapy, vocal cord stripping, chemotherapy. So the uh, treatment nowadays for such a circumscribed growth with mobile cords, early lesion is transoral CO2 laser. If you find a good margins around the growth, so we can clearly remove the growth completely with good margins with the laser. In olden days, it was radical radiotherapy, but nowadays the treatment is transoral CO2 laser. If both these options are given, the better option is transoral CO2 laser. A good margin lesion, circumscribed lesion, early lesion, CO2 laser is a good choice. That's all. A patient presents with carcinoma of the larynx involving the entire length of the left vocal cord with the left arytenoid. Treatment of choice is a patient presents with carcinoma of the larynx involving the entire length of the left vocal cord with the left arytenoid. Treatment of choice is, see, they have not given cartilage invasion. That's very important. The bigger cartilage, that is a thyroid or cricoid cartilage invasion, they have not given. But here the growth is a little bigger growth, entire length of the vocal cord and the arytenoids. In a bigger growth, laser is quite impossible. So what is the next option? We have to go for a partial laryngectomy is the option. So this is a treatment for a bigger growth lesions. That's all. See, we will come back to the question again after watching this treatment options in a easier way. See, in laryngeal malignancies, there are conventional treatment. What is a conventional treatment means? In early treatment, early malignancy, T1 and T2, the treatment of choice is radiotherapy, radiotherapy. And if the growth is little bigger, means infiltrating the paraglottic, fixity of the hemilarynx or vocal cord is happening, then the treatment is with radiotherapy, we have to go with chemotherapy, concurrent chemotherapy with cisplatin is the common chemotherapeutic agent. We have to go for that. So in the conventional treatment, voice preservation is very important. In laryngeal malignancies, voice preservation surgeries are very important. See, the surgical resection gives a good result for the laryngeal malignancy. But if you tell them, I will resect your part of the larynx or the larynx, entire larynx, you will lose your voice, the patient will not accept for the treatment. For humans, speech is very important, voice is very important. Hence, the dictum in laryngeal malignancies, as far as possible, voice preservation strategy should be followed. Very simply, voice preservation strategy should be followed. And hence, as much as possible, give a voice preservation protocol treatment. That's all. So in T1, T2, T3, we are giving radiotherapy or concurrent chemoradiotherapy. But in a stage of T4, please remember, once the cartilage is breached, I told you, if you give radiotherapy, it causes massive chondronecrosis, infection, the patient will die. So this variety, there is no other option. Laryngectomy should be done. Total laryngectomy is the treatment of choice. Okay. There are certain problems with radiotherapy. We have to give for a longer period. It is more morbid. It causes external skin and internal mucosal abnormalities. More comorbidities will be there. So apart from radiotherapy, which is a better treatment, the newer modality of treatment nowadays is newer modality. T1 lesion, a small lesion with the good margins, the best treatment is transoral CO2 laser. With a single sitting, we can remove the growth completely and the patient becomes normal. There is no need for giving radiotherapy for 30 days or 40 days for growth of the larynx. So radiotherapy has its own demerits. So CO2 larynx, remove the entire growth. Fantastic. In a single sitting, the patient will be okay. So the best treatment here is a T1 lesion CO2 laser. T2 means a bigger growth, mobile cords or impaired mobility, but mobility is preserved. Here, laser cannot be given in a crevices of the larynx. So we need to treat the patient. At the same time, radiotherapy is not preferable. What they are doing nowadays? Partial laryngectomy. By doing a partial laryngectomy, voice is preserved with the remaining part of the larynx and also avoiding the radiotherapy possible. So this T2 larynx and T3 larynx, they are doing partial laryngectomy nowadays. A bigger growth. Partial laryngectomies can be done with preserving the voice. T4 larynx, any other newer modality? No. In T4, if it is cartilage is breached, no other option. We have to again go for total laryngectomy only. No other option. So this is the things about the newer modalities. So CO2 laser in a small earlier lesion, partial laryngectomies in a bigger growth, and cartilage invasion, total laryngectomy. That's all. So this is what the questions were. So based on this only we are answering. See, the patient presents with carcinoma of the larynx involving the entire length of the left vocal cord with left arytenoid, a bigger growth. Treatment of choice is, please understand, if it is a conventional therapy, we can go for radical radiotherapy. There is no big problem. It is a T2 growth. Radical radiotherapy can be given, but the better choice of treatment is partial laryngectomy, which has a better cure for the patient. So the newer modality, if it is present in the choices, please go for that. That's all, partial laryngectomy. So that is about this answer. And the most common site is glottic carcinoma, and the maximal nodal metastasis is very common in supraglottic malignancy, small MCQ points. The best prognosis is glottic malignancy, and the worst prognosis is subglottic malignancy, because easily mediastinal nodes can be involved and they can be a worst prognosis. So this is about the differences between this laryngeal malignancies and their treatment. Post laryngectomy tracheostome picture. Identify the device. What is the device the patient is having? Post laryngectomy patient. So very typically after laryngectomy, after total laryngectomy, what we have to do? Give the rehabilitation of the voice. This is the area of questioning, frequent area of questioning now. So tracheostomy tube, tracheoesophageal feeding tube, tracheoesophageal prosthesis, electrolarynx. Please remember this picture. Have a good look at this picture point. Tracheoesophageal prosthesis. So this process is used for voice rehabilitation after laryngectomy. See this. After laryngectomy, you will be removing the whole larynx from hyoid to the cricoid. You will be removing the whole larynx. And the remaining trachea is sutured to the skin. Remaining trachea sutured to the skin. That is called end tracheostome. So patient can directly breathe through this end tracheostome. So how the patient can speak? There are certain methods. Even though there is no larynx, we can give voice rehabilitation. What are all the methods? Esophageal speech, electrolarynx, which gives a robotic voice, like this is electrolarynx, a device, external device. Tracheoesophageal speech. So these are all the three kinds of speech. Esophageal speech, asking the patient to swallow air, and that air is used to vibrate that existing pharyngoesophageal segment to produce voice. Quite difficult to learn, but can be applied. But more easier and more applicable way is tracheoesophageal speech. That is the point. What is tracheoesophageal speech? So this is the processes, Blom-Singer processes. So we know this is the end tracheostome, and the process is inserted in the tracheoesophageal wall. If the patient wants to speak, he can close the tracheostome, and the air from the lungs goes through this univalvular processes and exit in the pharyngoesophageal segment and vibrate. So this is tracheoesophageal processes, which are fantastic device for voice rehabilitation after laryngectomy. And the picture question is very important. This is how a tracheoesophageal processes looks like in a patient and a tracheostome. So this is the tracheoesophageal processes. Okay. And there is one more important rehabilitation. It's been mentioned is polite yawning. Because the patient is constantly breathing through the tracheostome, their nose is not utilized for this sniffing and olfaction. So polite yawning, so as if you will be yawn with the closed mouth. If you yawn with the closed mouth, the air builds up in the retrooral and the retronasal area, and that is used for olfaction purpose. This is called polite yawning, used for post laryngectomy olfaction rehabilitation. Nodal staging, please make a note N1, N2A, N2B, N2C, N3. So anything less than or equal to 3 centimeters N1, single ipsilateral A, single ipsilateral 3 to 6, multiple ipsilateral B, B is bi, multiple ipsilateral. Any contralateral node, please note this is MCQ point, any contralateral, a right-sided pyriform fossa growth and a left-sided node, it becomes N2C. But any node greater than 6 centimeter is N3. So this is the N staging, quite often they may be asking you. Coming to the tracheostomy and foreign bodies, with this we can finish it off the throat area. In emergency tracheostomy, the following structures are damaged except isthmus of thyroid, inferior thyroid artery, thyroidea artery, inferior thyroid vein. And of course, the answer is inferior thyroid artery. See, inferior thyroid artery is more lateral, and it's very, very difficult to injure the inferior thyroid artery in a midline tracheostomy, of course. All other things, thyroid artery is very rare, but if it is present, that causes massive bleeding. Of course, the inferior thyroid vein are the common areas of bleeding. An ICU patient on prolonged mechanical ventilation underwent tracheostomy. After recovery, the tracheostomy tube was removed. Few weeks later, the patient presented with stridor again. What would be the cause? So after tracheostomy removal, the patient presented with stridor, which is a very typical classical clinical question. What would be the cause? Glottic stenosis, tracheoesophageal fistula, subcutaneous emphysema around trachea, tracheal stenosis. We need to know what are the complications of tracheostomy. And the answer for this question is tracheal stenosis. And many people may think glottic stenosis also cause stridor. Of course, but tracheostomy will not cause glottic stenosis. So tracheostomy, the complication of long-standing tracheostomy is tracheal stenosis. Very important. So any tracheostomized patient, if they are presenting after a few weeks again with stridor, you have to rule out tracheal stenosis. This is very, very important. So complications, intraoperative, it is hemorrhage, sudden apnea, pneumothorax due to pleural injury, of course. Early postoperative, blockage of the tube, we will know that accidental decannulation due to coughing, it can decannulate. And very importantly, the question MCQ, and we are not much aware of this complication, but it's quite common, subcutaneous emphysema. After immediate tracheostomy, the air from this trachea can leak into the subcutaneous tissues around the tracheostome. So that causes subcutaneous crepitus in the area, subcutaneous emphysema. This is due to tight suturing of the stomal region. So if there is emphysema, release the sutures, the air will gush out, escape outside the tissues. So that is subcutaneous emphysema. It is not dangerous. It will resolve on its own within few days. So, but that is one important complication in the early postoperative. Within 1 or 2 days, within the next day itself, the patient will be having the subcutaneous emphysema. And the treatment is releasing the sutures around the stoma. Late postoperative, it's quite important to note. So, what are all the late postoperative complications? See, when the tracheostomy tube is present like this in the trachea, one thing, it can cause the constant rubbing of the posterior tracheal wall, and tracheoesophageal fistula can occur. And whatever the patient drinks, it will get aspirated, tracheoesophageal fistula. And the tip of the tracheostomy tube will erode the anterior tracheal wall, and if there is innominate artery in the midline, that causes massive bleeding in the postoperative period, late complication after 10 days or so. If the tracheostomy tube is present for more period, after removal, the tracheocutaneous fistula may persist, that will not close properly, tracheocutaneous fistula. And the more important complication is tracheal stenosis. So if you inflate the cuff for a constant period for many days, it will cause the pressure around the tracheal mucosa, ischemia, and causes fibrotic stenosis. So after the removal of the trachea, this area will go for stenosis and causes stridor for the patient. This is called tracheal stenosis. How to prevent? We often have to deflate the tube very often, once in 2 to 4 hours. If you inflate the tube, that should be often deflated to prevent tracheal stenosis. Or nowadays we are having the low pressure, high volume cuff, which exerts little pressure over the tracheal mucosa. So these are all the things to prevent tracheal stenosis. So very important is tracheal stenosis is a very important complication of late complication of tracheostomy. So we have these two kinds of tubes, plastic tubes and metallic tubes. In both the tubes, we have the inner cannula and outer cannula. Remember that. But ventilatory support is possible only with the plastic tubes. It is not possible with the metal tubes. And the metal tubes often you have to replace for every 2 to 3 months because it is more corrosive. The only advantage of metal tube is cheaper, that's all. Otherwise, the plastic tubes are very ideal for ventilatory purpose or even for the cleaning purpose. So it has both inner and outer cannula as in the metal tube. And speaking valve is also present. If a patient wants to speak, even in the metal plastic tubes, we have the speaking valves nowadays. The patient can speak. All are true regarding aerodigestive foreign bodies except coin foreign body is common in cricopharynx, peanut commonly lodges in the right bronchus, palpable thud and audible slap is seen in tracheal foreign bodies, fishbone commonly lodges in pyriform fossa. So very importantly, we may think the fishbone commonly lodges in pyriform fossa is right answer. Actually, the most common site of fishbone lodgement is tonsils, very important, tonsils. And the next is base of tongue. Please remember, the crypts of tonsil are notorious place for the fishbone lodgement and base of tongue. The pyriform fossa is not a common site of fishbone lodgement. So the answer here is D. All other things are very typical points regarding the aerodigestive foreign bodies. And this is again a classical question, clinical question. A 2-year-old child presented to emergency with respiratory difficulty. On chest X-ray, right side shows hyperinflation of the lung with the left side normal. Which of the following is the correct statement? A 2-year child with dyspnea. X-ray shows right side hyperinflation, emphysematous lung. Which of the following is correct statement? Decreased air entry on the side of hyperinflation is suggestive of foreign body. Removal by flexible bronchoscopy is a treatment of choice. Complete obstruction of bronchus can cause hyperinflation of lung due to ball valve effect, pneumothorax. The answer is A, very classical. So if the patient is having hyperinflation and if you find a decreased air entry on that side itself, it is very, very classically foreign body bronchus. That should be ruled out. So removal by flexible is not ideal. Rigid bronchoscopy is the ideal treatment for foreign body removal. Flexible is for diagnostic purpose. Complete obstruction will not cause this hyperinflation. Partial obstruction will cause the hyperinflation. I tell you what, how. And it is not pneumothorax, of course. So bronchial foreign bodies is common less than 3 years. Right bronchus is common, straight, stout, short, because that's why right bronchus is more common for the foreign body bronchus. And the classical triad of presentation is they will be present with cough, of course, foreign body, dyspnea, and diminished air entry on one side because the foreign body lodges commonly in the one side bronchus. Of course, diminished air entry on the one side. On taking the chest X-ray in suspicious babies, see this. Due to the partial obstruction of the foreign bodies, which is a quite common scenario, during inspiration, the air will enter all around the foreign body to enter into the lungs. But during expiration, bronchoconstriction happens. The entered air cannot exit out of the lungs. It will not enter and exit out of the lungs. So it gets stasis inside the lungs and cause emphysematous lung. So the air will go inside during inspiration and it will not come out during expiration due to the partial obstruction ball valve effect. So this is why the hyperinflated lung is present on the obstruction side itself. So this is called obstructive emphysema, very important X-ray finding in bronchial foreign bodies. Please remember, the early X-ray finding is obstructive emphysema. Once there is edema, complete obstruction happens at this bronchial level. No air will enter into the lungs and collapse will happen. So collapse or atelectasis is the late stage. Obstructive emphysema is the early stage scenario in bronchial foreign body. That's all. Very important X-ray finding. Obstructive emphysema on the side of obstruction itself. Of course, the rigid bronchoscopy in boys position is the treatment of choice. The patient is placed with flexion of the neck and atlanto-occipital joint extension. This is very important. Flexion of the neck and atlanto-occipital joint extension is called Boy's position, where this oropharynx will be in line with the airway or the foot pipe. If you want to do a rigid laryngoscopy, rigid bronchoscopy or rigid esophagoscopy, this is the position. Boy's position is to be followed. And regarding few points regarding the esophageal foreign bodies, where you will be asking about the coin foreign bodies. Very simply, if the coin is placed in the esophagus, how it appears, or in the larynx, how it appears. The most common site in esophageal foreign body is cricopharynx. And if there is any obstruction in the cricopharynx, there will be pooling of saliva and pyriform fossa. It is called the Jackson sign, and the treatment is rigid esophagoscopy. And coming to this coin foreign body, only point, single point. If the coin is placed, get stuck in the cricopharynx, this is how the coin will be stuck in the cricopharynx. If you take a X-ray in this esophageal coin foreign body, in the AP view, you can see the full coin, and in the lateral view X-ray, you will see only the slit of the coin in case of esophageal coin. Very simple. So for me, esophagus is compressed anteroposterior like this, anterior and posterior wall of the esophagus. So a coin foreign body, a coin will be lodging in this way inside the esophagus. A coin will be lodging in this way. So if you take a AP view, the full coin is seen. If you take a lateral view, only the slit of the coin will be seen in the case of esophageal coin foreign body. And if a coin gets lodged in the larynx, it will be lodged in between the vocal cords like this. That is the position it will be lodging in the larynx. But please remember, laryngeal coin is very rare. But if it happens, it will lodge like this. For me, the vocal cords are aligned like this. So the coin will be lodging like this in between the two vocal cords. Now, lateral X-ray will produce a full coin and AP X-ray will be a slit of coin will be seen. So this is a difference. So like this, in a laryngeal coin, the full coin will be seen in a lateral X-ray view. So this is the difference between the esophageal and the laryngeal foreign body coin. So this is about this foreign body coin in the esophagus, and of course the treatment is a rigid esophagoscopy and removal. So there ends your ENT material and the common areas of asking. So hope you had some good understanding and good areas of revision. This is the most common areas of revision to be done in ENT. So all the very best. With this, you can answer